everyone, and a very warm welcome to the 6th Annual International Conference hosted by the Board of Genetic Counseling India. I am Ariba Khan, genetic counselor from India, currently based in Dubai. It is an absolute delight to be your host for the inauguration today. BGCI has been instrumental in inspiring many genetic counselors, including myself, and giving us opportunities to gain better insights into our field, just like this conference. All of us in the organizing team have enjoyed putting together this conference for you, and we are grateful for you to join us today. Before we start, let us have a traditional prayer and a lamp lighting.
हे गजानन तू आदिश्वर तू परमेश्वर तूच ईश्वर सकल जगाचा तारणहार तू या विश्वाचा पालनहार तू मोदक प्रिय तू मंगलदाता भक्तांची कामना पुरविता
There are a few individuals in India who have been a driving force in the field of genetics and genomics counseling. One such person is the president of the Board of Genetic Counseling India, Dr. Annie Hassan. She is a pioneer in the field of genetic counseling and a torchbearer for all of us. She is a researcher, diagnostician, and a genetic counselor. She is passionate about establishing genetic counseling as an organized, independent profession in India to help clinicians, patients, and families to utilize the knowledge available to improve healthcare. She has a message for us today. Let us have a look at what she has to say.
Hello, everyone. It's my pleasure and privilege to welcome you all on behalf of the Board of Genetic Counseling India to the International Conference on Genomics and Genetic Counseling, Value in Healthcare. It's wonderful to be here to remember the highs and lows of the 6-year journey of BGCI and to celebrate the continuous advances in our profession. Carving the path to develop genetic counseling as a profession has been hard with significant challenges along the way. But all of us involved in this know that we are in the privileged position of both promoting and witnessing its growth globally and especially in India. The immense progress, genetics and genomics, which we have witnessed in our lifetime, could not have effectively served patients, families, and communities without genetic counselors. Genetic counselors truly use science to help people in ways which was never previously thought to be possible. All the genetics knowledge in the world would remain locked up in labs, universities, and institutions if it was not communicated effectively by genetic counselors to the clinicians, diagnosticians, patients, families, policymakers, and this list goes on. Genetics, family history, medical history, and lifestyle must be synthesized and translated to drive clinical and personal decision-making, contributing immensely to present and future healthcare. The Board of Genetic Counseling India, which started with a modest membership of 7 individuals 6 years back, is committed to lead the present group of 161 genetic counselors, and we are ready to welcome others who have not joined us as yet. We are eager to invite youngsters to come under this umbrella as we continue to enhance this field. I'm so proud to be a part of this field that is involved in the challenge of diagnosing rare diseases, identifying the cause of common diseases, planning individualized treatment and management, supporting families, developing new public health programs, educating our clinical colleagues and the community in this age of technological advancement and large data. Genetic counselors, with their knowledge and skill, add great value to current day healthcare. I welcome you all on behalf of the organizing committee and on my personal behalf to this online conference to learn, interact, and enjoy the fantastic program. Thank you.
We also have a message from one of our patrons, Professor Bhanwar. Professor Bhanwar has been a professor at the Department of Human Genetics, Guru Nanak Dev University, Amritsar. His international experience includes various programs, contributions, and participations in different countries for diverse fields of study. His research interests are reflected in a wide range of publications in various national and international journals. He is a member of various societies and has served as a president of the Indian Society of Human Genetics. He is a patron of the Board of Genetic Counselling India and currently heads the Center of Advanced Research and Diagnostics, Sri Guru Ram Das Institute of Medical Sciences and Research. Please let us listen to what he has to say to us today.
The field of genetic counseling is undergoing a rapid change in our country due to the availability of precise genetic diagnosis of various genetic diseases, due to the availability of various new molecular diagnostic techniques. This will help the clinician and the genetic counselors to devise new treatment options and counseling options. The BCGI is holding its annual conference on 2nd to 4th of July, in which about 30 eminent scientists would be delivering their scholarly talks on various aspects of genetic counseling and genetic testing. This will help the clinicians, the genetic counselors, and the students of human genetics in a big way. I wish this conference a great success. Thank you.
We thank Professor Bhanwar for his kind message and his best wishes. We are lucky to have amongst us several prominent people from our field with us today. I feel very lucky to have gotten to know one of them while planning this conference, our organizing chairperson, Dr. Prochi Madan. She is a senior genetic counselor certified by the Board of Genetic Counselling and is currently honorary consultant geneticist at Jastok Hospital and Research Center in Mumbai. She started her career in human cytogenetics in 1973 and has set up various genetic labs. She has also set up the Genetics and Pre-Implantation Genetic Diagnostics Laboratory at Jastok Hospital in Mumbai in the year 1999. She was among the first to start the FISH techniques for diagnostics in India in the year of 2000. She is a recipient of the Professor I.C. Verma Lifetime Achievement Award, Young Scientist Award, and the Leti Tata Memorial Trust Scholarship. She will be speaking to us to set the theme of the conference.
Thank you, Ariba, and welcome to everybody. So we are going to have a great scientific feast on genomics and genetic counseling. We are passing through a golden phase of information and knowledge, especially in the field of genetics and genomics. The fast pace of development in technology has heralded techniques for rapid and sensitive diagnosis. This has greatly improved prognosis and management of genetic conditions. It has also helped in prevention of recurrence through prenatal or pre-implantation genetic testing. As you know, knowledge about genetics has moved on from chromosomal and Mendelian conditions to various complex conditions like cancers, reproductive issues, neurologic and cardiac anomalies. with the boom in knowledge and increase in genetic diagnostic services, the need for genetic counselors is increasing as counseling is time consuming. Genetic counselors bridge the gap between clinicians and families of patients. They understand the emotional, psychological, and social implications of genetic conditions, and they know how it should be explained to the patients in a convincing and beneficial way. So in this conference, we have attempted to emphasize the values and importance of various aspects of genetic counseling and give an update on the advances in genomics for the benefit of both budding and senior genetic counselors. Whenever I give a lecture, I like to start from the basics so that it becomes very easy to understand, because I always remember the tune from Sound of Music, Do Re Mi, which starts, let's start at the very beginning. So we have grouped an array of talks by international and national speakers in interesting sessions and panel discussions. The inaugural is followed by a workshop on Prader-Willi syndrome. On Sunday, there is a panel discussion with various stakeholders of rare disorders, representing families, advocacy groups, patients, clinical geneticists, policymakers, and others, which is open to the public. We also have an impressive array of over 100 posters with short videos submitted by the delegates. They have been judged by a panel of national and international faculty with a detailed marking system. Prize-winning posters will be declared at the valedictory. There is room for networking with faculty and fellow registrants too. Please make the most of BGCI 2021. Thank you.
Thank you, Dr. Proshi, for setting us with the theme and gearing us all for this conference. It is my privilege to introduce our chief guest, Professor I.C. Verma. Although he does not need any introduction, but for the benefit of our international delegates, participants, and faculty, I will try to say a few words about him. Professor I.C. Verma is a renowned specialist in genetic medicine. After practicing in East Africa, he acquired training in pediatrics and genetics from London. He has practiced at the All India Institute of Medical Sciences for 29 years. Over a period of time, he established himself as a professor of pediatrics and head of department of genetics over there. Later, this unit got recognition as a World Health Organization collaborating center in genetics for credible performance. Dr. Verma has been awarded various recognitions, including prestigious FRCP Fellowship, Ranbaxy Science Award, ICMR and BC Roy Medical Council Award, and many more. In the year of 2003, he made a successful entry in Limca Book of Records as a pioneer in genetics in India. To deliver his knowledge worldwide, Dr. Verma imparted training in many national and international healthcare organizations. For the past 2 decades, Dr. Verma is a member of the advisory body of the World Health Organization Committee of Genetic Disorders. He has also headed Indian Society of Human Genetics. Presently, Dr. I.C. Verma is the head of Department of Genetic Medicine at Sir Gangaram Hospital in New Delhi. His researches added valuable contribution in the field of pediatric genetics and community health in India. I would like to request our honorable chief guest, Professor I.C. Verma, to please say a few words.
Thank you. Friends, colleagues, genetic counselors, trainees, distinguished guests from India and abroad. I sincerely thank Dr. Prochi Madon, Dr. Annie Hassan, Dr. Lakshmi, and other members of the executive committee for their gracious invitation to be the chief guest at this 6th annual conference. Friends, the dazzling discoveries of medical genetics has had an outstanding impact on healthcare in recent years. for chronic disabling disorders like Duchenne muscular dystrophy, spinal muscular atrophy, for which there was no treatment for decades. Now there is amazing treatment with antisense oligonucleotides. These treatments have brought back smiles on the faces of these children. For SMA, we have gene therapy, and if you give this when the patient is very early or asymptomatic, the children will develop normally and will run and jump at 1 to 2 years, something which was unimaginable before. Gene therapy is also on the horizon for many other neurogenetic disorders. Correspondingly, the next-gen sequencing has revolutionized the field of genetic testing. It has cut short the time to diagnosis. It has given us more reproductive options and has led to more accurate genetic counseling. It has ushered in an era of precision medicine. Stephen King's ordered program of rapid genome sequencing, giving you a report in 48 hours to 72 hours, has saved the lives of many newborns and is being adopted in many countries, and I do hope that soon it will come to India. Medical genetics and genetic counseling are very closely linked together like brother and sister. Advances in one immediately drive the need for the other. Genetic counseling is a young and rewarding field in India, and as it deals with human beings and their feelings. It is one of the greatest professions in the world because it helps people understand their own problems and to lead normal lives and by adapting to those problems. The satisfied smile of a client at the end of a session is cherished by the genetic counselor for many years to come. Recognizing the importance of genetic counseling, we have started a 6-month online course in genetic counseling with 6 weeks of clinical training with an organization called Future Medicine. Many such courses are required because we are terribly short of manpower in this field. The board, which has now established its credentials on very sound footing, now should divert some of its attention to start these genetic counseling courses, especially of the longer variety, 2 years in the universities. Friends, I have gone through the scientific program and I'm very impressed with it. It is truly an international conference. I congratulate the scientific committee for preparing such an outstanding program. I know there is much to learn from this conference. I have the utmost pleasure in inaugurating this conference and wish it success that it deserves. Enjoy the conference. Thank you.
Thank you, Professor Verma, for the insightful words and for your best wishes. We are truly grateful to have you with us today. We also have amongst us Dr. Hema Purandare, who is a founder director, Center for Genetic Healthcare in Mumbai. She is a practicing geneticist with an experience of 37 years. She is eminently qualified and has been trained in all aspects of medical genetics at most advanced centers and laboratories all over the world. She has been awarded the Indian Achievers Award for Health Excellence by All India Achievers Foundation and Bharat Jyoti Award by India International Friendship Society. She has recently authored the book, Shoots and Roots, Genes Matter the Most. And we are delighted to have this book launched at this conference by our honorary chief guest, Dr. I.C. Verma.
Friends and colleagues, I have great pleasure in releasing the book written by Dr. Hema Purandare. So this book, entitled Roots and Shoots, Genes Are the Most Important, is written by my very close friend, Dr. Hema Purandare, whom I have known for many, many years. This delightful little book gives her own experiences early on when she started genetic counseling in India. And it deals with the common genetic problems that she dealt with, like Duchenne muscular dystrophy, hematological disorders, and others. The most important chapter, and the chapter I found the most interesting, was on genetic counseling. For the first time, I found she compared genetic counseling session to the discourse by Lord Krishna to Arjun. Arjun, of course, represented the patient who was nervous, and it's only the counselor when the Lord Krishna explained to him that he had the courage to fight on. Another important thing she mentions in the chapter is that the patient is not like an empty container which is to be filled with knowledge and information. So the patient has his own beliefs and his own customs and his own feelings. So the genetic counselor must always remember this, that you are dealing with a human being, his feelings, and you must counsel, and that he should absorb what you are telling him. So this book, I would recommend all genetic counselors should read it, especially the chapter on genetic counseling. Enjoy the book.
Thank you so much, Dr. Verma. We will definitely give it a read. Our co-organizing chairperson, Dr. Jaya Vyas, is also an expert in her field. She is a senior genetic consultant with 21 years of past experience in her field. She is a senior genetic counselor recognized by BGCI, and her areas of interest are in genetic and genomic aspects of inherited diseases and oncology. She is currently working at Metropolis Labs in Mumbai. Please, Dr. Jaya, could you say a few words for us today?
Thank you, Ariba, for such a kind introduction. I want to begin by extending a very warm welcome to all the faculty, the registrants, fellow colleagues, and dear friends to this grand scientific feast, both for the heart and the brain. This magnanimous conference comprises of over 2,500 registrants from 44 countries who will be enlightened by more than 80 faculty members, both national and international, from 11 other countries. But getting together this great gathering of elite faculty for enthusiastic and keen to learn young registrants and having an array of enlightening talks on genomics and genetic counseling has been made possible only because of the constant and persevering hard work of multiple teams. First and foremost, we would like to express our big heartfelt gratitude and thank you to Mr. Kamineni Suryanarayan for his constant endeavor and commitment to support genetics and genetic counseling services. It is his support that gives us the courage and confidence to go ahead and take challenges and realize our dreams. We would also like to thank our chief guest, Dr. I.C. Verma, for gracing the occasion and enlightening us with his rich experience, and Dr. Hema Purandare for giving us her book on her vast genetic counseling experience with case studies and enriching the young genetic fraternity. Next, we would like to express our big thank you to our constant pillar of support and guidance, our President, Dr. Annie Hassan, who has laid the foundation of Board of Genetic Counseling in India and is constantly striving to get more and more recognition for genetic counselors. She's been the biggest motivating and guiding force in all our endeavors. We would also like to thank our Vice President, Dr. Lakshmi, for her encouragement, guidance, and support in organizing this event. We owe a very big thank you to Dr. Prochi, the main organizing chairperson of this conference, whose constant day and night hard work and perseverance has led to the successful arrangement of this event. A heartfelt thank you goes to all the young and enthusiastic organizing committee members for their undying effort and who have not only done all the groundwork, but also given so many new ideas for this conference to ensure its success. This conference has been very ably supported by MICE, which is our partner for the virtual conference. And a big thank you goes to Mr. Rajesh, Mr. Nitesh, Mr. Kalpesh, and their entire team. We would now move on to thank those without whose support this conference would not have been possible, and that is our sponsors. We have been very generously supported by, for organizing this conference by companies like Illumina, Bionano, Agilent, Thermo Fisher, MedGenome, LifeCell, Genetico, and many others. I would like to add for all, especially registrants, that if there are any technical glitches, please feel free to contact us, that is the organizing committee and the MICE team, whose contact details have been provided on the website. Also, please do provide us your feedback on your experience at the end of the conference. Hope you all have a very great learning experience. And at the end, I would like to welcome you all again to enjoy this grand scientific feast. Thank you.
Thank you, Dr. Jaya. May I please request Dr. Hema Purandre, author of the book Shoots and Roots, Genes Matter the Most, to please say a few words.
Thank you, Dr. Verma. It's a great honor to have my book Shoots and Roots, Genes Matter the Most, released by a doyen in the field of medical genetics like you. My sincere thanks to Dr. Annie for suggesting the release of my book at such a prestigious conference. This will help it to reach the large number of delegates interested in the field of genetics. The book came out of inspiration from my friend Dr. Nalini Inamdar, professor of biochemistry, who had seen my struggle and passion to help the patients with genetic disorders. The complex subject is presented in a lucid language and will be beneficial to non-physicians as well as physicians, and to understand the subject and available advances in the management. The cover page of the book is of the eternal Ashwath tree, describing Dhaneshwari, which reads as Urdhvamulam adhashakam atra prahurvayam. Chandasi yasya parnani yastam vedasa vedavid. This means that this eternal Ashwastha tree in Srimad Bhagavad Gita has its roots above and branches below. It perpetuates the continuous cycle of life, death, and it's constantly changing. The genetic world is like huge Ashwastha tree for the soul. We inherit the traits from our ancestors and pass them on to our descendants. The variations in this legacy are only permanent aspect in this materialistic world. Hence, the metaphor of Ashwastha tree seems appropriate for this continuous transitional genetic characteristic that are transferred to generation the context. This is what, that's why that is the cover page of the book. The same book was released in Marathi in March last year, just when the lockdown began. And we got a thumping response that this information should go in English, so the new book has come. Now, of course, the cover page of the book I've said, but last but not the least, now I want to thank my content writer, Ms. Ujwala, and publisher, Granthali. Thank you all.
Thank you, Dr. Hema. We wish you all the best and success with your book. I would now like to pass on to Gayatri Iyer, who will be leading the PWS workshop. Thank you.
Hello, everyone. I, Gayatri R. Iyer, Organizing Secretary of the 6th Annual Board of Genetic Counseling India Conference and your moderator for this session, welcome everyone to our pre-conference workshop on Prader-Willi syndrome. To give you a brief introduction of PWS, it is a genetic disorder caused due to changes in paternal chromosome 15. It affects metabolism, growth, behavior, and intellectual development in an individual. If you check the literature or just Google PWS, it would say that it is a rare disorder affecting 1 in 10,000 to 1 in 30,000 people. But while doing my PhD, I realized that this is not the scenario, since I had tested a relatively small cohort of only 37 people and 11 out of them were confirmed to have PWS. So this indicates that there is lack of awareness as well as accurate statistics of this condition. I would like to share my journey with PWS in this forum today. It started back in 2014 while I was doing my genetic counseling training under the guidance of Dr. Annie Hassan. Ma'am had interacted with the then International Prader-Willi Syndrome Organization, that is the ITSO president, Dr. Susan Cassidy at the ASHG, who offered to do free testing for individuals suspected to have PWS. I was assigned a short-term project where we would outsource samples to Bird Institute Italy for MSPCR testing. MSPCR is methylation-specific polymerase chain reaction, a simple test yet not available in India at that time. Subsequently, Dr. Annie and I wrote a proposal for setting up PWS MS-PCR diagnostics to the Department of Science and Technology, India, which was awarded, and that also became one of the key components in my thesis. The Bird Institute Italy and IPSO were kind enough to share the protocol with me and helped us set up as well as standardize the technique at Kamineni Hospitals, Hyderabad. IPSO was founded in 1991. It strives hard for the betterment of the individuals as well as families with PWS. They host several webinars, seminars, conferences, as well as allocate conference and travel grants across the globe to get the interested and committed individuals connected with the experts in PWS care. Through them, I was introduced to the Indian Prader-Willi Syndrome Association, where we could refer all our diagnosed cases and families for support and guidance. In 2018, I had the opportunity to participate and present my work at the 4th Asia Pacific PWS Conference in Australia. At this conference, I learned and understood the different specialities of medical expertise a PWS child may need from infancy to adulthood. I observed how having an inclusive and sensitized society can be instrumental in promoting self-reliance and self-capability in PWS fraternity. If it is diagnosed early enough and the growth hormone as well as the behavioral therapies are practiced in a timely manner, the individuals will grow on to become adult citizens joining the workforce of the society. The Board of Genetic Counseling planned a similar workshop for India in early 2020. However, due to the pandemic and lockdown restrictions, we had to call it off. We changed our platform from in-person to the virtual mode this year, and we're grateful to be supported by the IPSO to make this into a reality. In today's workshop, we intend to provide wholesome and comprehensive information to all parents, caregivers, healthcare providers, educators, friends, and families of PWS individuals with our 7 distinguished faculty. For ease of conducting, the workshop is planned in English, but please do not hesitate to write to us if you would like any part to be explained in your regional language. The BGC has committed members from all parts of the country who can help you with the query in your preferred language. I welcome all participants, faculty, delegates, and hope all of us benefit and understand PWS a little more closely with today's workshop. I request all participants to type in their questions as and when you get them in the chat box, and they shall be answered either during the question and answer session, after the respective talks, or taken in the end for panel discussion. With this, I come to our first speaker, Dr. Sanjeeva Jian. Dr. Sanjeeva Jian is an associate professor at the Department of Pediatrics. He is also in charge of genetic clinic at Indira Gandhi Institute of Child Health, Bangalore. Sir is also a nodal officer at the Center of Excellence for Rare Diseases, IGICH, Center for Human Genetics, Bangalore. Sir has a diploma in child health. He is a DNB in pediatrics and also has fellowship in clinical genetics. He has special interest in pediatric HIV and pediatric genetics. Sir has about 80 national and international publications and has received 5 research grants in the last 3 years from reputed institutes like ICMR, DBT, BIRAC, RGUHS, etc. Over to you, sir. I kindly request you to give the introductory remarks and begin today's workshop. Thank you. Sir, you are on mute.
Yeah, good afternoon, everybody. I would like to thank the organizer for giving me this opportunity to share some of the thoughts on this very important syndrome, Prader-Willi syndrome. And it's a very important workshop on Prader-Willi syndrome. It is a syndrome which is most of the time for a pediatrician, they are not very well aware of this. Even for a genetic counselor, the counseling is a challenge here. So it's a very important workshop. So we all know the prevalence of Prader-Willi syndrome is somewhere around 1 in 15,000 live births. And in India, with an estimated 27 million births per year, we expect around 1,800 children with PWS born in India each year. Because of very poor awareness among general pediatricians and common people, most of the time this is undiagnosed, and they are by the time they reach the diagnosis, it will take a lot of time. So this syndrome was initially described in 1956 by a group of Swiss doctors. And the major problem emerged in this condition is from insatiable appetite, which ultimately results in obesity and secondary complications of obesity like diabetes and hypertension and other things. And sleep apnea, obstructive sleep apnea, and many children succumb to this problem if it's not been identified and treated properly. Now, this Prader-Willi syndrome is a most common genetically inherited childhood obesity syndrome. So there are now obesity, though the exogenous obesity is common, but when we talk about the genetic cause for obesity, Prader-Willi is at the top. And it's a most common example for an imprinted disorder. What do you mean by imprinting? Usually what happens in Prader-Willi syndrome is there is absence of expression of paternally active genes in Prader-Willi syndrome critical region, which is on chromosome number, long arm of chromosome number 15. So we have two copies, one from mother and one from father. And so in Prader-Willi syndrome, the paternal copy is lost, especially this Prader-Willi syndrome critical region. So it may be due to paternal deletion of the paternal copy, which accounts for 65 to 75% of the time, or it may be due to disomy, in the sense that both the copies are from the mother, or there may be a point mutation in the imprinting center, which is an inheritable disorder. So these are some of the pictures of our children, which we have seen in our clinic. So these are children with different ages, and you can see the typical face, obesity, almond-shaped eyes, thin upper lip, and tapering fingers, short, stubby, tapering fingers, hypogonadism. Some of them doesn't look obese because it's not yet started, it was young age. As they grow older, they start developing obesity, moribund obesity, and it's very difficult to control that obesity. And in fact, this child was around 12-year-old who had very severe respiratory distress, and we could not able to revive this child, and he died at home with obstructive sleep apnea. So we published a paper in 2017, which was a case series on Prader-Willi syndrome, which included 34 molecularly confirmed cases. 23 among them, 23 were male. The age group was somewhere between 1 to 24 years. The youngest was 1-year-old child, and the oldest was a 24-year-old. The median age was 8 years. And all of them had low weight as one of the key feature. The birth weight ranged from 1.5 to 2.8 kgs. And the onset of obesity was somewhere between 1 to 6 years with hyperphagia. And obesity was seen in almost 97% of these cases. In 3% of them, it was still yet to be noticed. Neonatal hypotonia was seen in majority of them with feeding difficulties. And this feeding difficulty improved by around 9 to 10 months. And bilateral undescended testes was seen in 87% of the males. The major neurodevelopmental profile in these children, what we found was 94% of them had initial hypotonia and motor delay as a consequence of that. Behavioral problem accounting for like predominantly hyperphagia and temper tantrum in 87% of the cases. They had a very high threshold for pain, and skin picking was very commonly seen in these children. 2/3 of them had this. Sleep disorders were also seen. In fact, one of our colleague, respiratory colleague, has recently published a paper on sleep disorder and sleep studies in these children. He evaluated around 20 children with Prader-Willi syndrome for sleep disorders, and he found a very significant number of children having sleep disorders. And seizures were seen in 40% of them. They were like most of the time febrile seizures, not much of a problem one. Vision abnormalities like strabismus and refractive error was seen in 40%. Overall, learning and development is influenced by this vision abnormality, untreated hypoglycemia, hypothyroidism, and behavioral problem. So these problems used to complicate their learning, and they deteriorate the development further. So molecular testing is a multi-tier. I think the next speaker is going to speak on this. I'm just going to touch a little bit on this. It's a multi-tier algorithm where initially you do a methylation study. If that is normal, then it's PWS unlikely. If it is abnormal, then we know this is PWS, but we don't know what is the real underlying mechanism. So then we need to do the next level testing. The first is FISH. You do FISH for this PWS region. That is SNRPN probe. And this, because nearly 2/3 of these children will have deletion of the paternal copy. So the FISH will identify this. And if FISH is negative, then we need to do the microsite analysis to look at maternal uniparental disomy. And if that is also, if there is a biparental inheritance, then we need to look for imprinting center analysis by sequencing or to look for deletion or mutation in that particular region. So this is a multi-tier system technique. So we can do in a stepwise manner when you suspect a Prader-Willi syndrome. When it comes to management, since the problem is in the multiple domain, so you need a team to evaluate and manage these children. So this multidisciplinary team includes a genetist at the core. You need a pediatrician, you need a dietist, you need a endocrinologist involved in this. You need neurodevelopmental experts or developmental people to handle, to manage these children. So the core to this whole management is dietary management. So if you can able to prevent the obesity, you can prevent majority of the comorbidities in these children. So diet management is very important, and management of behavioral disorder, especially this food-seeking behavior, temper tantrum. So all these needs to be managed. I think the next speaker is the expert in this, and he's going to throw a lot of light on these problems. And growth hormone therapy has really promising effect, especially when you start very early. It has got a whole remodeling effect on the system. So you have to start very as early as possible. I think there is an endocrinologist also in the panel who is going to speak on this. There are some newer therapeutics which are being tried. One is levolitide, which was started as a phase 2 trial, and unfortunately, it was not really picked up. It was one of the agonists of ghrelin, which is an appetite suppressor, and it was withdrawn because the results were not optimal as was expected. And the next was a combination of tisofensin and metoprolol. Basically, this is This blocks, disophinin blocks the monoamine oxidase reuptake, so that it will increase the concentration of these monoamines like your serotonin, noradrenaline, and dopamine. So this again will decrease the food craving and appetite, and it will alter the metabolic or it will increase the metabolic fat burn. So this is in the phase 2 trial. Because to mitigate the side effects, though, it's been combined with a beta-2 blocker, specific beta-2 blocker. And another drug which is been tried is GABA modulating drug called acamprostate. So this is also because basically this works on controlling the temper tantrum, because there is an imbalance between inhibitory and excitatory neurotransmitters in the brain. So this drug will modulate that, and it will try to help in temper tantrum. These are experimental therapies that are going around the world. We hope that in near future we'll have some therapy for these children. With this, I would like to end my introduction. Thank you very much. And I also wish a very interesting workshop to follow. It will be an academic feast to all the participants in this workshop. I wish all the best for the workshop. Thank you.
Thank you, Dr. Sanjeeva. That was a very wonderful introduction to get us started on the workshop. Can I please request you to introduce our keynote speaker, Professor Tony Holland?
Yeah, it's my really honor to introduce Professor Holland, who is our keynote speaker for today's workshop. Currently, he is a president of International Prader-Willi Syndrome Organization. He is also Professor Emeritus in Department of Psychiatry at University of Cambridge. He is Health Foundation Chair in Learning Disability, and he is instrumental in establishing the Cambridge Intellectual and Developmental Disability Research Group in 2002. And he has published research extensively in academic and practice-based journals. His interests are in eating, behavioral, and mental health problems, which are very commonly seen in Prader-Willi syndrome. And his career highlights include he is elected as a fellow of UK Academy of Medical Sciences in 2010, and he was awarded a CBE in Queen's Birthday Honours for services to psychiatry in 2015. I welcome you, sir, for this workshop, and we are really looking forward for your enlightening keynote address today, sir. Over to you, sir.
Thank you very much. It's a real pleasure and honor to be part of this meeting. And I'm really delighted that the International Prader-Willi Syndrome Organization has been able to work with you to help organize this workshop. As the previous speakers have said, Prader-Willi syndrome is an important and now recognized genetic cause of obesity. And I think one of the key aspects of Prader-Willi syndrome is that if you understand the syndrome, even though there may not be very many treatments at present, you can do an enormous amount to improve the lives of people with the syndrome and also help their families. So what I would like to do during this keynote talk is really to give you an overview of Prader-Willi syndrome. As Dr. Sanjeeva has said, my background is as a psychiatrist, so inevitably I'll have a particular focus on some of the behavioral and psychiatric aspects of the syndrome. But if there's one key message about Prader-Willi syndrome, it is that it involves the skills of many different disciplines across medicine, of which genetics and endocrinology are obviously the most key, particularly early in life. But it also involves the skills of physiotherapists, speech and language therapists, dietitians, orthopedic surgeons, and so on. So it's really a syndrome that requires expertise across many different disciplines. As you've heard already, it was first described by Professor Prader together with Labert and Willi in 1956. So in my talk, what I really want to do is to say something about the characteristics at birth and touch briefly on the genetics, as that has already been explained. Look at how the phenotype changes over the lifetime and some of the particular physical and mental health risks that occur over the person's lifetime. And then end really by reflecting a bit on the importance of services and support, and particularly the importance of the care environment, the family environment, or whatever the environment is that the person with Prader-Willi syndrome is living in. Because without major treatments at present, much of the positive aspects of supporting people with Prader-Willi syndrome is about the quality of care. And that's really a key message. So you've already heard really that Prader-Willi syndrome is a genetically determined neurodevelopmental syndrome. It's lifelong, it affects many systems of the body, and it affects cognition and physical and mental health. In our own study, we estimated a birth incidence in the UK of about 1 in 29,000 live births. It's clearly established that there's an increased rates of morbidity and mortality, much of which is obesity related, and I'll return to this later in the talk. It's clear also that early diagnosis is very important, and the family having knowledge and an understanding of the syndrome is critical, particularly in those early months and years of life. It's also clear, as I mentioned, that outcomes can be improved by optimal support and treatment. And this will be really a theme that goes throughout my talk. So just to say that really, ideally, Prader-Willi syndrome should be recognized very early in life. And one can expect, I think, that it should be recognized within days of the child's birth. Pediatricians and obstetricians and others should be alerted to the possibility that the child has Prader-Willi syndrome, largely because of this extreme hypertonia that is present at birth, this associated failure to thrive, and often the need for additional help with feeding, the sexual immaturity that in boys is most obvious because of undescended testes, and then the later emergence of developmental delay, and this switch from undereating to overeating that is so characteristic. And I will address these particular issues during the course of my talk. Now, you've heard about the genetics, so I won't go through this in detail, but largely about the major cause being deletion on the chromosome 15 of paternal origin. And then the other cause, which probably accounts for about a quarter of cases of people with Prader-Willi syndrome, is the presence of a maternal disomy. And then very rarely, the imprinting center defect. The reason that actually knowing the different types of Prader-Willi syndrome has become increasingly important is that we do have some evidence now that although obviously they all share in common the core features of Prader-Willi syndrome, there are important differences in some aspects of the phenotype, particularly in terms of cognitive profile, but also in terms of mental health. And I'll return to that issue during the course of my talk. One of the really areas of great interest particularly in genetic aspects of Prader-Willi syndrome has been to try and identify what are some of the key genes, the genes that by definition have to be maternally imprinted and only expressed when inherited from the paternal chromosome. And there's also been debate as to whether we should think of Prader-Willi syndrome as a contiguous genes syndrome in which the absence of expression of more than one maternally imprinted gene leads to the phenotype, or how much of the phenotype of Prader-Willi syndrome could be accounted for by the absence of expression of a single gene, and SNORD116 has been the gene of greatest interest. There's also, of course, these genes here, particularly UBE3A, which have the opposite imprinting pattern. And if that gene is not expressed, you get a very different syndrome called Angelman syndrome. And I won't say anything more about that, but it's been part of really understanding Angelman syndrome has been part of trying to disentangle some of the key aspects of Prader-Willi syndrome. I'm sorry, my video seems to be playing up a bit. So if I can just continue, I'm sure you can hear me all right. I have had some problems with
issue,
the camera.
You can continue.
I can continue. Okay, thank you. So if we now reflect a bit on Prader-Willi syndrome across the lifespan, in fact, it may be suspected in pregnancy, and particularly if you have a mother in which this is not her first child. So she has some experience of the amount of fetal movement, for example, that you would expect. Then the parents or the mother can raise concerns because she feels that the baby is not moving sufficiently and so on. Also, what we know is that there is an increased rate of problems at the time of delivery, often leading to increased amount of cesarean section, and as well as an increased rate of either premature or post-mature births. The birth weight is typically low or low normal. And then, as I mentioned earlier, you have these very characteristic features of this extreme floppiness or hypertonia at birth and failure to thrive. So that's really the key, a very early feature that should lead to concern and lead to the potential of Prader-Willi syndrome being considered. But what the key feature that really ultimately leads to early concern is shown in this slide, and this is taken from some early work that we did in collaboration with pediatricians. Here, what this shows in a group of people with Prader-Willi syndrome is the relationship between the weight and height percentiles. So early on in life, the children were low weight for their length, for their height. But as they develop in time, so here's 6 months, then you begin to see a change. So you begin to see, if the diet isn't properly managed, an increase in weight for their height. Now, this actually is relatively mild here. If you had looked at this type of graph some years before, I think you would have seen a much bigger increase. And the reason that it's milder, this switch from being low in weight to being high in weight, is that because the diagnosis is being made and the family are being advised about how to manage the feeding of the child and the risk of this switch from undereating to overeating. And this has been looked at by various people now, and I think is beginning to be understood, although we still don't know the mechanism that results in the development of hyperphagia. In this study done in the UK, it was indicated that really the weight remains stable until about 15 months. And it's over this period, it remains relatively stable. But after that, you begin to see marked increases in eating behavior. So if you ask the family about it, they're beginning to say that their baby is now wishing and would eat more and more food if they allowed the infant to do so. And that's when, of course, obesity can occur if the family are not aware that they need to limit the amount of food. And that's where really a good dietetic advice is required. Jennifer Miller and colleagues in the States have looked at this again in detail, and they've identified different phases, from this in utero phase that I mentioned, to this underweight phase, to a phase when they begin to increase in weight, although it's not obvious that they're overeating, to eventually the development of hyperphagia. And then much later in life, there's been some suggestion, in the 40s and older, that the drive to eat may diminish, although I think there is really dispute about that. By and large, I think we should think of this hyperphagia as being a risk that once it develops in early childhood, it is present for the rest of life. So these early interventions will be familiar to many of you, but some may require really rather intense neonatal care. Some all will require some level of augmented feeding, which may mean tube feeding. But it's clearly, as I mentioned, important to establish the diagnosis at this point, so that you really can perhaps prevent severe obesity developing. Because of the floppiness and the difficulty feeding, physiotherapy and dietary advice may be really critical at this phase. Important that the family is aware of the issues, and at some point early in life, in that first year, growth hormone supplementation will be started. So the early involvement of pediatric endocrinologists is important. And I've listed here some links to resources on the IPSWO website that people can turn to for more detailed advice on these matters. So then I want to then move forward. We've discussed infancy and the feeding difficulties, the gastroesophageal reflux may occur, problems of hip dysplasia, strabismus, and then the emergence of evidence of developmental delay. To this period in early childhood where you will see the increase in appetite and weight in this transition to hyperphagia. You may also notice some of the more characteristic features in terms of the facial appearance, small hands and feet, and so on. And then in later childhood, if access to food and if food is not carefully managed, you'll see a serious development of obesity. And this can be extremely serious early in childhood. The problems of sleep apnea and perhaps abnormal breathing pattern. There may be gastrointestinal problems. Particularly as they start school, there will be evidence of intellectual disabilities, and some of the behavioral and emotional problems may emerge, which I'll touch on in a while, such as skin picking, repetitive and ritualistic behaviors, and emotional outbursts. And then in adolescence, in the absence of dietary control, again, obesity will be a problem, delayed puberty. And you may see here the development and the problems of scoliosis being noticed, and I'll again just briefly touch on that. Again, the intellectual disabilities and social impairments. And some people with Prader-Willi syndrome will actually meet criteria for autism spectrum disorder. In early adulthood, you can see problems again emerge. There's the transition to education, and if in school, for example, access to food can't be managed, then you may see the emergence of this hyperphagia and this risk of obesity. So food security remains important, and food security in all environments really is important. There's the emergence of additional physical problems like the risk of diabetes mellitus, as well as things like sleep apnea. There's the problems of low bone mineral density because of the hormone deficiencies. And you may begin to see the emergence of mental ill health, which can include the development of psychotic illness, particularly in those people with the maternal uniparental form of Prader-Willi syndrome. And then in later adult life, there's the ongoing physical and mental health needs and the need for continuing support. So what I'd like to do now is to focus on some specific aspects of Prader-Willi syndrome, and in a way, really take you a little bit on both a clinical and a research journey here, because although there aren't specific treatments for some of these problems at present, I think our understanding has developed massively around these problems. And I think we know what needs to be done in order to prevent the consequences, for example, of obesity. Now, on this slide, what I have here is the weight chart of the first patient I ever saw with Prader-Willi syndrome when I was a trainee psychiatrist at the Maudsley Hospital in London. And in 1980, I was asked to see a person with Prader-Willi syndrome who was at that time 18 years of age. Now, I have to admit, I hadn't heard of Prader-Willi syndrome then. And the story, well, I actually saw her in the 1981, and the story was that she had been living at home with her family. And since moving away from home into a hostel for people with intellectual disabilities, she had started putting on weight. And you can see how rapidly she put on weight throughout 1981. And when I met with her and her parents and asked about this, what a parent said to me is that we said to the staff at the hostel that if you don't control her access to food, if necessary, locking the cupboards and locking the kitchen door, she will eat and she will continue to eat and she will put on weight. At home, we locked the kitchen door, we controlled access to food. Of course, the problem in the hostel was that it was shared by many other people, and it just wasn't right that you locked the kitchen and denied other people access to the kitchen, simply because there was one person with Prader-Willi syndrome living there. And I was involved, along with Janet Treasure and other colleagues at the Institute of Psychiatry, in a study of Prader-Willi syndrome, in which we brought a number of people into the hospital and we gave them free access to sandwiches for an hour. And this shows the rate of eating of a control group and the rate of eating of people with Prader-Willi syndrome. And on average, they ate 3 times more calories in that hour than the control group. Interestingly, of course, there were a small number whose eating wasn't as severe. Although I know this person very well, and she has gone on to be extremely obese when there were no controls on her access to food. And this really led us and others to this idea that what is happening in people with Prader-Willi syndrome is, when the hyperphagia develops, then they do not develop the mechanisms that really bring about satiety. So, and again, we went on to show this, they don't lose feelings of hunger and develop feelings of fullness that you and I would experience when we eat a meal. And although they do shift and they do develop some sense of fullness and loss of hunger, it requires many, many more calories to do that. And there have been studies since then that have gone on to use brain imaging and have really essentially demonstrated that those areas of the brain that are activated when you eat and which become activated when you're beginning to feel full are not activated in the brains of people with Prader-Willi syndrome. So the point about this type of work, and I think this was important at the time it was done, is that people were still thinking of, if only people with Prader-Willi syndrome could try hard enough, they would be able to control their overeating, control their hyperphagia. But what these neuroimaging studies showed is that really this wasn't possible for them, that there was a biologically determined abnormality of the satiety cascade. It wasn't that the system wasn't there, but it was very insensitive. And this helps to explain why, for some people with Prader-Willi syndrome, they seem to have more control over eating than others. It's not something that everyone with Prader-Willi syndrome just cannot do, but it's clear that all people with Prader-Willi syndrome have some level of problem in terms of controlling their eating behavior when they have access to food. And therefore, if others don't manage it on their behalf, severe obesity develops. So I think one of the sort of more general and interesting developments in the whole field of obesity, and this is from the work of Professor O'Reilly and Dr. Faruqi here in Cambridge, around other causes, genetic causes of obesity, many rare genetic causes of obesity, is that I think we've seen a shift in obesity researchers thinking about obesity, from not really thinking of it as a metabolic syndrome, but as seeing it as what here they describe as a neurobehavioral disease. It's really about the way the brain regulates this balance between energy requirement and energy intake. So, and Prader-Willi syndrome really illustrates that in a very powerful way. So really, in terms of people with Prader-Willi syndrome, it's really a managing the diet through supervising access to food. And the phrase that's used time and time again is the importance of food security. That may amount to locking cupboards, but it may just amount to supervision, depending upon the level that the behavior of that particular individual with Prader-Willi syndrome. But of course, weight has an other side to it. It's also as well as about having exercise as part of the daily routine and the importance of routine weight monitoring, because daily calorie requirement in people with Prader-Willi syndrome is reduced compared to people without Prader-Willi syndrome. And part of this is because they tend to have a much higher fat mass than lean body mass compared to the rest of us. There are, and you've heard about this already, potential future treatments for the hyperphagia, but as yet there are no treatments that are actually approved and have been shown to be truly effective. One of them I've put here, benuronimab, looked to be effective, but sadly the trial had to stop because of side effects, and 2 people in the trial died because of pulmonary emboli. So it's important to state, I think, that failure to manage the food environment in the support of people with Prader-Willi syndrome will almost certainly lead to a high level of obesity, and that obesity will be life-threatening. And then with it, of course, you get obesity-related morbidity, such as diabetes and sleep apnea. You get decreased mobility, and you certainly get a poor quality of life. And this is just a study some years ago in Australia, and there they had a database of people with many different genetic neurodevelopmental disorders, including Prader-Willi syndrome, and they followed them up over time. And I think a very striking feature of the 46 people with Prader-Willi syndrome, they had been admitted to hospital over 328 times, a mean time of seven times, I think it was a year. And these for respiratory disorders, also dental care. People with Prader-Willi syndrome have abnormal saliva, and they can have severe dental problems. But musculoskeletal problems, cellulitis for extreme swelling and edema of the legs, for example, but also because of skin picking, and also admission because of severe psychiatric problems. Some of these can be prevented by managing the food environment. And just to say that the respiratory disorders, some of them due to choking, for example, and aspiration, is not necessarily obesity related, but more hyperphagia related. So someone with Prader-Willi syndrome seeks out food and tries to eat too much too quickly and chokes as a result of it. But much of it is because of obesity. So again, here's a study that shows the types of problems that occur. And here, interestingly, diabetes wasn't seen, this was in the UK, in children because their weight was being managed. But type 2 diabetes we're beginning to see in adults because with more independence, they were becoming more obese. Again, respiratory problems, scoliosis, and problems because of low bone density. Here, this is X-rays given to me by Dr. Van Bosse in the United States, who's really an orthopedic surgeon who I know works very closely with the Indian Pediatric Orthopedics Association. But this is a child with Prader-Willi syndrome at age 2.5 years, and you can see the extreme scoliosis. They tried to manage it through braces and so on, but it got worse. And then at age 7, they had surgery and the rods were implanted. And the scoliosis is likely to be due to the fact of the hypertonia and the fact that you don't have the normal muscle development that is bracing the back during growth. Here is just some data to show the level of sleeping problems, particularly sleep apnea that can be both central and peripheral in origin. I now want to turn to the area that is perhaps my area of expertise, and that's, if you like, the neuropsychiatric or behavioral phenotype of Prader-Willi syndrome. And it's already been suggested, some of the behavioral problems are the things that give the families really the greatest difficulties. To some extent, we know about the use of growth hormone, that means that children will grow to a normal height, it improves body mass and so muscle mass and so on. We know about monitoring for orthopedic problems. We know about managing and preventing obesity. But the temper outbursts particularly, but the skin picking and the mental illness is a big problem. And these are just some rates of these problems that have been observed in a cohort study of Prader-Willi syndrome. In addition, the mean IQ of people with Prader-Willi syndrome falls around 60. There are some differences depending upon whether you have the deletion or the UPD subtype in terms of verbal performance profile. And in addition, and this can be important, people with Prader-Willi syndrome have specific impairments in what's known as executive functioning. This is the ability to plan, having a sense of time, and in your working memory that can lead to really quite significant problems particularly in adulthood, in terms of being able to organize and plan their life. Again, another reason for why they need ongoing support, not only in childhood, but into and through adult life. So we've discussed already the hyperphagia and the overeating, but look at some of the other problems. Now, there isn't time to go into these into great detail. So really what I've got here is some sort of summary slides that will help you think about these problems. So I think temper outbursts and ritualistic behavior and repetitive behaviors are in many ways rather similar to the types of problems that you see that are normal as part of early development. The young child that asks questions, why type questions, but also this, what is often referred to as the terrible twos, the outbursts that you see in young children, the inability to control their emotions in response to being thwarted in some wish or whatever. And it may well be that impaired atypical development is part of the reason why the propensity to these problems continue throughout childhood and in many children with Prader-Willi syndrome into adult life. It also may be that these two things are related, the temper outburst and ritualistic behaviors, and I'll come back to that. And this is partly because one of the cognitive impairments that is observed in people with Prader-Willi syndrome is this idea of being able to switch attention. So if they're focused on one task, we all know that life places demands on us and we may have to suddenly switch to deal with something else. And that's a big problem for people with Prader-Willi syndrome. So unexpected change is something they find very difficult. And sometimes repetitive questioning may be in response to the sort of anxiety that comes with uncertainty and with change. Also, it's clear that they have problems with emotional regulation. And this has really been shown with two very small studies using vagus nerve stimulation that have shown marked improvement in temper outbursts. And so we therefore think that there's impairment of the autonomic nervous system and particularly the parasympathetic nervous system. Interventions around these problems are really of a more psychological nature, looking at what triggers these behaviors and what maintains them over time, something in psychology is referred to as functional analysis. There are now programs and studies going on looking at, can you train children with Prader-Willi syndrome in childhood to better manage the switch from one task to another when unexpected change happens? Treatment of comorbid psychopathology, such as a mood disorder, is important. And I mentioned these early trials in vagus nerve stimulation. And this is a sort of schema that helps you think about temper outbursts. So you have the genetics that leads to atypical brain development, a deficit in attention switching, some unexpected change happens, you have physiological arousal, and this leads to the person trying to manage it, asking questions about you or saying things like, you promised me this would happen, you said this, you said that, and eventually losing control. And these temper outbursts often have a very particular pattern to them of being triggered by something, building up and up and up. The person loses control. And then eventually, of course, it begins to settle. But it can be very problematic during the course of the temper. Another area that is a big issue is self-injury. What we know about self-injury in people with Prader-Willi syndrome is it's most commonly skin picking, and usually picking where there is an existing skin, a bite or a scar of some sort, often on the face, the chest, or the limbs. And it can be very serious. It can lead to infection, and it certainly can lead to scars developing that just don't heal because the person is continuing to pick. What we do know, I think, is that there are some predisposing factors to skin picking. It may be mood related. So if his mood is low, this can increase the likelihood of skin picking. It may be considered at times to be part of the sort of repetitive behaviors to become a habit, if you like. One of the factors that may be important is that people with Prader-Willi syndrome have a high pain threshold. So it may be that the negative feedback that you and I would feel if we were picking our skin, the pain that we would feel, isn't present in people with Prader-Willi syndrome, and therefore doesn't help to stop the behavior. We also know that skin picking is much more common in circumstances where people with Prader-Willi syndrome have no one with them and there's no activities. So part of managing skin picking is to ensure the environment is right. And there has been some studies using, in this case, N-acetylcysteine, which has been shown in an open trial to reduce skin picking behavior. But I think it's fair to say that at present, we're still uncertain as to the underlying reasons for skin picking. But it's clear that they have a vulnerability to it for the biological reasons and for the reasons that I mentioned. But there's also environmental factors that increase the risk of skin picking. I mentioned earlier that autism spectrum disorder may be more common in people with Prader-Willi syndrome, and this was a systematic review published about 5 years ago. And here the interesting feature is that people with Prader-Willi syndrome who meet criteria for autism, about a third in those who have the UPD form, and about just under 20% in those with the deletion form. And there's been another study shows that the types of repetitive and ritualistic behaviors you see in people with Prader-Willi syndrome are fairly similar, not identical to what you see in people with autism. So I think the point about this slide is that some strategies that have been developed for supporting people with Prader-Willi syndrome, such as educational strategies, may also be relevant and inform the management and support and education of people with Prader-Willi syndrome. Now, I want to turn to something rather different for the moment. And I mentioned earlier that people with Prader-Willi syndrome, particularly I think with the UPD form, have a high risk of psychotic illness. And I'll give you some data on that in a moment. But just to illustrate the form this might take, this is just a summary of someone I saw a few months ago who was 18 at the time. He had a UPD form of Prader-Willi syndrome. And literally over hours, there was a marked deterioration in his mental state. He was living at a group home that was specifically for people with Prader-Willi syndrome. And very quickly he became confused. And the best word to describe it really was bewildered. He was very, very anxious. And for someone who was perfectly able previously to talk coherently, he appeared unable to talk coherently. He was referring to blackmail and a number of other things. And he was taken to the accident and emergency department, where the casualty doctors thought he had a confusional state due to some underlying infection and gave antibiotics. And they thought he improved, but he really didn't. But they noticed at the time that he was using unusual and unrelated words, that he was grabbing things, hitting staff, saying strange things. And on one instance, he was crawling on his, sorry, that should be knees, not news, chasing a butterfly that was not there. Because he improved after some antibiotics, he was discharged, but he returned very quickly because the same problems returned. And he was seen by the liaison psychiatrist and diagnosed as having an atypical psychotic illness and started on medication aripiprazole and improved. And although he's had two minor relapses, in general, his mental state returned to normal and he's been doing well. This was a study we did some years ago that looked at the rates of psychotic illness in people with UPD and deletion. And you can see here that it was about 60% in those with the UPD form. Now, I think it's very, very important, particularly if there are families listening to this talk, and particularly if those families have children with UPD, to emphasize here that psychotic illness is a treatable illness. The problem was that in people with Prader-Willi syndrome, it really was not being recognized. But once you recognize it, then the right treatments can be started. And I think the real main message here is that if in someone with Prader-Willi syndrome, particularly if they have the UPD, but it also occurs in those with the deletion form if you see a deterioration in behavior and the onset of new bizarre behavior and abnormal mental experiences, then you should consider the possibility of psychotic illness and perhaps get psychiatric advice at that point. And medication, among other things, can be very useful. And here's some further guidance that's on the IPSWO website. So what I want to do now, towards the end of my talk, is really to bring this all together a little bit, if you like. And in a sense, I think the point about this is that the needs of people with Prader-Willi syndrome from the time they are born and first recognized evolve and change. And as I mentioned at the beginning, they will involve the skills of many different health professionals. And therefore, multidisciplinary care really is important here. So they may be alert to some concerns because of reduced fetal movements and complex delivery. There may be the need for neonatal intensive care because of failure to thrive. There's the critical importance of genetics, and then of pediatric endocrinology and starting growth hormone and also sex hormone replacement. And there's been less attention on sex hormone replacement, but these two are both deficient because of the hypothalamic disorder that is central to Prader-Willi syndrome. It's been critically important to have the expertise of physiotherapy, OT, speech and language therapy, and dietetics. If you think about the baby with Prader-Willi syndrome, they're not moving because of their hypertonia. And movement is so important as part of the feedback to the brain to help brain development. So you need exercise, families need to know what to do, and so on. There's the issue of special education and how you support a child to learn and at the same time manage their food environment in a school setting. There may be the need for child mental health services because of the behavior, families support and respite, orthopedics because of scoliosis, expert in sleep disorders, and sometimes crisis support because of the outbursts and so on. And then I've put here, then there is the transition to adult life, exclamation mark, exclamation mark. I think in IPSWO, we haven't heard from any country that they really have mastered how you support families and support individuals in this transition to adult life. Because with adult life becomes greater independence. And with greater independence, there comes additional problems, or some of the old problems like the overeating begin to become apparent again, and things like obesity become a serious issue. Now, in the next slide, what I want to do is to sort of reflect on this a bit in terms of a model of how we are beginning to think about Prader-Willi syndrome. And I think Prader-Willi syndrome is telling us something incredibly important about the brain and about brain development. And I will argue in a moment that we don't as yet have, if you like, the complete understanding of Prader-Willi syndrome. How does everything fit together? But I think we are getting there. And I think the argument is a bit like as follows. You've got the genetics of Prader-Willi syndrome and certain particular genes that we know are maternally imprinted and paternally expressed. The Prader-Willi syndrome appears because of the presence of the genetic abnormalities that were mentioned. And that in turn leads to atypical brain development, particularly in terms of the hypothalamus and the hypothalamic links both downwards to the visceral organs, but also upwards to the cortex and to the brainstem. This network and the hypothalamus itself are abnormal, and there's post-mortem study that indicates that. But in addition, I think there are other abnormalities in terms of the cortex and more general brain development. So the argument might be, from a neuroscience point of view, you have three pathways here. You have failure of the hypothalamus developing normally and its links, which lead to impaired regulation of mood and food intake, temperature regulation, for example, and the hormone deficiencies. And you might see that people with Prader-Willi syndrome have a problem of homeostasis. And I think this concept of homeostasis is really important in Prader-Willi syndrome. But you've also got this pathway here where other abnormalities are leading to impaired cognition, and therefore the ability of people with Prader-Willi syndrome to make sense of the world and to respond to the changes of the world that are inevitable as part of day-to-day life. And then you have, particularly in people with UPD, some other process that's leading to this high risk of psychotic illness that may be more to do with genes of the opposite imprint. So these genes, which of course will be doubly expressed in people with the maternal UPD. And then you have the importance of the environment and the psychological interventions, early interventions to help people with Prader-Willi syndrome develop the cognitive and social skills to cope with life, managing the environment, for example, managing the food environment. But also we know that behaviors such as temper outbursts can also be reinforced and maintained by the way that they are managed. So how do you help families manage them properly and appropriately? How do you manage the present environment and so on? So this, I think, for me, is a useful way of conceptualizing Prader-Willi syndrome. None of us can give you the whole answer. What we hopefully can do is give you a way to think about it. So when the patient with Prader-Willi syndrome comes to you, you can think through the issues and develop strategies that are both informed by your knowledge of Prader-Willi syndrome, but are shaped and unique for that particular person with Prader-Willi syndrome. So what are the aspects of good care? Early and accurate diagnosis, the availability of information on the syndrome for families and clinicians. There is no excuse now for clinicians not knowing about Prader-Willi syndrome. No one can expect everyone to know about Prader-Willi syndrome, but now with a click of a mouse, you can find out about it. And information is on the National Prader-Willi Syndrome Association website, our website, and so on. Then access to appropriate treatments, of which growth hormone is one obvious example, but also the importance of coordinated care, planning for the future, and recognizing the specific needs of people with Prader-Willi syndrome, such as food security. And then there's about the challenge of supporting independence in adult life. The United Nations Convention on the Rights of People with Disabilities place a big emphasis on people with disabilities having the right to choice and opportunities, not only in childhood, but in adult life. So in people with Prader-Willi syndrome, there's a real tension here between balancing this issue of choice against the risks of harm. If you have choice in terms of access to food, you will develop severe obesity. There's the risks because of social naivety and because people with Prader-Willi syndrome can be tempted by food to the potential of exploitation. And there's problems that behavior can lead to, for example, in adult life contacts with the criminal justice system. So it's really important in adult life, particularly, that people are aware of changing needs and that also you have a sort of strategy of knowing what to do when problems arise. You're aware that physical illnesses can develop. You're aware that they have a high pain threshold. So, for example, a broken leg or appendicitis may not present in the same way. You're also aware, for example, that people with Prader-Willi syndrome have a lack of vomiting. So if they do vomit, that's often a very serious sign that there's some illness. So this combination of a high pain threshold and a lack of vomiting mean that physical illnesses such as appendicitis can go unrecognized until it's too late. There's also this risk of severe mental illness. And then you have the issues of how do you support people with Prader-Willi syndrome to relationships, leisure, and employment. So I think the main messages of my talk is that knowledge has advanced. I think we still miss this coherent model. There are limited treatments, but I think research is moving into this phase of investigating mechanisms and treatment trials. The biggest challenge, I think, is to put existing knowledge into practice. The central importance of the quality of support and the importance of knowledge about the syndrome are really all crucial. But I think if you can get it right, there is the potential for transforming the lives of people with Prader-Willi syndrome through knowledge and understanding, integrated care, and anticipating and preparing for the future. This is a picture from the last international conference we had, which was in Havana, Cuba. Some of the Cuban members who attended and Cuban people with Prader-Willi syndrome. And recently, Cuba was one of the countries that recently developed the skills to do the genetic testing with support from IPSWO. And they have in a way demonstrated, and this is a family with a young lad with Prader-Willi syndrome from Cuba, what is possible. And I want to end by encouraging you all to come to 11th International Prader-Willi Syndrome meeting, which is going to be held in Ireland in 2002. All being well, that we're all through this COVID pandemic. We hope it will be face-to-face. But also, and I understand in India, there are many ECHO programs, to encourage you to look at the IPSO ECHO program that we've been running for some time. And again, you can find details of this on the IPSO website. So thank you very much for listening. And thank you again for being so kind to put on this conference. And I apologize that my camera has been problematic. I will try and put it on and keep it on, but it keeps switching on and off as it is now. But thank you again.
Thank you, Professor Tony. That was a wonderful presentation, and I'm sure that our audience has got to know a lot about Prader-Willi syndrome through your keynote address. I would request you to take in few questions now from our audience. I'll be reading out to you. Are you able to see me, sir?
Yes, I can. Yes, yeah. Thank you very much.
Yes, yes, sir. The first is a message to myself. Yes, Dr. Renu Saxena, we know that it has been, Prader-Willi testing has been available in India since 2004 at your center. Sorry, I missed to put that out, that only few developed centers in the country had it before. And after 2014-15, I see many of the companies as well as labs have started it. So sorry, I missed to point out that there were few centers were offering MS-PCR and MS-MLPA before. The first question to Professor Tony, yes, this is from P. Hebziba. She's asking, when there is an hyperphagia, how does this metabolism work? If access to food is controlled, wouldn't it affect their metabolism and energy gain?
Right.
It is not out of hunger they take more food, so how it can be supported?
Yeah, I think that's a very important point. And really it highlights the importance of having good dietetic advice. And I think the thing to remember is that with people with Prader-Willi syndrome, it seems to be that the break that you and I have that stops us eating, that slows down our eating when we feel inside that we've eaten enough, is sort of absent in people with Prader-Willi syndrome. So that the skill is that, in a sense, because you and I are able, our bodies manage that ourselves. The skill is for people with Prader-Willi syndrome is to be able to do it externally, if you like. So what you're doing is you're making certain that they have an adequate diet with the right vitamins and minerals and so on. And you're doing that through dietary advice. So it's not that the meal they have must be appropriately constituted. It's just you're stopping them having too much when it would normally, you and I would have stopped anyhow. And so it's really just controlling the amount, but making certain that the food they do have is appropriate in terms of its content. Just the other point just to make is often people say to us, well, won't that make people with Prader-Willi syndrome even more hungry? And the answer, I think, is no. I think the way to think about this is that they remain still hungry. But just like any of us, if we had to starve because we were having a surgery, for example, it is actually better to be kept away from food. And what you often find with people with Prader-Willi syndrome, if they're in a food-controlled environment, their other behaviors improve because they feel safe in that environment and they know that others are responsible, firstly, for providing food, but secondly, for preventing them having too much food.
Thank you, sir. The next question is from Ishani Bose. What is the life expectancy of a person with Prader-Willi syndrome?
Again, I think this is a really, really important question because the answer to that is that it will depend very much from country to country. So, for example, we've been doing some work in Kenya and in other African countries recently, and you really find very few people with Prader-Willi syndrome. So there, our fear is that they may not be surviving early childhood because they may not have access to the neonatal care. But assuming they get through that difficult period in early childhood, then life expectancy will almost certainly depend very much on levels of obesity and on whether access to food is controlled. But if you look at the data, for example, you really don't see very many people with Prader-Willi syndrome over the age of 40. Although if you look at countries where they've got specific support for people with Prader-Willi syndrome, then you are now seeing, and I'm pleased to say, people with Prader-Willi syndrome into their 50s or even older. We've estimated a mortality rate of about 3% per year over time. But much of that, not all of it, but much of that is dependent on whether you're managing the food environment or not.
Thank you, sir. The next question is from Achint Kaur. She also has a message. Thank you for the excellent talk, Professor Holland. Is skin picking also linked to UPD, or is it equally prevalent for the relation subgroup?
It's common across both subgroups. I think the main thing that's different is the psychosis risk, but skin picking, I'm just thinking about that. I'm pretty certain it's equal across both groups, yes.
Thank you. Next question is from Dr. Sumita Danda. Is depressive illness also more common in maternal UPD cases? Which drug is more suitable?
Right. That's again, generally what it looks as if affective disorder or mood instability and affective disorder, depression, perhaps a slightly manic or high mood, is probably equal across both groups, UPD and deletion. But what you see in the UPD group is that mood quickly becomes a psychotic illness, if you like. Now, just to say that psychotic illness isn't easily categorized. It's not obviously, it's not schizophrenia in its characteristics, nor is it obviously a bipolar disorder, but we think it's a mood psychosis, an affective psychosis. So it's sometimes referred to as a cycloid psychosis. So it looks as if mood instability is common across both. The psychosis is more common in the UPD. In terms of treatment remains problematic. And I say that because, like with all people with neurodevelopmental syndromes, when you're using any drug whose action is on the brain, and of course psychiatric drugs' action is on the brain, you always have to be careful that they may be more sensitive or even less sensitive to such medication. Now, it does look as if people with Prader-Willi syndrome may be rather more sensitive to some of the traditional antidepressants. And the ones that are most commonly used are the SSRI antidepressants. But if someone has depression and it's persistent in someone with Prader-Willi syndrome, you might choose to use such an antidepressant, but you would start at a lower than normal level. And if you're going to increase, you would increase very, very carefully.
Thank you. Next question is from Shubham Agarwal. Can PWS lead or act as a stimuli for neurodegenerative disorders because of the psychotic illness?
Right. That's, again, a very interesting. I think we're beginning with, in a sense, the positive message that people with Prader-Willi syndrome are living longer. We are beginning to see in those that do live longer into their 50s and 60s some concern that there may be age-related decline and neurodegeneration. But really, no country has, in a sense, enough people with Prader-Willi syndrome in that old age group that anyone has really been able to look at that in any great detail. I think it's absolutely correct to say that Prader-Willi syndrome, if you like, provides a window onto behavioral and psychiatric problems, and it may provide a window on a whole range of problems that emerge as we see people with Prader-Willi syndrome living into later life.
Thank you, sir. The next question is from Dr. Annie Hassan. Should PWS testing be included in newborn screening, and which countries have included in their screening programs currently?
Right. I mean, I can answer that to the best of my ability. It's a little outside. I mean, you all of you are probably better than I, but I think the answer is the problem, as I would understand it, of course, is that it is rare. So let's say it's in 1 in 20,000, 1 in 30,000 births. So when the time comes that that there is the possibility of screening for many neurodevelopmental syndromes at birth, then I think you could include Prader-Willi syndrome in that. But unlike Down syndrome, where of course, that maternal age is a risk, we don't at the moment really have guidance as to what pregnancies should be screened. You might argue that if there was poor fetal movement, and by the way, the disomy form of Prader-Willi syndrome may increase with maternal age, just like Down syndrome does. So in a way, you can't at the moment really pick out the particularly at-risk pregnancies. What I do think is really important is that people have a high index of suspicion that if the child, when born, is hypotonic, and there's no obvious explanation for that, then you think very quickly, could it be Prader-Willi syndrome? So I'd be very interested in what the rest of your views are about that. But and I think this will come, by the way. This work being done in Australia, I think, about this. There will be screening for neurodevelopmental syndromes generally.
Thank you. The last question is from Mr. Parijay. Guanfacine for aggression. It is for self-injurious and self-injurious behavior in Prader-Willi syndrome. What is the duration for this clinical trial?
Sorry, for the vagus nerve stimulation, or for what? I missed the beginning of your question.
Yeah, Guanfacine, the drug trial, how long would it be? Like, do you have any early results for the aggression and behavior in PWS?
I mean, I'm not aware of trials going on at the moment for the aggression. So there are trials going on for the hyperphagia, and there will be trials for aggression. And I do believe there will come a point at which that there is an approved treatment for the hyperphagia. Just to say, for the aggression, I think people do prescribe medication for that, and I think that can be problematic because I don't think medication is usually the answer to aggression. But there has been this trial of vagus nerve stimulation that has shown benefit, but it was very small numbers, and it needs really to be repeated.
Thank you, sir. Thank you. And thank you for patiently answering all our questions. Well, I thank Professor Holland as well as Dr. Sanjeeva for chairing this session. We'll be moving on to our next workshop, that is by Ms. Farida Raj. To introduce ma'am, ma'am is a freelancer. She's a trained remedial educator, certified REBT counselor, providing psychological counseling to children, adolescents, and parents. Ma'am has authored Breaking Through, a handbook for teachers and parents of children with specific learning disabilities and understanding learning difficulties for Cambridge University Press. Ma'am has special interest in remedial education for children with SLDs and also passion for creating awareness about this hidden handicap. Her career highlights include setting up Center for Special Education, where children are assessed and provided remedial education. Ma'am has written several articles for the popular English dailies like Deccan Chronicle, New Indian Express, The Hindu, and Urdu's Daily Sea, as well as Siyasat. Over to you, ma'am. Ma'am has written several articles for the popular English dailies like Deccan Chronicle, New Indian Express. I think the workshop is also parallelly running on one of your browsers. If you could mute it down, then we can start with the session. I think the workshop is also parallelly running on one of your browsers. If you could mute it down, then we can start with the session. I think the workshop is also parallelly running on one of your browsers. If you could mute it down, then we can start with the session.
Dr. Farida?
Yes.
You can share your screen, ma'am.
Yeah, it is not showing.
Dr. Farida?
Yes.
You can share your screen, ma'am.
I know, but I am not able to see that green share screen.
There is somebody is something is open, YouTube or something. in your background. So you need to off that one. There is somebody something is open, YouTube or something in the background. So you need to off.
Okay. Begin I would like to take this opportunity to thank Board of Genetic Counseling India for giving me this opportunity to talk about a subject which is not really very well known. It is just beginning to make sense to people, and especially coming from our rural population. Specific learning disabilities is a very, very important issue, and it has to be addressed so that full support can be given to the children. As you know, India has a huge population of 1.3 crores. And out of this, 20 crore children are in the age group of 6 to 14. And these are children who get enrolled in schools, but only 14 crore continue to be in school and the rest drop out. So the dropout rate is very alarming, and that is the reason we need to address this issue and try and help children so that they can continue to be in school and make a good living for themselves. So this is specific learning disabilities. And yeah, next. So learning disability, as we talk about it, because it is a disability which does not seem obvious. There are no prostheses. The child does not wear a hearing aid. He has no other issues. He looks absolutely normal as his classmates, as his peers. And yet, when it is, you compare his classwork to his classmates, he is underperforming. And that is one reason why he drops out of school. And in this particular disability, it interferes only with learning basic skills such as reading, writing, spelling, math, and motor planning. Next. So definition of learning disability, I will not go into the details, but it says that this disability shows up in the psychological processes of learning to read, write, spell, mathematics, and movement, motor ability. And here, one thing has to be made very clear, that these are children who do not have mental retardation. They do not have any sight issues or hearing impairment. And so these are the issues which are made very clear. If the child has any psychological problem or an emotional problem, then that comes as a secondary issue. Next. So incidence and prevalence. In our country, huge country, we have 10 to 12% of our school-going children have learning disability. And out of these 10 to 12%, 4.6% are severely disabled. That is, without the help of a special educator, they will not be able to continue with their studies. And the research has shown it is boys who are more affected by it than girls, the ratio being 4:1. Next. So what are the characteristics of specific learning disabilities? It is the disorder of attention. These children may look very restless, fidgeting all the time, or may look very inattentive. So these are the areas that affect the child from learning. He also has perceptual impairment. That is, he's not able to discriminate between similarities and differences. And general coordination deficits are very, very important, because here, what the brain says to the body, what message it sends to the body is not being able to carried out in a proper manner. And his movements are restricted or very sloppy, and he's not able to carry on with his classwork and also with his fine motor and gross motor activities. Then he also has a disorder of memory. The memory is where he has difficulty with storage, or he is able to store information, but at the appropriate time, he is not able to retrieve it. So that is another area. And one area which impacts his learning of mathematics is working memory. He's not able to hold information in his working memory for even for a very short while, and he forgets, and that is how it impacts his learning. And then, of course, there are specific difficulties pertaining to reading, writing, spelling, and arithmetic. Next. So what are the causes of learning disability? Now, at the prenatal, natal, and postnatal factors, they play a very, very important role. Research has shown children who have learning disability, they were born to a parent who had tremendous difficulty during pregnancy. Maybe she was not reproductive readiness was there, and certain metabolic factors also affect, and also RH incompatibility, maternal endocrine disorder, low birth weight, and radiation and drugs during the first 2 trimester is probably the reason for a cause of learning disability. And post-birth trauma also plays a very important role. If child has a birth trauma, or he's had a head injury, or he has intracranial infections such as encephalitis and meningitis that can impair or damage the brain in a minimal way, and the child may have learning disability. Then we have the genetic factors. This also has been proved that it runs from one generation to the other. When a child's case history is taken, it comes to the fore that the child has family members who has had this particular problem. Then the biochemical factors, if the mother has had some metabolic disorders, or the child has hypoglycemia, or he has endocrine disorders, so that also will, thyroidism, hyperthyroidism is also a cause. And the psychological factors play a very important role. The child who has learning disability, he knows that he has a problem, but he doesn't know what it is. That leads to some psychological and emotional problems, and his self-esteem goes down, and he may have behavior problems. So here, the psychological factors become the secondary issue. Nutritional deficiency, very important. A child who is in his infancy, if he is deprived of good food, nutritious food, that will also lead to some kind of a change in his brain, and which will cause learning disability. And experiential deprivation. Children who are coming from low economic and society, or they are coming from a culture where these things are not taken very seriously, then they may have learning disability. A simple thing like if the child has not handled paper and pencil, and so when he comes to school, he doesn't know what he's supposed to be doing. So these are things that he's deprived of, and he's not that causes a learning disability. Next. What are the types of disabilities? So here is one slide that I would like to show you. A child, next one please. The child was shown this particular paragraph, and he was asked to read it. He had tremendous difficulty, and he said he can't read. So when the teacher asked him, why can't you read? He said, the words are dancing, the words are jumping, and I can't. So just to give you an idea, this is how the passage looked to him. Next one, Mira. He saw that the words were jumping up and down. Next. Next, please. Next one. And when he looks at the text comes into focus and then again goes out of focus. He may see blur, and so he's not able to read the passage. The next one. He has, here you will see there's a small paragraph at the bottom. Here the child has learned the technique of reading, but there is no comprehension. He reads this once upon a time as on, see, up, on, a, ti. So this is how he is reading, so there is no comprehension. So when there is a difficulty like this, It is called reading disability or disorder, and it is known as dyslexia. Next one, please. Dyslexia, it's a Greek word, and dys means difficulty and lexia is words. So difficulty with words is a reading disorder. In this slide, you will see this is a 9-year-old child who is writing. You can see the way he is writing. The letters are looking very different, very odd. And also the expression of what he's writing is not age appropriate. So this is called writing disorder, dysgraphia. Next, Dira. Here in this slide, you will see that the child has been given 3 sums to do. And in the first example, the sign is multiplication, but the child has taken it as a sign of addition and he's added the sum. And in the second one, 39 divided by 3, he has missed out on the division sign and he's taken it as a subtraction and he's given the answer, which is not correct. So this is when there is difficulty with numbers, difficulty with simple calculations. It is called dyscalculia. Next one here. Next. And in this particular slide, you will see that the way it is written, it shows that the child who has written it had not enough control on the writing tool. So if you don't hold the writing tool with a firm grip, the words that show on the paper are looking very odd. And so this is a difficulty and it is known as dyspraxia. Next one. Dyspraxia, please go back. Dyspraxia is a disability which is not very well known. Most people talk about dysgraphia, dyscalculia, and dyslexia. Dyslexia is a very common term these days. But dyspraxia, here the interconnections between the nerve cells in the cerebral cortex are reduced. So the cortex remains in a state of immaturity, and this leads to a problem where the information is not processed fast, with the result when the child is acting on a message, he seems very hesitant or reluctant, and this is what is dyspraxia, and he has difficulty with fine motor and gross motor activities. Next one. So always one needs to remember that dyslexia, that is reading, writing, number work, they don't exist in isolation. They are actually a combination of all this. A child who has attention problem will also have a problem with reading because he's not really paying attention. He has problem with reading, it will show up in his writing and spelling, number work. So there is always a combination of these. And sometimes the emotional immaturity also plays an important role. The child is not ready to learn. Next one. So I want to talk about this particular aspect of learning, slow learners and specific learning disability. Normally, children who are little slow to pick up what the teacher is saying, he is termed as a slow learner. But in actual, when we go to see in the classroom, it is the child who is, suppose he's at class 4 level, but in all subjects, he is performing at class 2 level. So he is a child who is a slow learner. So how would you differentiate him from a child who has a learning disability? A child, same child, a child who's in class 4, and he is very good with number work. That number work is, say, maybe he's doing his calculations at class 5 level. But when it comes to reading, he goes down to class 2 or class 1. And the other subjects, geography, history, and science, they remain at class 4 level. So this is a child who is showing a discrepancy, and this one is known as a child having a learning disability, whereas the other child is a slow learner. Next one. Perception. Perception is a very important area which is not really been addressed well. This is a strong perception, both visual and auditory, help the child to be successful with classroom learning. Now, it is the ability to recognize and discriminate visual and auditory stimuli. Auditory stimuli, suppose you hear a bell ringing. When this reaches the brain processes this information, and then it associates it with the previous knowledge, and it says, well, this is a bell, it's a school bell and not the church bell or the bell in the temple. But if the child has difficulty here, he will not be able to identify. The same goes with visually what he sees. If he is not able to discriminate between an apple and a pear, then he is definitely going to have difficulty when he is beginning to read. And as I said earlier, a strong perception helps the child to learn well in classroom. Next one. Here, when you see this particular slide, it shows, go back please, it shows a figure which has got 3 lines. So it is nothing to do with vision. Now vision, he takes in this image and it goes to the brain. The brain interprets it as a 3-sided figure and says it is a triangle. A 3-sided figure is a triangle because the brain is associating it with the previous knowledge, and no matter in what orientation it is, it will still remain a triangle. The next one. And here, this particular sign here, when the brain takes this information, the visual information, processes it, and the interpretation is that this is a place where you can cross the road and it is safe to cross for a pedestrian. Next one. So there are 5 visual perceptual skills that have great relevance to the learning ability of the child. The first one is visual motor coordination. Almost everything we do is governed or guided by our vision. A simple thing of like an activity like, reaching out to a book, opening the school bag and taking out the book. That movement is guided by the vision. So eye-hand coordination is very, very important. And so if he is lacking in this particular area, he will have tremendous difficulty. Next one. Another one is a very important one is figure ground. Now figure ground, we say that the child should be able to focus on what is relevant and discard all that which is irrelevant. For example, when the teacher stands up to explain something to the class, the child should be focusing on her voice. But the child has difficulty in keeping himself focused on her voice, and his attention goes to different sounds coming from different places, children playing out in the corridor or in the playground. So he misses out what the teacher is saying, and that is one. So here the teacher's voice is the figure and the rest things are in the background. Similarly, when the teacher starts writing on the blackboard, his focus should be the blackboard, which is the figure, and the rest of the things are in the background. But here the child is not able to do so. I shall show you with another example. Next one, please. This is a very, very common slide. Those who have done psychology, they have seen this number of times. When you focus on the white portion becomes the figure and the black is the background. When you focus on the white portion, it shows it is a vase. And black is the background. But when you focus on the black part of the slide, the white becomes the background and the black one, it shows up 2 faces. So here, I would like to inform you that the child who has difficulty with figure ground, we call him that he is stimulus bound because his attention is going to all stimuli and he seems very inattentive. Next one, please. Position in space, another very, very important skill, perceptual skill. Here, it is you are seeing yourself, your body in relationship to what is in front, what is behind, what is above, under. So this is, you are comparing that particular object in relationship to yourself. So next one, the children who have a problem here, when they look at the letter B becomes D, P looks like a Q, the word was becomes saw, And the numbers is again reverse. So this is the difficulty he has when he has difficulty with position in space. Next one. So it makes it difficult to read, write, spell, and do mathematics. In this particular slide, yes, please, Neera. In the slide, you will see that the child has very good fine motor control. He's drawn the figure very well. But when you look up the name he has written, there the D is reversed. And at the bottom where he has drawn a cat, the cat again is reversed. And in the next one, it shows the numbers which are reversed. So this is what happens when the child has difficulty with the position in space. It's a perceptual skill. Next one. This also becomes very clear. Now here, this is a child who is 9 years old, and he was given a very simple dictation, a dictation with 3 words, 3-word dictation. Now here, this child had auditory and visual perceptual deficit. Now when the teacher said Tom had a pot, so he had learned in phonetics that is U. So he wrote Tom had, he's put U, not A. Pot is again, the P is reversed and it looks like Q. And in the second row, it says Tom sat the pot on a box. There again, you see box is dogs and P is reversed, and the child has written Tom sat the pot. So the word the sounded to him like the sound of B, letter B, B. So he has written B. So this is the tremendous difficulty the child has in classroom learning. Next one, please. Perceptual constancy. Again, a very important skill. It shows that every object possesses an unchanging property. And this will help him to identify the geometry figures and simple things like, say, if you're standing on 8th floor and you're looking down, and in the playground, you are seeing children playing football. What the image is made on your retina is small, but it doesn't mean that the football is become smaller, is shrunk. Football has its own size, and that is constant. Next one. Spatial relationship. This is a very, very important perceptual skill. Here we are talking about the relationship of 2 objects to each other and to the child himself. For example, when the child is given a pencil and paper, he puts the pencil to the paper. So there are pencil and paper relationship between these 2. And this relationship with the person who has sat down to write. So here, if the child has a deficit in this particular skill, he will not be able to judge distances, and his writing will not be age appropriate. Next one. In this slide, if you pay little attention, you can read every word. But what has happened here, that words are getting into each other. So here, because of this particular deficit, perceptual skill deficit, he is not able to maintain proper distance when he's writing. Next one. Yeah. So when we talk about children with learning disabilities, most children come under tremendous emotional and psychological pressure, because they started thinking about themselves as no good, I'm stupid, I have no sense, and I can never do well. And this impacts their self-confidence, and they're not able to function well. So, but it has been proved time and again that these are children who have other talents. They are very imaginative and creative. They can create things, they can paint, they can become very good artists, and they are more curious than other children. I think would like to give you one example here. There was in the rural setting, there was a vendor who was selling like spectacles made of paper, and in place of glass, he had different colored papers. And this 7-year-old child was standing there and taking one paper spectacle and wearing it and replacing it with the other. Finally, he just threw away all those paper spectacles, and he looked up with his own eyes. And then he turned to his mother and he said, when I see through red paper, everything looks red. When it is blue or yellow and green, everything looks green and yellow. But when I look up at the sky, and why does it not look brown? Because my eyes are brown. So that is how curious they are, and their curiosity has to be addressed. Otherwise, if we just tell them to keep quiet, they are not going to question again. Then we have children who are good at lateral thinking. We have two types of thinking, linear and lateral. Most of us are linear thinkers. We know the use of a particular thing is for a particular activity or for thing. For example, if you show the brick to a 6-year-old child and say, what is it used for? And he's going to say, it is a brick and it is used for making houses. But a child who thinks differently, and he may turn on and say, well, if you put little flowers on it, it can also be used as a paperweight. So basically, lateral thinking is out of the box thinking. Here, I have another very interesting episode to share with you, a memory to share with you. There was a very big company which made soap, and the dealers complained to the company that some of the boxes are empty. When they open the carton, some boxes are empty. So there was a high-level meeting, and people gave the CEO and the manager, they gave their own inputs how to do it. When they came out of the meeting, there was an employee on the floor who said, sir, can I give you a suggestion? When the soap is wrapped in paper and it is put in that box, and the box comes down to fall in the carton, at that point, if you keep a fan which is at high speed, if it is empty, it will fly away. If it is not, then it will fall in the carton. So you can imagine how much money the company must have saved, and the employee must have gotten some raise in his salary. Next one. And they have superior spatial skills. We just talk about spatial skills. That is the relationship of two objects to each other and to the person himself. So here, these are children who are able to hold an object in their mind's eye, and they can rotate it. They can, in short, I can say that it is a three-dimensional aspect of it they can perceive, and they do very well when it comes to mathematics and doing geometry sums. Next one. And they can be very hardworking and motivational. So these are some frequently asked questions. So the first question is, parents always ask, is there a cure for learning disability? No, there is no cure, because learning disability is not a disease. It is not an illness that can be cured with medicines. But there are some professionals in the market who will say, well, if you take this tonic for so many days, it will help his memory, or he will get out of this particular difficulty. And the second question is, do children grow out of it? No, the children do not grow out of it, but they learn the coping skills, and with that, they are able to move on. And there is a diagnosis. There is no a diagnosis as such. We need to be professionals, that is the educational psychologists, the clinical psychologists, teachers, pediatricians. We all need to work as a team to be able to help the child overcome his difficulty. And early intervention is very, very beneficial. If you start early, if the child is caught when he's just about to start schooling, it will help him. And many a times when the child is small, 2-3-year-old, there are certain symptoms that tell you that this child maybe is at risk of developing learning disability. So next one. So what are the therapeutic interventions? So we have remedial education. These are teachers who are trained in helping children to overcome their difficulty. They are called remedial because they give a remedy to what wrong they are doing. And occupational therapy is also very important. Those children who do not have a firm grip, they can be, the fine motor grip is not very good, so they can be helped with certain exercises, and so is those who have gross motor difficulty. Some children have difficulty with the articulation, so they need speech and language therapy so that they are able to pronounce the word properly. And if they hear what they are saying, they are able to write it well. And counseling for student and family. This I find is a very, very important area, and which is always almost never looked into. The child needs to be counseled. The child has low self-esteem because he keeps thinking that there is something wrong with him and he is not as good as the other children in his class. So he needs to be told that you're fine. We know that you're working well, you're working hard, but it is your brain. It has been wired in a different way, and that is why you are having difficulty. And with the proper support, you will be able to overcome this. And the family demands a lot from the child. I have had cases where the child is brought to me and then the parent turns around and says, how long do I have to bring him to you? How much time will it take? Will it 1 week, 3 sessions, 10 sessions? So the family has to be counseled, that you have to be very realistic. You understand what the child is going through, what is a learning disability, and don't put pressure on the child. Accept him the way he is and support him. Next one. So here, this slide, children who fail, they do not want to fail. They fail because we have failed as teachers to be able to teach them the way they learn. In a class of 30 children, 27 children will learn the way teacher is teaching, but there'll be those 3 children, they do not learn the way teacher is teaching. So what do? Do we leave those 3 children to themselves and say, well, you take tuitions or you do what you want, I'm not interested in you? Whereas those 3 children are your responsibility as a teacher to see that why the learning is not taking place and what you should need to do. Next one. And here is a prayer from a young girl. It says, if I cannot learn the way you teach, will you teach me the way I learn? And here, how many of us really take the trouble to understand this and help the child? But if we were together, if the parents, the school teachers, the school, and they understood the child's difficulty, they came forward to help. The society, because our society also says, oh, your child is 7 years old, but my child does so much and yours is not doing it. The parents come under pressure and they put pressure on the child. So if we all come together and accept the child for what he is, look at his strengths and not the weaknesses, then it will really make a difference. Thank you very much.
Thank you very much, ma'am. That was a very informative talk, and I really enjoyed the part where you changed the narrative. We also always talk about from the parents' perspective, from the caregiver's perspective, but where you told like how the child feels and how the child has to be counseled and approached, that would make the real difference, and then like help you in forming a behavior or helping them learn it themselves. So that was a wonderful part. There are many questions for you, but keeping the interest of time, I would just ask 2 of them. And may I please request you to be there for the panel discussion in the end where we can take up the additional questions.
Yeah.
The one question, the question is from Navya Pranavi. Does learning disability children have the same IQ levels as normal people, or do they have it less?
No, the children with learning disability, they have average to above average intelligence. IQ is just like, with normal people. Yeah, that is not an issue.
Yes. Next question is from Dr. Parul Goyal. What to do when child of a normal IQ is not able to study because of problems in behavior, like not willing to listen because of rigidness?
Yeah, but we need to probe a little more that why the behavior problem is occurring. Is it because he is not able to learn the way others learn in the classroom? So that is impacting his behavior and he is, throwing a tantrum or not behaving well. So that needs to be looked into, and a counselor, school counselor, or any other psychological counselor will be able to help out to change his behavior.
Yeah. The last question that we'll be taking, are general teachers able to pick up these children in a conventional class?
This is a very, very crucial question. Teachers, most of them, they are not very well versed with learning disabilities. So they don't really bother to look for those signs and symptoms. They need to be given some kind of an orientation from time to time to make them understand if the child is writing in this way, if he's behaving in this manner. So there is something more to it than just behavior. So you should be able to, if you yourself are not able to identify, then refer him to the school counselor or maybe a remedial educator who will be able to help out.
Thank you, ma'am. We'll be taking the rest of the questions in the panel discussion at the end. Thank you. Now, I would like this opportunity to introduce Dr. Radha Rama Devi. Ma'am is chairperson for our next coming talks. Ma'am is a senior consultant at Rainbow Children Hospital, Hyderabad. She has over 42 years of experience in pediatrics and clinical research, about 80 publications in national and international journals. She has special interest in inborn errors of metabolism, newborn screening, clinical genetics, and genetic counseling. Some of her career highlights include she started the first large-scale newborn screening in India. She received the Lifetime Achievement Award in Inborn Errors of Metabolism by the Hyderabad branch of Indian Academy of Pediatrics. Ma'am also got the Senior Women Bioscientist Award from the Department of Biotechnology in 2005. Ma'am has received a Dr. I.C. Verma's Outstanding Researcher Award in 2018. And she has also featured in BBC's Tomorrow's World for her topic, First Genetic Testing in India. Over to you, ma'am.
Madam, you need to unmute yourself, Radha ma'am.
Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay. So let me at the outset thank Dr. Annie Hassan and the organizers of this meeting for inviting me to this to chair this very important session. I really thank Dr. Annie for this, and it is my pleasant duty to invite the three speakers today. And the first speaker will be Dr. Safala Mahadev, who will be talking to all of us in the nutritional management, the challenges that you meet managing Prader-Willi syndrome. Just a brief introduction about Dr. Safala Mahadev. She's a senior clinical metabolic dietitian at KEM Hospital with 32 years of experience. And she's specialized in the management of metabolic disorders, endocrinology, and other disorders. And she has her interest mainly in the nutrition and oncology, obesity, diabetes, and dyslipidemia, and other gastrointestinal disorders, as well as metabolic syndromes. And academically, she is also a guide and mentor to many of the postgraduate students and research internship students in planning the therapeutic diets. And she has published as well as presented number of research papers and projects on the dietary effects of various diseases. And her career highlights includes that she is a certified and life member of several national and international nutrition and dietetics associations. And she has featured in discussions on nutrition for Mumbai Doordarshan and programs like Sati Sayadri and Young Karan. And she conducted a series of lectures on diseases and nutrition in Arogya Sampada in Prasar Bharati's All India Radio. So with all this background, we expect a very good presentation from her in the management of Prader-Willi syndrome, especially the nutrition, which is very, very important in Prader-Willi syndrome. And I invite Dr. Safala Mahadev. Dr. Safala.
Thank you so much, ma'am. I'll just share my screen. Is it visible?
Yeah.
Yes, the screen is visible. Yes, put it on a slideshow.
I have already put it on the slideshow. Can you see it clearly?
Yeah, slide is seen very well.
Ma'am, can I proceed?
Yes, go ahead.
Yeah. First of all, thank you so much, ma'am. It's my really honor to be part of this workshop. And before I proceed, I would like to thank Board of Genetic Counseling team for giving me opportunity to speak on nutrition management and challenges with respect to Prader-Willi syndrome. Prader-Willi syndrome is a multisystem neurobehavioral complex disorder which is due to absence of normally active paternally expressed genes from the chromosome 50, that is Q11 to Q13 region, or parental maternal disomy or imprinting defect. Now, basically described as two stages syndrome: poor feeding with failure to thrive in infancy, which is followed by hyperphagia leading to obesity in later childhood. Endocrinological abnormalities usually includes hypogonadism, short stature due to hormonal growth hormone deficiency, central hypothyroidism, adrenal insufficiency, premature anarchy, and osteopenia. Now, usually signs and symptoms visually we have seen in infants are primary sign is poor muscle tone, that is hypotonia, with distinct facial features like turned down mouth or lowering of the temple, narrowing of the head near the temple, or thin upper lip. Then babies usually show generally poor responsiveness, underdeveloped genitals, and poor sucking reflex, which leads to poor feeding and failure to thrive in later. In children and adolescents, usually food craving and weight gain is a classical sign of PWS. Intellectual disabilities or learning disabilities, along with affected thinking process, something of that kinds are cognitive impairment is also seen. Underdeveloped sex organs, then in adolescents, usually sleep disorders are seen, which might go lead further to OSAs. On denial of food, they can show through tantrums or show stubbornness. Speech delay with articulation of words also seen, and due to underproduction of growth hormones, they seen short stature with high fat mass and low skeletal muscle mass. Management of PWS can be best done by geneticists, pediatricians, endocrinologists, clinical dietitians, physiotherapists, or occupational therapists, speech therapists, clinical psychologists, and other medical professions and paramedics with respect to their comorbidities. Now, nutrition plays a very important role, as in because in every phase, individuals and the caregivers with PWS will face various related nutrition related issues throughout their every phases. And to combat obesity, she has to assess at minimum every 6 monthly with a holistic and comprehensive approach with detailed nutrition assessment. Then she can counsel, motivate, and execute a well-balanced diet plan. Now, why there are changes in phases? There are various proposed mechanisms with respect to this. One is that the normal feedback mechanism that results in metabolic and psychological changes associated with food intake are impaired in Prader-Willi. Secondly, the eating behavior and brain activation studies show some evidence. Secondly, structural brain imaging and postmortem studies revealed cortical and hypothalamic abnormalities in few cases. And the most important is there are many peripheral hormonal circulating hormones which regulates appetite and behavioral are anosogenic leptin, then intestinal cholecystokinin, glucagon like peptide 1, peptide YY, then stomach derived ghrelin. So all abnormalities in these hormones contributes to hyperphagia. As we have already said, there are 2 stages of PWS. Let's move on to these stages in detail. Now, one proposed theory where I come across is the shifting of gut hormones. One theory which shows that PWS shows fluctuations in the gut hormone, that obestatin, in infancy with markedly elevated levels of ghrelin, which is an orexigenic hormone in childhood and later. The shifts of these gut hormones may possibly correlate with the changes in the phases. As the growing understanding of the natural course of PWS identified into successive nutritional and eating behavioral phases and subphases, what precautionary measures to be taken to instill healthy dietary habits well before the child's craving and appetite increases, that I will discuss in next few slides along with the phases. Actually, in utero, this phase starts with the growth restriction and decreased fetal movements, which is supposed to be 0 phase. In phase 1A, where hypotonia starts with difficulty in feeding, weak cry, uncoordinated suck, sometimes they might need to feed through nasal or gastrostomy tube because feeding becomes real difficult. Babies show no signs of being hungry or no excitement at feeding time. They have to given by widened nipples or special bottles are required in this. Now this phase, first phase 1A starts is up to 9 months. So first 6 months we have to basically breast milk is a best option. So as their feeding is difficult due to suckling reflexes are poor, so mother has to express breast milk and give through widened nipples or special bottles to be used. Sometimes she might need use of standard infant formulas to be used, but at age of 6 months, when actual weaning period starts, that time we can use various millets, like we use cereals like rice, ragi, jawar, such cereals we make it into amylase flour along with the pulses, and we make cereal pulse combination porridges and growels. This help when we combine these two things together, cereals and pulses, it becomes a very good quality protein. Along with that, various colorful vegetables can be used for making soups and purees. At age of 8 months, the steamed fish or boiled eggs, those are non-vegetarians, definitely use this non-veg food items. Even the fruits, stewed food pulps also should be introduced in their diet. But care should be taken that in baby should get natural taste of the food. No need to add any honey or sugar or jaggery in any of this weaning foods. In this word, anyways, this nowadays we tell otherwise to all the infants that they should get natural taste of the food. They should not unnecessarily go on adding any simple carbs in their use in weaning practices. Then comes as a phase 1B, where the child starts growing, infant starts growing very nicely. There is no feeding is absolutely improved, appetite is good, starts growing according to natural growth curve, standard charts. But the crucial period starts at phase 2A, where weight increases without any increasing appetite or even without giving in excess calories. Your carbohydrate consumption has to be a little bit reduced to 60%, because usually typical toddlers that makes it to up to 70% of carbs, but here we reduce it to 60% of complex carbs, and good quality proteins up to minimum 15% of the protein should be incorporated into their weaning food items. That has to be taken care. Now the nutritional guidelines, keeping in mind that aim that weight for length should be up to 25th percentile. Then calorie needs should be adjusted as per the standard growth curve, and weight, length, hair circumference always has to be closely followed, initially 2 to 4 weeks and later on every monthly. After 15 to 18 months of age, the calorie needs are typically have to maintain strictly up to 60 to 80% of the RDA. Now, in this weaning phase, as I said, we have to use various food groups into their weaning practices, but in the form of various porridges and gravels and soups, etc. But without use of simple carbs. That is very much necessary. Now, mostly all the babies by age of 1 year, their teeth development has already occurred. So we have to introduce finger foods like small pieces of colorful vegetables and fruits to be given in their hands. Now, after slowly, baby should start eating as per the family's family lifestyle, family eating practices. Now here the family responsibility increases as choices of the family has to be taken care of, because they should be having all healthy practices in eating. Otherwise, otherwise they will pave wrong path or liking towards the simple carbohydrates, unnecessary or high salty foods if they are not taking care at this phase. No pampering or rewards to be in the form of cream biscuits or chocolates or candies or Cadbury's at this phase. That has to be taken care by parents. Now in phase 2B, where weight increases with an increase in appetite, their interest in the food increases, that tempting advertisements have an impact on their mind. They're always concerned about their next meal, what to eat, what you will be giving me in my tiffin. So these questions always they have in the mind. Appetite increases and tend to eat easily more if than the typical child would eat. So frequently we have to be very careful in this when they're giving any breakfast or any lunch or whatever the meals options. We have to be very careful in this. Like at this step, parents has to be very careful, and they have to spend more time with them in the physical activities and outdoor games, and so that they can divert their attention from the food. Secondly, they should develop very healthy food habits. In all the meals, they should be very particular, including more of vegetables and fruits which are lower in glycemic content, and with high protein food items. Good quality proteins should be incorporated in every meal of their day. And then they have to make the specific rule in the house and discipline that no eating while watching any TV shows or in the front of screens, because the chances of eating much more higher. It's easy and it's quite possible, and gaining of the weight also is quite possible, because we see it is the ideal nowadays scenario in normally otherwise also all the family people are eating in front of, they are sitting with their sales and or in front of TV shows, and they are having their food. This is a common scene nowadays, and this has to be taken, precaution has to be taken at this phase very much, because otherwise they will easily gain more weight. And because in this phase the craving towards the simple sugary items is very high, so we have to be very careful in this. Then the phase 3 starts, where the hypophagia begins, and rarely child feels full, and it starts from the 8 years onwards, and they will continue eating if not control the portion sizes. They might steal some money for for food, might throw some tantrums to get their food, or their liking towards that food. If they're not getting, they will make some tantrums for it. So I feel if we monitor right from the phase 2 and with proper nutrition, exercise, and deal affirmatively with the behavioral issues right from that age of 2, then it is easier for us to tackle the phase 3 and prevent and delay the further consequences. But my experience is, when we see in our OPD the patients are many times they'll end up at age of 8 years, sorry, and then the previous phases are missed, and then already they are pampered, and nahi sunta hai karke we are giving more. Okay, then nahi manta hai, we have given him food. All these things the parents start telling us, and already he is into that phase where he is sometimes, it becomes very difficult for the parents to manage. So I feel that they should know the major consequences in the future right from phase 2, and they should take care at that time, that period only. In phase 4, what happens is appetite is no longer insatiable, and they might not make tantrums as they are grown-ups now, but due to urbanization and what I have found in our cities, at all the food malls and food brands are at their doorstep, and one click or one phone, immediately it is possible for us to get it within half an hour at our doorstep, and it becomes very handy for them. And so indulging in this unhealthy food items is very much what we have seen. Many of times I have seen in this in adolescence phase, they are sitting at late night, they are busy with watching televisions, and they are I have seen the patients where till 2 a.m. 3 a.m. they are awake and busy in this TV screens, and same time they are indulging on the cold drinks or sweeter foods or something like burgers or pizza, which they have already stored in the house, and then whole family sleeps and then start eating, and then they get up next day morning by 11-12 o'clock. The whole cycle of the day is messed up, and then they do the brunching, like breakfast and lunch is all together, and then at 12 o'clock they will have all things together in a good amount. So this all mess up also we have seen in this phase. So we have to be the parents and family and everybody has to be very careful at this phase, because phase 3 and phase 4, if not taken care, then they will be paving a path towards obesity, morbid obesity I would say, and other comorbidities like insulin resistance and developing metabolic syndrome with respect to hypertension, type 2 diabetes, sleep apnea, respiratory insufficiency. Some I have seen going into cardiac congestive heart failure, or in cardiovascular events are quite often seen with respect to this. And then so dietary restriction at phase of 3 only, it is very necessary to be in 60 to 70% of the total calories of RDA to be given in spaced out throughout the day, along with good quality proteins and vegetables and fruits to be incorporated. And that also, those are higher, they are lower in the glycemic index. That should be the choice, along with, of course, physical activity and behavior management has to be taken care of. And these are the fundamentals for the prevention of obesity and the future health problems. As I said, nutrition has to do nutrition assessment. What is that assessment supposed to be? It's a ABCD approach. What we do, that means anthropometry. A is anthropometry, wherein we see the height, weight, body mass index, mid upper arm circumference, till toddler's age, head circumference is seen, waist circumference has to be seen because that shows a visceral fat. Then hip to waist ratio has to be checked. DEXA scan reports and muscle tendon reports to be looked for. Then biochemical parameters according to the grade wise, like blood sugar, HbA1c, HbCBC, lipid profiles in detail, liver function test, renal function test, iron studies, inflammatory tests like IL-6, CRP. This to be checked for, see the fluid intake, whether there is appropriate for the day. Then electrolytes to be seen, other vitamin or minerals, serum electrolytes like vitamin D, vitamin B12, magnesium is done at least once in a year for this patients. Then clinical signs and symptoms to be seen. Firstly, she should be reading thoroughly all the clinical notes given by all the all the physicians clearly. Then check for gastrointestinal issues, like frequently they come across irritable bowel syndrome, then like sometimes they have frequently episodes of diarrhea or constipation. Then check for the observe well with the body organs like nails, skin. Is there any pitting, edema or normal puffiness on the face, or they are having any gastrointestinal reflux, sometimes a complaint of the GRD, that has to be asked for. Then see whether they are having proper how's the urine output, whether fluid intake is proper for the day. Then her own forte is a dietary history. Usually we see a nutritional assessment by subjective global assessment tool, which is a SGA tool, which is a comprehensive tool where we can take a detailed recall from morning till night, whatever he does or she does. Along with that, food frequency questionnaire, how often they are into binge eating, that has to be seen. dietary food habits, the cultural pattern, the family eating style, his his school or college schedules, the timing of this, the whether he gets activity, whether he gets time for any physical activity has to be seen before or after, what type of food he takes in between, because nowadays we are seeing there's so much competition in the studies. They are busy in back-to-back tuitions. They don't have time for actually in outdoor games, and usually those games to be played on the ground sorry, on the playground, they played on the mobiles, and then they don't have time to do on same time they go on binge eating on various chips and wafers. That is also commonly we see. So all these things has to be asked in detail. Her curiosity also has to be always on whatever he or she says. On that has to be questioned ahead about the activities, because the sleep cycle also has to be seen, because many times is, as I said earlier, they sleep well very late at night, and even I ask about the whole family what time they sleep, because I have seen sometimes the whole family only is indulging or in busy in screen shows at till late night, and the whole family sleeps late, and that because automatically the child also is awake till late night. So this is also very commonly seen in the urban our routine cities. So that has to also be asked, and then after taking the comprehensive total approach, then she has to plan well balanced diet. So basically she should be a well observer, a good listener, and very well having good patience. Then only all these questions will she will be better deal with. This is what rightly said, there's no single or correct way of feeding the person with Prader-Willi. This graphic I have taken from the dietitian Melanie Silverman is so true that Prader-Willi plate we should look like this. We always tell them to take a small to medium sized plate, and the half of the plate should be filled with or more of vegetables and sprouts and colorful salads, either tossed salad or the other different types of salads should be used. And here the additional focus is seen on the gut health by including fermented foods like curd, buttermilk. These things has to be incorporated in their daily diet. So PWS should be advised with strictly with the 45% of the complex carbs, 25% proteins, and 30% of the healthy fats should be incorporated in their 3 major meals and 2 small meals in between. Previously, the 2 decades earlier, I see the focus was only on restricting on the calories and restriction on the fats. There was no much attention on the carbohydrates. But now in recent years, the focus has turned into micronutrient composition. How's the composition of the protein, fat, carbohydrate balance, whether it is maintained or no, how much percentage of protein he is taking, what quality of protein he is taking, whether the first class protein is there or no, which is very much needed for the high biological value protein is needed for the skeletal muscle mass. So that has to also be taken care. So when we are taking this, dealing with the detailed recall, we come to know various of this macronutrient composition. Along with that, where there is a micronutrients and functional foods, whether they are incorporated in the diet or no, that also has to be seen. So is all recommended that to reduce, or I should say eliminate simple sugars or refined carbs. First and foremost is a prime importance, and focus on very good quality proteins and vegetables along with healthy nuts is a prime importance. Now, gist of this heavy slide is basically gives the importance of fiber. The dietary intervention rich in fiber, especially a minimum of 40 grams per day, which shifts the dysbiotic gut microbiota to the healthier structure. Along with it, contributes in elevation of the metabolic deteriorations in PWS as well as in the obesity. It helps in improving systemic inflammation and lipid profiles. It also helps in improving hypophagia-related behavior because satiety we are getting due to fibers. This fermentation of dietary fibers by the gut bacteria produces short chain fatty acids, and which has shown the help in increasing expressions and secretion of anexogenic hormones GLP-1 and PYY. So this is all is of really importance to incorporate fiber by good amount of sprouts and healthy vegetables and fruits in their daily practices. Now you must all have seen this proposed food pyramid, which is very true that this pyramid has to be followed. Now I'll show you this all colors in pictorial way in the next few slides.
You have only 2 minutes time. Please wind it up.
Yeah, sorry, ma'am. Nutritious foods are naturally low in calories to be used. We can use it generously without any limits. We can go ahead with this. These are the revised food things where pulses and legumes should be taken in good proportion. See that legumes are good in the cereal combination. 1:2 proportions to be used. Then these are the nutritious contents which are to be used in daily purpose. The proteins to be taken in good quantity, which are of real benefit and should be used in every meals to be incorporated. These are the to be eliminated strictly with because these are very detrimental to the health. Here one thing which frequently asked by the patients, that can I use artificial sweeteners here instead of simple carbs? So here I usually say no to it, because though it is not giving any calories, but it derives affects metabolic signals. The calories our brain associate with sweeteners are not received, so still craves them, and hunger is not satisfied at all. So artificial sweeteners also not should not be used. Food challenges which I have seen in my practices is trying to fit dietary regime in family dietary habits, and availability and cultural footprint is a real challenge, because whole families together, our siblings are sitting and they are more in munching and all that. Is difficult for them to handle and give them disciplinary instructions. It's also again a challenge. Factors with financial constraint, because though we say 25% proteins should be included, then the first class protein nowadays for low socioeconomic backgrounds, then the high good proteins which are costly ones are difficult for them. Peer pressure is one more challenge, and family understanding capacity has to be seen, the literacy effect to be seen, and dietary discipline exercises are really main thing to be motivated. Training with the good recipes, modifying recipes with the palatability of food consideration is of prime importance. And mainly what I have seen is a fight against temptations with the advertisements and gadgets is against to ready to eat food and food delivery at the doorstep with adaptive lifestyle is a definite challenge, and we have to go on hammering them at every our diet follow. And yet we have to be very affirmative in approach, because priority of the patient healthcare is a prime importance. Follow up every minimum monthly or at least once in 6 months is necessary with the total ABCD approach, along with counseling with the caregivers and family support. Don't believe on every claim which is given. So a rule of thumb is check for the ingredients very closely. There are hidden forms of sugars like high fructose corn syrup, hydrogenated oils, these type of sugars to be checked upon. Take-home message will be dietary modifications, food habits to be seen, portion control is quite important, meal timing, they should not go on munching at any time of the day, as a fixed time set for the patients to be eating. And then water consumption, because here I said purposely because many times they don't like the taste of the plain water. This is the complaint, because parent pamper them with the sugary drinks in the water bottle in the school, in preschoolers, and afterwards it becomes difficult for them to handle for the plain water. Physical fitness and multidisciplinary management with the medical team, it's a prime importance and mandatory. So conclusion is energy restricted and well balanced diet with dietary fiber is a first line approach in dietary management with appropriate recommendations to achieve healthy weight for the PWS along with normal growth curve. And lastly, I would say the sticking to a structured, consistent approach to some fundamental aspects of eating will be of definitely benefit to the child and the whole family. Here I have given some healthy recipes examples like veg soya curry or vegetable curd raita, colorful sprouts chaat, paneer saute with plenty of vegetables, vegetable egg burjis, idlis in the reverse proportion of rice and dal, mushrooms with rainbow chaat, mushroom with plenty of vegetables, whole grain egg rolls. So there are few examples to just give an idea how we can incorporate good quality vegetables and fruits in this. Thank you so much for patiently hearing, and my best wishes to the conference. Thank you so much, ma'am.
Thank you very much, Dr. Sapala, for your exhaustive exposure towards the nutritional management of Prader-Willi. And in our experience, it is a really difficult task to deal with these patients, and how much we go ahead and explain to the parents. most of them come back with a failure. So it is really very, very difficult to manage nutritionally this and finally ending up in gross obesity of patients. So any of the questions, I think we will be taking in the panel discussion, and we'll go with the next speaker. Thank you very much.
Thank you, ma'am.
So now I invite Dr. Kavita Bhatt to give her talk on metabolism and sleep disturbances in Prader-Willi syndrome. Just a few words about introduction of Dr. Kavita. Dr. Kavita and me, we have a few things in common, and because she is the one who started the first of its kind pediatric endocrinology and diabetic services in the state of Karnataka. And I think I also did the same thing of starting the first newborn screening in the state of Karnataka. So this is what is common between her and me. And she also launched the Pediatric Diabetes Center with focus on technology in managing diabetes. And she also started the endocrinology fellowship program, pediatric endocrinology program at the Rajiv Gandhi University of Health Sciences. Her main interest will be in the treatment of diabetes, short stature, growth hormone deficiency, early and late puberty, obesity, pediatric bone age disorders, endocrine disorders, and bone health. So academically, she's a fellow in pediatric endocrinology and diabetes from the Louisiana State University School of Medicine, USA. And she has lots of postgraduate students under her training in pediatric endocrinology. And she is affiliated as a senior consultant pediatric endocrinologist at a group of hospitals, Bangalore. So Dr. Kavita, may I invite you to give your talk on sleep disorders and especially the daytime sleep disorders in Prader-Willi syndrome. And welcome.
Thank you, Dr. Radha, for the kind introduction. I hope you can hear me. Yes. I have to use my mobile to give the talk. So the topic was metabolism and sleep disorders, but I think I would change it a little and speak more about endocrine dysfunction in Prader-Willi, because Prader-Willi syndrome is essentially an endocrine disorder. It happens, it's a syndrome that is due to dysfunction of a portion of the brain called the hypothalamus. I'm assuming that there are a lot of parents here, so I'm going to make it rather basic. So it's likely to be due to a dysfunction of a portion of the brain called the hypothalamus. The hypothalamus is an endocrine organ at the base of the brain that plays a crucial role in many bodily functions, including regulating hunger and satiety, body temperature, pain, sleep, wake, balance, fluid balance, and etc., emotions, fertility, and a whole lot of functions.
Dr. Kavita?
Yeah?
You want me to share the slides or?
Yes, I want you to share the slides.
Yes.
So you can put the first slide. The next one. So I have not yet covered this. So it's basically due to a dysfunction at the level of the hypothalamus. Next slide, please. Next slide. Yeah. Which causes all the endocrine changes, including obesity, growth hormone deficiency, hypogonadism, which is lack of development of the reproductive system, hypothyroidism, adrenal insufficiency, low bone mineral density, risk of type 2 diabetes. Could I have the next slide? Next slide, please. Yeah, so I will first cover the implications of growth hormone deficiency, the role of growth hormone and what happens to the growth hormone axis in Prader-Willi syndrome. In Prader-Willi syndrome, there is invariably an altered growth hormone IGF-1 axis. It's a universal feature. Growth hormone is a hormone produced in pulses in the pituitary gland. It acts on the liver to produce IGF-1, which is what acts on the growth plates and causes us to grow. So growth hormone deficiency is very frequent in children with Prader-Willi syndrome, up to 74%. But however, some children may not have growth hormone deficiency as such, but have an IGF-1 deficiency. So nearly 100% of the children will finally have IGF-1 deficiency, either due to growth hormone deficiency or even with normal growth hormone responses. Could I have the next slide, please? So amongst all the treatment options available for Prader-Willi syndrome, available currently, I think this is one of the most promising, and we need to diagnose Prader-Willi syndrome early, because treatment should begin before the onset of obesity, which happens by around the age of 2 years. These children start gaining weight by around the age of 2 years, and growth hormone treatment should be started very early. Hence the importance of early diagnosis. However, despite growth hormone treatment, it is important proper nutritional management also should go on. Could I have the next slide? So how much growth hormone is given? We start with the dose of 1 milligram per meter square body surface. Dosing is based on IGF-1 levels, for 2/3 of the normal range. We typically don't want it to go above the range of normal, because it can lead to acromegalic features in the infant, large head and small chin, those kind of features, if we keep IGF-1 levels supraphysiological for a long time. So in adults, the dosing typically starts with 0.2 to 0.4 milligram, with slightly higher dose for women, because estrogens causes increased metabolism of growth hormone. Could I have the next slide? So these are the remarkable benefits of growth hormone. Here on this, the graph on the left side, this is the University of Florida data, wherein they have started growth hormone in infancy, early infancy, even as early as 3 to 4 months. And you can see the normal IQ could be anywhere between, average IQ of the population is between 80 to 115. And we see here that when it started early, the IQ is almost normal, say around 100 to 100 and above 85, definitely in that graph we can make out. Even if it's begun a little later, there is some benefit. So it's very important to catch these children early. Children with Prader-Willi syndrome early. Growth hormone can change the natural course of the disease if started early. It has also been shown to increase the muscle tone, mobility of children when the treatment is started early. Could I have the next slide? So we all know there are several benefits of growth hormone. It's multiple, and it's important that we continue to give this benefit to children. The drawback is the expense of growth hormone treatment, which I won't get into in this talk. Could I have the next slide, please? So what are the side effects? There is definitely no increased risk of leukemia. There is no greater risk of scoliosis, which is a curvature of the spine. Children with Prader-Willi syndrome can develop curvature of the spine even without growth hormone, and growth hormone does not impose a greater risk. So we should not deprive these children of the benefit of growth hormone treatment. However, we need to keep in mind that the growth hormone can also cause the tonsils to grow, and it can worsen the obstructive sleep apnea, which commonly happens in children with Prader-Willi syndrome. One of the signs of obstructive sleep apnea is snoring, irregular breathing at night. When the child is sleeping, the parents say that the breathing is very irregular. There are pauses in breathing. The child wakes up frequently, gasping for breath. These are all signs of a sleep disordered breathing or obstructive sleep apnea. And when we start growth hormone, we question the parents as to whether they have observed such things in their child, and because this is one of the things that we need to follow. Sleep studies are recommended at baseline, and again within 3 to 6 months of starting growth hormone therapy. Ideally, getting sleep studies done in our circumstances is not very easy, but this is in the ideal situation. So can I have the next slide? So most of the children with Prader-Willi syndrome could take growth hormone treatment. And in fact, it's a game changer for Prader-Willi syndrome. If begun early, it can change the natural course, natural history for better. So, but there are certain exclusion criteria like severe obesity, if there is uncontrolled diabetes, if there is untreated severe obstructive sleep apnea, we do not start growth hormone till that is addressed. And if there is active psychosis or any other malignancy, like in any other, like in the general population. Could I have the next slide? So this is how we monitor children who are on growth hormone. Because the dosing is IGF-1 based, we do monitor the IGF-1 levels. We monitor the body composition. We monitor the pubertal status. We do a bone age. We look for symptoms, signs and symptoms of obstructive sleep apnea. We monitor blood glucose level because growth hormone treatment can impose a state of insulin resistance. We do have to monitor for thyroid function tests, lipid profile, and liver function. So these are all the things that we monitor when the child is, we ask the families and we examine these things when they come to us. Could I have the next slide? So there are a few side effects, which is not very common, but we need to keep in mind. If a child who is on growth hormone treatment develops hip or knee pain, they need to inform us immediately because it could be a condition called slip carpal femoral epiphysis, or if the child starts limping, we need to keep in mind, we need to examine the child for this. Insulin resistance, because growth hormone is antagonistic to insulin, and they can, we need to monitor the blood sugars to see if it's all fine. Could I have the next slide? So the next endocrine abnormality because of hypothalamic dysfunction is hypogonadism. Hypogonadism is a lack of development of the reproductive system, gonads. So the hypogonadism can be due to a hypothalamic dysfunction itself, or at times it could be primarily a problem in the gonads as well, or it could be a combination in these children. Could I have the next slide? So these are the manifestations of hypogonadism. It's like in a male, you may notice as the child is born or as an infant when they come to us, if we see scrotal hypoplasia, or if we see that the testis is not come down, or if the penile length is in. So suppose we have a child whose testis is not in the scrotum and the child is hypotonic, floppy, we definitely need to check out for PWS and start treatment early. Because like I said, growth hormone treatment started early, as early as 3 months, can be a game changer. It can normalize the body composition. It can normalize the IQ, cognition. Also, studies have shown that cognition improves when we start growth hormone early. So and it's very, very beneficial. And also expense-wise, I think this would be the best period if we have to invest in growth hormone when their body weights are so less. In females, you have hypoplasia of the labia or clitoris, and there could be a pubertal delay. Breast development could start, but it may not progress into menarche or periods. The child could present with lack of periods or irregular periods, and the serum is, when we do the serum estradiol, it's low, and the inhibin B levels, which indicates the potential for fertility, that would also be low. Could I have the next slide? So, so for when we see either unilateral or bilateral undescended testis, which is almost universal in children with PWS, we want to treat it early. We give a hormone called human chorionic gonadotropin, which mimics one of the pituitary hormones called luteinizing hormone. And studies have shown that this has better outcomes in terms of development of the scrotal sac and growth of the phallic length. And this better outcome can persist for a long time. So what happens is the age of puberty in males can be normal. It may apparently be normal, but it may not progress beyond a certain stage. So these children, when it's time for them to enter puberty, need to be treated with testosterone. So it's recommended that testosterone be started by around the age of 15 to 16 years in boys. Could I have the next slide, please? So in females, it's a combination, again, there could be a combination of a pituitary, hypothalamic pituitary dysfunction causing hypogonadism, which is called hypogonadotropic hypogonadism, or there could be a primary ovarian failure itself. So if there is no breast development in such children by the age of 13 years, or puberty starts but it stalls, or there's no periods by the age of 16 years, then we need to give hormone replacement therapy. Could I have the next slide, please? So these are the other hormones, the hypothyroidism and hypocortisolemia. The pituitary gland, which is controlled by the hypothalamus, produces a hormone called thyroid stimulating hormone, which acts on the thyroid gland and makes it produce T3 and T4. So children with Prader-Willi syndrome could have central hypothyroidism. Central hypothyroidism is due to a deficiency in the thyrotropin releasing hormone in the hypothalamus and subsequently the thyroid stimulating hormone. So we need to screen them every year for this and replace it if and when we observe a deficiency. Now there is another condition called central adrenal insufficiency. We all have a gland called adrenal gland, which produces steroid hormones called cortisol. So when this cortisol production by the adrenal gland is controlled by the pituitary gland ACTH production, which in turn is controlled by the hypothalamus. And we have hypothalamic dysfunction in children with PWS. So due to that, the adrenal gland production of our own steroids called cortisol also may be suboptimal. It may not be obvious in the basal state, but when the children go through major surgery or some other stress, then they may need covering a stress steroid coverage guideline. After investigating, after doing some tests to uncover whether the child has a deficiency or not. So this is CAI, central adrenal insufficiency, which is a lack or insufficiency of steroid production in our own body. Could I have the next slide? So bone health and vitamin D, there are multiple factors affecting bone mineral density in children with Prader-Willi syndrome. So it is recommended that bone mineral density by DEXA be done at around the age of puberty and every 1 to 2 years thereafter. We need to maintain normal vitamin D level, give adequate calcium intake, and we need to treat the hypogonadism because these sex steroids are important for peak bone mineral density achieving peak bone mineral density. And if we delay hormone replacement for either the testicular or ovarian dysfunction, then that may impact the bone mineral density permanently. Could I have the next slide? So now coming to diabetes, what they say is type 2 diabetes is more common in children with Prader-Willi syndrome. And these children are believed to be exquisitely sensitive to insulin. But we do see other type 1 diabetics also. Hence, we need to screen. We need to rule out type 1 diabetes in these children before we think it is type 2 diabetes. And type 2 diabetes actually occurs in adults with Prader-Willi, not in very young children. So there are certain molecules like liraglutide, which has been approved for use in children, which also helps with weight loss. So there are very effective treatment strategies available for children for type 2 diabetes in individuals with Prader-Willi syndrome. Could I have the next slide, please? So there are several medications for weight loss, which do have benefits. Some of them have some side effects. So this is a list of medications. I'll come to the next slide. Next slide, please. So these are all medications in the pipeline. These are all very interesting, exciting. So I'm sure we'll have something very effective to treat obesity in children with PWS soon. So there are many medications in the pipeline. Could I have the next slide, please? So this is, this font is a little small. So these are the recommended screening and monitoring recommended for children with Prader-Willi syndrome and how frequently we need to do it. Could I have the next slide? Now coming to sleep disorders, this is not my specialty, but as such directly. But sleep disorder is very common in Prader-Willi syndrome. One is, of course, because of the obesity, there is something called obstructive sleep apnea, which is now called sleep disorder breathing. So we need to ask for a history of snoring, whether there are pauses in breathing, choking during sleep, and stopping of breathing during sleep. Some children do have excessive daytime sleepiness. They have behavioral and learning problems, which is compounded by these sleep disorders. So we need to screen them for sleep disorders and refer them. Often my patients, what I find is that they have problems in with snoring and obstructive sleep apnea, which also affects their cognitive ability. So I refer them to the pulmonologist to do sleep studies, and depending on whether they need a CPAP or a tonsillectomy, the ENT and the pulmonologist, they take a call on that. I think with this, I'll stop and I'll take any questions. Thank you.
Thank you, Dr. Kavita, for your excellent presentation, and that too finishing before time. And maybe we'll take one or two questions.
Sure, Doctor. Thank you. Thanks.
I just want to ask you one question.
Yeah.
When you start a child on growth hormone, how long this has to be continued?
Definitely till the epiphyseal fusion, after which they need to be, again, adults need to be evaluated for growth hormone deficiency, and they can also be started if they're found to be growth hormone deficient. Whereas children don't need to go through growth hormone stimulation test. All children should receive the benefit of growth hormone treatment. So it's across the lifetime.
Across it.
Needed.
Okay.
Yeah, if needed, like if the adult tests positive for growth hormone deficiency.
So are there any constraints with regard to the treatment being very expensive?
Yes, definitely. Definitely it's a big major constraint, because their body surface is based on body surface area, and the weight also contributes to increase body surface area. So as they grow older, the expense of growth hormone treatment increases. So if at all, that's what I said, if at all, the best period, if the parents can afford only a short period of growth hormone, they don't have too much of resources at their will, maybe the first 2 years of life is the period where I'll go with, because it has been found to improve cognition and change the natural history of Prader-Willi syndrome in a positive direction. Right. So it's a game changer almost, if started early.
That's right.
Early infancy is what they talk about, 3 months, 4 months. So we have to have a high index of suspicion. Pediatricians need to be sensitized. And when the child is that small, the child is actually failing to thrive. So the dose of growth hormone is very, very less. And I think many will be able to afford it at that stage in life.
Right. Thank you. Any more questions? I don't see any in the chat box.
Yes, ma'am. So there is one question from Mr. Rohit. What is the maximum age at which starting growth hormone therapy is still beneficial for Prader-Willi syndrome kids? Or how much delay is not too delay in start of GHT therapy?
Growth hormone has benefits if started at any stage. But maximum benefit is when it started early in infancy, because it will help cognition. It's supposed to increase the head circumference and brain growth and cognition, IQ. So, and body composition, mobility. So there is no such thing as too late. because even adults can be given growth hormone treatment with beneficial effects, but the best outcomes are when it started very early.
Okay. One more question we'll be taking. Do you recommend any safe alternative for testosterone or benefits of testosterone? Those are two questions.
Yeah, testosterone is definitely indicated. It's a replacement for hypogonadism. Does it answer the question?
Yeah, the question is, I think the question is, do you recommend a safe alternative for growth hormone? And the next question is benefits of testosterone. Sorry, those are clubbed. Yeah.
Growth hormone. No. Growth hormone itself is safest and the best.
Okay. And benefits of testosterone. This is the second question.
Benefits of testosterone is it replaces a hormone deficiency. So definitely, if the child has testosterone deficiency, his peak bone mineral density will be low, his bones may be fragile. So that's the benefits of testosterone replacement.
Thank you, ma'am. We'll be taking the rest of the questions in the panel discussion. May I please request Radha ma'am to introduce and invite our next speaker.
Yeah. Thank you, Dr. Kavita. And let's go to the third speaker, Shika Mehtaramani. And she is the founder president of Indian Prader-Willi Syndrome Association. And actually, after a great struggle to get a right diagnosis for her son in early 2000 in India, she approached her family of doctors in USA, and her son was finally diagnosed with Prader-Willi syndrome. And he was the first Indian to register as Prader-Willi PWS case in the international database. So in 2004, June, Shika was invited to attend the PWS conference hosted by the USA Association, where she met the then IPWSO president, late Mrs. Pam Eisen, who mentored her and encouraged her to start the Indian chapter of Prader-Willi syndrome. So she's the one who started the Prader-Willi syndrome association, and she will be giving a talk on the role of advocacy groups and the note by parents representations. And Shika, please come and give your talk.
Thank you, ma'am. Thank you to BGCI for giving us the opportunity and this platform for spreading the much needed awareness of Prader-Willi syndrome in our country. So the Indian Prader-Willi syndrome, and obviously thank you to IPSO for coming in front and sponsoring the workshop today. Now the Indian Prader-Willi Syndrome Association is...
Madam, should I share the screen? Slides?
I'm also sharing the screen. If
okay, okay.
Can you see the screen now?
Yeah, yeah, it's okay, yes.
Okay. So the Indian Prader-Willi Syndrome is a non-profit trust founded and run by parents of PWS patients. We work as a parent support group to extend support to the affected families, and we spread awareness about this complex and rare genetic disorder. By sharing our experiences and connecting with PWS families, our primary focus is to improve the quality of the life of our individuals with PWS and the quality of life of the caregivers. We all have already heard the previous speakers, and we know that PWS is a very challenging disorder. So it is very challenging on the family as well. By sharing each other's experience, we just kind of motivate each other and give each other a moral support, which is very important. As a parent and as a mother, I know what it means to me. IPSA is a member of the International Prader-Willi Syndrome Organization, and we are affiliated to them. We're also a member of the Organization of the Rare Disease India. We welcome everyone associated with PWS to join IPSA. We request doctors and geneticists everywhere to connect PWS families to us, because PWS is something which has ongoing and every stage has different needs. So with proper guidance and to be in regular touch with us, we can always guide the families on how to improve the quality of life and what are the tests to be done at a regular interval. So the next slide is how we started IPSA. Dr. Radha has already given a brief of how we started. So when I came back to India with the support of my other two co-founders and trustees, Mr. Rohit Nagarat and Mr. Anil Chaube in the picture, we three started the Prader-Willi Syndrome Association in India. And formally, we were registered in the year 2010. Before that, we had our informal conferences and where we met up with the family and the children met each other. So from IPSA, we also provide free diagnosis. Earlier, it was very difficult to get too many laboratories to do the genetic testing, but now it is much better. So through the help of International Prader-Willi Syndrome Association, we had earlier started doing the genetic testing from Bird Laboratory in Italy. We would send the samples of patients there and the reports were sent from there. It was done. But now we have many other, in fact, there are many labs who are doing it. And for patients who cannot afford the genetic counseling, we have Dr. Dipanjana Datta, the geneticist, who's been very kind to give free genetic counseling to PWS patients and families. So we also arrange free diagnosis for patients who cannot afford the test. In our country, more than 90% PWS cases, as we heard the first speaker speak about the number of cases, Prader-Willi cases could be as close to 1,800 in our population. But 90% PWS cases, surprisingly, are undetected or diagnosed at a very later stage. Now, early intervention is always the key of Prader-Willi, and we emphasize that the earlier you start in taking care of the child is better management and for behavior and in terms of behavior and obesity. Although PWS can be a life-threatening disorder, but with continued mentoring and prevention of obesity, these children can live a normal lifespan and accomplish many things that their normal peers can do. Ever since we have been guided and motivated by IPSO, and over the years we have taken part in several reputed medical conferences like Pedicon, like ISPE, and various other cities in India. We have been trying to spread awareness of PWS at the medical fraternity, and gradually it has been increasing our numbers. And it's totally depend on what the doctors are taking back from the conference and how many patients are they connecting to us. We have Dr. Bhatt, Dr. Archana Arya, very esteemed doctors who have been very kind to connect Prader-Willi patients to us and referring our group to them. In 2018, we had done our 4-city tour guidance and presence of then the IPSO president, Mr. James O'Brien. This was attended by very senior doctors and collaborated with eminent hospitals such as AIIMS Delhi. This is a picture of the AIIMS Delhi conference, and in Rainbow Hospital in Calcutta, we had doctors from SSKM and Institute of Child Health. So they have been participating. We have some very good doctors who've been guiding us throughout. In 2020, our national conference was shelved due to the pandemic. So we held 2 virtual meetings to mark the month of May, which is a PWS awareness month all over the world. And we had 2 international speakers, Dr. Casey Bernard, psychologist and a fitness expert, along with some Indian speakers as well. So that was one way that was totally parent-centric, and the parents could take back a lot of information which could improve the lifespan and the life quality of their children. About what is a PSG? So a PSG is, you can read as per the definition, is a group of people with common experiences and concerns who provide emotional and moral support for one another. Support groups fulfill many functions like educating patients, families, sharing the illness experiences, providing strength to its members, raising public awareness, and fundraising. The patient support groups in the West came into existence much before the concept became known in India. With high levels of poverty and low levels of education, a large patriarchal society and multicultural environment, joint families, traditional beliefs that hinder, India has many challenges in this field. there is insufficient patient data, and that is one of the largest concerns in our country, because of which we are not being able to give a proper database to the government. So we really are wanting parents to come and connect with us, so that as a group we can have some weightage in the voice when we are writing to the government to give some grants on to Prader-Willi families regarding growth hormone, and even something like a recognition as in the disability certificate. So even unlike the West, India has a culture of hiding one's illness and not asking for help. So that is another reason of inadequate disease database. There is a they live in a denial, and so the disease is not, eating disorder is not really actually taken as a very serious illness initially by the family and the parents. So these PSGs actually came into existence to provide patients and their families a compassionate and safe environment to share their experience and learn coping mechanisms for managing their health challenges. Now, the long-term sustainability of a PSG totally depends on the commitment of the PSG leaders, the active involvement of the medical professionals, and financial support from funding partners, and most importantly, the level of patient engagement. The level of patient engagement I would like to emphasize here, because we do get patients or families who come and speak to us once, but when the moment they find out that there is no cure to Prader-Willi syndrome, they just sit back and they don't want to do anything much about it. So I just keep urging to the families that maybe there is no cure today, but there could be a cure someday. And we keep up to date with the latest research which is going on around the world, and keep forwarding and informing the families in our group about it. So, we should not regret later that what we could have done today when there is no cure. And by the time we start and there is a cure, it's too late. So the very idea of a support group is understood very differently in India. In our culture and context, support groups are seen as resource centers for seeking information or emotional support only and as when the need arises. So again, one more thing, what happens is some members in our group are always putting up pictures and encouraging and motivating other parents and sharing their children's achievements. So I just feel that only when the need arises, we should not get in touch with each other, but we should be in touch with each other on a regular basis, sharing about our experiences, good or bad. We are gradually achieving our goal of early diagnosis and early intervention. And that's our core activity. And our core activities continue like patient education, public awareness, and counseling support. We work on improving the outcomes of treatment through patient education and lifestyle management, but we always emphasize that this should be done under the guidance of a good medical practitioner. There has been, in the last few months, we have lost some Prader-Willi children who have been just hitting puberty. And it really saddens to hear about such cases. We just feel that if the families would take our suggestions more seriously and kept in touch more, there is always hope and there is help. Thank you.
Thank you, Shika, for your presentation on the IPWSA. And I'm sure that all these parent groups, I think they are the most strongest group in the country to achieve what is required for their wards. Especially, we do see a large number of the parent advocacy groups coming forward to get the things done. As we have seen recently, the government coming out with the recent rare disease policy, and wherein all these disorders are included as rare diseases for the financial support for these patients.
Yes, ma'am. For the first time, for the first time, the rare disease policy also mentions Prader-Willi syndrome in the Group B category. And in West Bengal, the growth hormone therapy is provided free of cost to a lot of patients who cannot afford it.
Right. Thank you very much. And I think we have finished this session. And just to sum up that we got the exposure to see how early a diagnosis of Prader-Willi has to be made, so that you can initiate a very good nutritional support to these children as proposed by Shafila in her talk of 4 stages of nutritional management, because this is a very important aspect of Prader-Willi, because these children, by 2 years of age, they come with obesity. So that is the reason why an early diagnosis is very essential. And then coming up with the second speaker talking about the metabolic changes in Prader-Willi syndrome, this is again a very important field wherein we will be able to control the excessive weight gain, at least by looking at the hormonal imbalance these children have. And finally, we have the advocacy groups coming up in this country to help these children in terms of getting a diagnosis or getting help from other families. And many a time the parents ask whether they can be introduced to other family members so that they can exchange their views with the other families with regard to the management or what are the problems they face. So this is a very important group that we need to encourage in this country. So with this, I think we finish our 3 speakers, and then we go into the next panel discussion. Is that okay, Gayatri?
Yes, ma'am. I request you and as well as all the speakers to join the panel discussion, and we'll be taking up the questions that were missed during the sessions now.
Yeah, I think we all are here and they can start taking the questions.
Yes, ma'am. I request all speakers to put their videos on. Yeah, the first question is to Ms. Farida Raj. The question is, what are the specialized courses available in India? How can we pursue education for our children with PWS who are not able to cope? Ma'am, you're on mute.
Me? No, I'm not muted.
Farida ma'am, you're on mute.
Yes.
Shika will be able to answer this question.
Yes, ma'am, you can answer now. We are able to hear you.
Yeah.
Okay. The Rehabilitation Council of India conducts courses which help train people, teachers, to look into the education of children who are having learning disabilities. And this is really a very good course, and the teacher trained are good. They can help children with this issue. Does that answer the question?
No, are there any places where these children can be trained?
No, not really. It actually, the regular schools, they have resource rooms. And if these children are going to a regular school, then the resource teacher will look after them. She will train them. But apart from that, I am not really aware that for such children, there is any place that they can be trained.
What about Shika? Will you be able to tell anything about this?
Yes, ma'am. I would like to just put in a few words. Like my son is turning 18 this year, and he's passed his secondary examination, and he's preparing for his senior and secondary. There are multiple other children in our group who are very actively involved. They are themselves in pursuing senior secondary examination. So I see a lot of children who have different interests, and we need to find out what is the interest of our child. So I do not emphasize academics specifically only, because I just feel a basic education is important. But when in terms of my son, he's very fond of painting. So I am pursuing his career in the form of I want him to be an artist or whatever. He feels like in the field of art. There are some children who are very focused with computers in animation. Then I have one child who's from Pune, and she's very good in quilling art. So this is like she makes greeting cards with quilling. And she's making beautiful cards, which we had distributed to some doctors at a conference as a thank you gesture, which she had made. Then there is a swimmer who's in our group who swims literally the National Olympics of disabled children. So we need to find, and more than that, coming back to academics, there is NIOS, which is the National Institute of Open Schooling. So I just personally also feel that our children are anyways battling so much inside them that the pressure of academics should not be an extra added burden to them, because that would psychologically really, drive them into depression. So as we should take it easy and see the capability of a child. Do not pressurize them. Up to whatever level they can achieve in a normal class, it's fine. Otherwise, we go to an integrated classroom setup. They can always opt for a NIOS syllabus in their school. There are many schools available like that. They have specialized courses which can be taken up, and the children can achieve to some extent academically and professionally.
Yeah, I also feel that putting so much emphasis on academics is not really required. What is more important is to go in for vocational training, so that in future the child will be, the youngster will be self-sufficient. And pursuing interest is a fantastic thing. Wherever he feels good about himself and he's got a talent, that should be nurtured.
Yes. Sure. As a continue to that question, there is a question from Ms. Geeta Sharma. How do you get some kind of employability and insurance for children with PWS? Are there any options, and where should the caregivers go to?
This question is for me.
Yes, ma'am. You or Shikha, you can take this up.
I think there are insurance agents who are now getting these policies for children who have disability, and it is they are doing quite well. I have a couple of references I can share with you later.
Thank you, ma'am.
Ma'am, please do share the references, because this is a continuous struggle which is there in our group as well. For any kind of hospitalization for children with special needs, they are not even getting insurance coverage. This is a battle which is going on in between the government as well as the insurance sector. And it's, there is a court PI there that the children with special genetic disorder are not getting insurance coverage. So even if they are getting into the hospital for a mild infection, they are somehow, if the doctor has mentioned that they are born with a rare genetic condition, the insurance companies are very readily wanting to link the illness with that, so that the insurance coverage is not done. But just 2 days back, we heard a family, and in fact, last few insurance policies have been covered for two, 3 other families that we heard for hospitalization. Child had a surgery because accidentally she picked her skin. There was a needle which she poked into her thigh, which was there for a month, and she didn't realize because of a high pain threshold. But the surgery was done, and the family got insurance coverage because the doctor mentioned that Prader-Willi syndrome is not related to whatever happened. So only in those conditions we get the insurance coverage. But if there is any other hospitalization which is related to Prader-Willi, then the insurance is not given to the families.
Sure, I'll find out and share it with you.
Thank you, ma'am.
Thank you, ma'am. The next question is to Dr. Radha. Will eye surgery correct the squint?
Yes. To me?
Yes, ma'am. To you.
Okay. Most probably, yes. If it is done early, it is useful.
Is there an age limit when it has to be done soon after birth or soon after the onset?
No, it should be done before 5 years.
Before 5 years. Thank you.
But there have been cases where the child is, say, 13, 14 years old, and the surgery has been done to correct the squint. But when the child is little older, then the problem is that some habits are set, like he holds his neck at an angle. So even when the surgery is successful, but he continues to hold his neck in that position. So
yes,
that is
that's the reason why it has to be done below the body.
Next question is to Professor Tony. This question is from Devi Suryanarayana. Hi, sir. If we control on food-seeking behavior in PWS, do they tend to eat non-food material, like in pica disorder, which is usually temporary. And have you noticed any specific food favored behavior more in PWS than in other cases?
I think the answer to that is that we don't see pica in quite the same way as you see it in people with other neurodevelopmental syndromes. You certainly see people with Prader-Willi syndrome who may eat food out of the dustbin or food that's gone off. But I think less commonly do you see people with Prader-Willi syndrome eating things that are clearly non-food items.
Yeah. The next question is to you again. What is vagus nerve stimulation?
Right. Vagus nerve stimulation is something that has been a treatment for epilepsy for many, many years. And it's traditionally done through an implanted device, a bit like a pacemaker that's implanted in the chest with a wire that runs up and is connected to the vagus nerve as it runs through the neck. And the reason we did a trial of that in people with Prader-Willi syndrome is that the vagus nerve is one of the important feedback mechanisms between the gut and the brain. And it's thought to be important as part of this satiety mechanism that we've all talked about. And so 3 people with Prader-Willi syndrome agreed to have one implanted and to try it. What we found is, to our disappointment, it didn't seem to help their eating behavior. But completely to our surprise, we found that for 2 of the 3 people, it transformed their other behaviors, their temper outbursts. And the mothers in both cases said that it just was, they were completely different in a very positive way. Since then, there has been a different type of vagus nerve stimulation that doesn't require surgery. And it's a device that you carry around with you about the size of a mobile phone, with a wire and an electrode in your ear, in your left ear. And you wear it stimulating what's called the auricular branch of the vagus nerve in your left ear, and you wear it just 4 hours a day. And again, we found that that also helped behavior, but after it had to be worn for quite a few months before it had an effect. There will be, I think, further trials needed to see whether vagus nerve stimulation should be approved as a treatment. So at present, it's looking encouraging. And I think the other important thing is it's given us new insights into what causes some of these problems. I hope that answers the question.
Yeah. Thank you, sir. Yes. The next question is to Dr. Safala. Please advise a diet chart for Prader-Willi syndrome children. Ma'am, you're on mute.
Yeah. Yes. See, as I said just now in my talk, it cannot be a one-line statement, describe that or for Prader-Willi syndrome. But the thing is, as I said earlier, when we say carbohydrate composition of the micronutrient, we have to space out from the breakfast, the main meals to be considered, where we are incorporating more of veggies and proteins along with the carbohydrates, so that the satiety will be the main factor which we have to consider, because more of the fats and carbohydrates we consume, then respiratory quotient will increase more than 0.95, and then it goes to adipogenesis. So that's why every recipe, whatever according to their cultural pattern or whatever the family eating style, they have to see that they are including good protein as well as vegetables in any recipes which they have according to their lifestyle, and space out. But night time they should not indulge on more of sweets and hoteling. All these things has to be taken care by the whole family, because skeletal mass has to be seen, that it should not go down, because that is a thing which gives muscle strength. So that has to be taken care with a well-balanced diet, actually.
Okay. Ma'am, may I please request you on behalf of the parents, if you can chalk out a vegetarian as well as a non-vegetarian diet chart, a basic diet chart that they can see. If you give out one, then they will have idea how to change it with their recipes.
Okay, I'll try and give it to, send it to you. Yeah, okay. I'll see how we can connect to it. Definitely,
no,
I'll do.
It's better you give it to Shika. She will put it in her address.
I will connect with her and I will cooperate. Yeah.
Thank you, ma'am. The another question for you is, what is healthy food substitutes that can be given instead of tempting foods? Are there any healthier food substitutes that can be given?
In the sense like healthy means whatever the traditional, I think that is more healthy than the packed and canned processed food what we get outside, because more times because of career orientation or whatever the pattern is, we try for fast foods very easily, ready to eat pat, just heat it and immediately use it, something of that kind also is more we are into this, even normal otherwise also. So we have to see that whatever the traditions are there, we can nicely modify and do something, but basically avoid all refined and processed food. That is what I think, because I cannot explain in one line, so many things, but I'll contact Shikha and I'll give her some guidelines about it for sure.
Thank you, ma'am. The next question is for Dr. Kavita. Why severe obesity and exclusion criteria for GH treatment?
Hello, Dr. Kavita.
Hello.
Hello, Dr. Kavita. Your video and audio both has been put off.
Madam, we have given the request, but Madam is not accepting it.
Yeah.
Let's go to the next question and we can ask afterwards.
Yes. Ma'am, will you be able to take this question? They have asked, can we start growth hormone therapy? If not early, can it be started just before the puberty, like by the age of 9 or 10 years, if they have missed to give it in the early childhood?
Yeah, this can be started. That's what she was telling. This can be started, but only concern is about the dose. So as the child is growing, the requirement for growth hormone increases. So the cost of the treatment goes up.
Thank you, ma'am.
Gayatri, can I ask a question to Dr. Tony?
Sure, ma'am.
Yeah, Dr. Tony, I just would like to know about the recent developments that are occurring in Prader-Willi, especially with regard to the management of the ghrelin responsive patients, as well as the treatment with the N-acetylcysteine in some of the children having skin picking disorders. And then the role of modafinil in sleep disorders. So what are the new developments that are coming up in the management?
Right. I mean, I do think you're right to highlight this, because I think it's an important and exciting time in sort of Prader-Willi syndrome research, if you like. I think, as other speakers have highlighted, one area is, of course, the developments in treating the hyperphagia. And what I think is really interesting about that is the various companies that have developed products to do this. Most of the products are acting on different pathways. So we may find that one product, and for example, some of the products that work on the ghrelin pathway haven't really been successful. But I think at one level that's disappointing, but I don't know if it matters too much, because I think it just may mean that that is not the right pathway to act upon, and that some of the other agents that act on different parts of the pathway are going to be important. It may also, of course, be that you're going to need ultimately a combination of treatments to manage or to control the hyperphagia. So I think that's one really important area. I do think in my own area too, we are beginning to see treatments developing for some of the behavior problems, particularly the temper outbursts, and vagus nerve stimulation is one. There has also been a trial of an SSRI antidepressant that has shown some benefit. But it also highlights a problem, and that is that doing proper conducted trials, placebo blind, double-blind trials, is actually rather difficult, because it's a rare disorder. It's quite difficult always in any one country to identify all the people that you need for such a trial. So I think one of the things we at IPSWO are looking at is how we can bring different countries together so you can more easily get multi-centered international trials. So, I mean, there's also continuing advances in genetics, because I think we don't fully understand the genetics yet. And of course, people are very interested in whether there's any developments in the area of epigenetics, what controls the expression of genes, and whether that might be used in any way to treat or alter the trajectories of children with Prader-Willi syndrome. I'm sure I'll think of other things after the end of this, but there's some examples.
Thank you. Thank you. Thank you.
Professor Tony, this question is to you once again. This is from Keng Beatik. He's asking, have you seen the worsening of behavior with sex hormone replacement?
Right. Again, I think it is a very important question, and something in terms, certainly with boys and the use of testosterone, is asked of us a lot. And the answer is that I think the answer is yes, it has been seen, it has been reported, but that's usually when testosterone has been given at too high a dose or has been increased too quickly. So what I would say is that I would be in general supportive of the idea that sex hormones should be replaced, and in boys it should be testosterone, but it needs to be done carefully and slowly. So you're not exactly mimicking puberty. You're doing it more slowly over time. So you would start at a lower dose, you would increase it more slowly. And if you do that, then my endocrinology friends would say to me, it's okay, you don't get a deterioration in behavior. So that would be, I think, the main advice.
Thank you, sir. The next question is to Dr. Radha Rama ma'am. Ma'am, the parent is asking, because of sleep apnea, growth hormone therapy has been deferred for their child. So how do they go about it?
Yeah, first we have to tackle the sleep apnea. And so they have to see the ENT specialist, as well as the sleep management team. And then if that is controlled, then only one can go with the growth hormone.
Yeah, so this patient has also undergone adenectomy. So like after that, can GH therapy be considered for them?
No, if the sleep apnea is under control, yes, they can go. But sometimes adenoidectomy, it may not help also. So they can have to have other management through the ENT and sleep management. This has to be done.
Thank you, ma'am. The next question is to Ms. Farida. All the learning disabilities that were described, will the patients always have either a single or combination of the perception deficits? Or are there any specific perception deficits that are mostly found in specific learning disabilities? Will that be a combination, or it would come as a single feature?
There will always be a combination. As I said showed in my presentation, there is an overlap. So if a child has, say, reading difficulty, dyslexia, but it will also have difficulty with math, because it is reading. So when he's doing statement sums, that will be difficult for him to understand. So there is always a combination. But when we talk about perceptual issues, then there are very simple exercises, paper pencil exercises, which can be done to overcome those perceptual deficits. And that has a very positive impact on their classroom learning.
Yeah. My next question is to Ms. Shikha. Ma'am, how do you, how many families are registered under IPSA as of now? And what is the youngest and the oldest child that you have in your group?
Yeah.
So we have about 100 families, Indian families, not only in India, but there are families who are connected from abroad as well. And I think the youngest, which must be, we've got somebody from Gujarat recently who's just few months, and the child got diagnosis at a very early stage because both the parents are doctors. The entire family is the first patient from Gujarat that we got. From the entire state, that's the only patient that has come up. And with all the medical conferences that we go, we come across a lot of doctors from Baroda and different parts of Gujarat, but they've never got back to us. In fact, very couple of years back, we read a news which was published in a newspaper in London. It spoke about an obese child from Gujarat, some village of Gujarat, and there was an article about it. But when we tried to reach that village, we got to know that there was no means of communication there. So we don't know what exactly happened to that child. And the oldest is in 20s. Yes, she's a girl who is in, and she got interested in animation. She's again, her grandparents are doctors.
Yeah. So I have one girl who is now aged about 19 or 20 years.
Yes, 19, 20 is still very, we have a lot of children now that are 19, 20 in our group, but this one is in her late 20s. Late 20s or 50s. I'm not very sure about her age right now, exact age.
The other question is, in which all cities do you have the ITSA members who can be approached?
So all the 4 zones have Calcutta, of course, I'm there. In Bombay, we have a representative. We can be reached now, with social media and WhatsApp. Everybody can be reached. Plus, we always target to reach the 4 zones. Bangalore, we have very active members. Then Delhi, we have, and Ludhiana, Mr. Rohit and Mr. Anil Chaubey are North-based. So they are there in Delhi and Ludhiana. East, I'm there. And Bombay and Pune, we have some volunteers as well.
Okay. So this question is for you as well as for the for other members who will be able to take this up. Like you mentioned, on compassionate grant basis, you are able to give growth hormone therapy in Kolkata in few centers. So is there any similar leads for the South? Like in we do have Arogyasri facilities in Hyderabad and few regions of Karnataka. So are there any leads where the parents can approach for free growth hormone therapy?
So in Karnataka, there is ORDI, the Organization of Rare Disease India. Somehow they try to help the patients, but no, nothing from the government side as of now. And that is the only reason where we emphasize that we need a patient database. And, there has to be a weightage when we are approaching the government. So for this, we need the doctors as well as the families to come forward, connect with us so that we can regularly shoot mails to the, the government and do something about it.
I think the government has started some 7 centers of excellence for rare diseases. And one of the centers is in Hyderabad. So probably if a child requires growth hormone, they should apply to CDFD, Center for DNA Fingerprinting and Diagnostics. And this is for the help from the government through the rare disease policy. So the Hyderabad center is CDF.
Thank you, ma'am. Dr. Kavita, have you joined?
Yes.
Yeah.
Yes, I have.
Yeah.
I have.
Yeah. So
this is me.
The question is, growth hormone therapy, is it for lifetime, or when do they stop giving the therapy?
Usually after epiphyseal fusion, there is something called epiphysis, growth plates. So till that is closed, it's continued. Some individuals do require it later on also. But when they're adult, we tend to retest. We tend to test for growth hormone deficiency in adults and then start.
Okay. And how do you screen for adrenal insufficiency in PWS?
In PWS, we ask for history of any nausea, vomiting, feeling pukish. We look at the blood pressure to see if the child is hypotensive. And we do what is called as an ACTH stimulation test. If we do the baseline cortisol, 8 AM cortisol. Cortisol is a steroid which we all produce. We first screen for 8 AM cortisol. If the 8 AM cortisol is normal, we don't generally proceed. If it's in the upper half of the range of normal, then the child does not have adrenal insufficiency. If it's low normal, then we may want to do what is called as an ACTH stimulation test.
Yeah. The next question is to you again. Do you monitor insulin resistance based on HOMA-I values?
Not really, no. That is not, currently it's not it's only used in research settings. So in fact, in Prader-Willi, they're exquisitely sensitive to insulin.
Thank you, ma'am. One more question to you. Please tell about onset of periods in girls with PWS.
Some children do get their periods. But it could be sometimes irregular because the cycles could be anovulatory and it could stop quickly. Many of them have hypogonadism, meaning the pituitary gland doesn't produce enough of the hormones which is responsible for growth of the ovaries, which in turn produces estrogen. Or if it is, it may stop working very, very early. So what you get is a pubertal arrest. Children may show signs of puberty, but it may not progress on to periods. So that is about PWS children. A very small percentage can have spontaneous periods.
There is another question. Dr. Radha or Dr. Kavita, both of you may take this up. That is, if there is a finding of IUGR or polyhydramnios, would you suggest screening for Prader-Willi syndrome in prenatal setting?
IUGR and polyhydramnios, not necessarily. But if there is history of reduced fetal movements, or there are some forms of PWS which recur, it depends upon the genetic form, we may want to do a prenatal screening.
It's a very difficult question because large number of cases we do see IUGR as well as, and every case we cannot go and do a prenatal test.
Yeah.
It is very expensive unless if the parents are very specific about it.
Thank you, ma'am. Yes, with this we'll come to the end of the workshop. I thank all the speakers, all the panelists and the chair people for coming and gracing this occasion. I thank all the delegates, all our participants for their patient hearing. And I invite one and all for our next session at 5 o'clock, choosing the right test. My colleagues, Dr. Indumati and Brinda Ramanathan, will be moderating the session. Thank you, everyone.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you.
and good evening, everyone. I hope everyone is doing safe and vaccinated against COVID-19. After an interesting workshop on Prader-Willi syndrome, on behalf of BGCI, we moderators Dr. Sailesh Kumar with Ms. Brinda and I, Dr. Indumati, glad to welcome you all for the 6th annual e-conference session 1, Choosing the Right Test. Genetic testing is an integral part in genetic counseling for appropriate diagnosis, which helps in risk estimation, prevention, and management. Advances in next generation sequencing technologies have opened up wide testing options. So choosing the right test amongst is challenging and most important for better patient care. We have eminent speakers to share their expertise on the same. It's our immense pleasure to introduce and welcome our chairs, Professor Julian Barwell and Dr. Kumar Manikavel this evening. Professor Julian is a clinical geneticist and honorary professor in genomic medicine at the University Hospital of Leicester, UK. He got his training in medicine at Guy's and St. Thomas Hospitals in London. His doctoral degree was on familial breast cancer susceptibility. He has about 59 peer-reviewed publications in international journals. He helped in coining the internationally known phrase, the Angelina Jolie effect, on reference to inherited breast cancer, and published how high celebrity profile can have impact on cancer-related services. He also helped in launching Cancer Genomics branch of the UK-based 100,000 Genome Project on BBC's Breakfast Sofa. His interests are clinical genetics, genomic medicine, cancer genomics, especially breast cancer. Professor is a very passionate cricketer too. It is an honor to have you on our board, sir. I over this platform to Ms. Brinda to introduce our next chair, Dr. Kumar Manikvel.
Thank you, Dr. Indumati. It is indeed a pleasure of mine to be able to introduce Dr. Kumar Manikavel. So, Professor Kumar Manikavel is a research director at two premier ophthalmic institutions of India, Narayana Nethralaya, Bangalore, and Aditya Jyoth Eye Hospitals, Mumbai. He is a medical director, counseling in medical genetics at Jain Vamsalaya, Jain Vams Trust, Chennai. He has his MD in physiology from the University of Madras. He's been trained in ophthalmic genetics by Dr. James Fielding, USA, and by Dr. Robert F. Mueller in genetic counseling, New Zealand. With more than 123 papers to his credit, which include 90 peer-reviewed publications and 5 books. His area of interests include ocular genomics, epidemiological research in ophthalmology, gene mapping, and genetic counseling. With more than 10,000 patients counseled so far, he is involved in 2 major epidemiological and genetic projects comprising of 20,000 subjects at Shankar Nethralaya, Chennai. He's also been involved in genetic counseling of patients with inherited eye diseases and has immense experience in bringing bedside to bench to bedside practice. He is also MSc and a PhD guide for aspiring students and a visiting faculty at national and international universities. Indeed, a pleasure to have you with us, sir. Over to you.
Thank you very much for the very kind introduction today, and welcome to everybody. I am in Leicester today in the United Kingdom, the home of David Gower, the cricketer. We're great fans of cricket here in the UK and look forward to the latest series with India in the weeks ahead. They're the home of DNA fingerprinting as well, where the ability to identify individuals was first discovered and useful for paternity testing and in forensic medicine. And similar technologies were useful in finding a king that was buried in Leicester several hundreds of years ago and was found recently under a car park, King Richard III, through his mitochondrial DNA and one of his living relatives. So it's a really exciting session that we have planned. We're starting today with a recorded talk by Dr. Brian Honying Chung. I'm delighted to say that he is from the University of Hong Kong at Queen Mary's Hospital, where actually I spent some time in 1997, where he has his MD in medicine and clinical genetics. He's a fellow in clinical genetics in Canada and has 50 peer-reviewed publications with interests in clinical applications of whole genome technologies, clinical genetics, genetic counseling, epigenetics, and human diseases. He won the Faculty Teaching Medal in 2018, Loyalty Award to Queen Mary's Hospital in Hong Kong, the Silver Medal in Academy of Medicine, and one of the top 4 submissions at the Canadian College of Medical Genetics. He's currently a clinical associate professor in pediatrics and adolescent medicine and a consultant in clinical genetics and in pediatric service. And we're very delighted to hear what he has to say today on choosing the right test. And now we're ready for his talk.
Hello, this is Dr. Brian Chung from the University of Hong Kong and the Hong Kong Genome Institute. I would like to start by thanking the organizing committee for inviting me to give a talk on choosing the right test, and I will focus on whole genome and whole exome sequencing. In 2020, a very interesting review was published to celebrate the 150 years anniversary of the journal Nature. It talks about the brief history of human disease genetics. Progress has been made in identifying DNA variants, and it is made possible by 4 main progresses. First, advances in technologies, genomic resources and database, analytic tools, and access to data. It leads to improvement in the understanding of both rare and common diseases. And many of these testing is now on clinical implementation, paving the path of personalized medicine. From the year 2000 to 2018, there is a 4-fold increase in gene discovery. And these are the key landmarks that demarcates this period of improvement in gene discovery. It includes completion of the draft of the human genome sequence and the implementation of clinical microarray testing, next generation sequencing, and the use of exome sequencing and genome sequencing in the clinical context. Now we understand the difference between genetics and genomics. Genetics is the studies of genes and their roles in inheritance and their effect. And the main focus include monogenic or Mendelian disorders that are very well known, such as cystic fibrosis, Huntington's disease, and PKU. Whereas for genomics is the study of all the genes of a person, and it includes the studies of the interactions between genes and the environment. So the new discipline called genomic medicine is an emerging discipline that involves using genomic information about an individual as part of their clinical care and health outcomes and policy implications of that clinical use. It is very common now in genetics and genomics clinic that the clinicians and the families will be discussing the use of different genetic testing, including next generation sequencing, whether we are choosing gene panel or exome sequencing or genome sequencing for our patients and families. The difference between genetic test and genomic test is very easy to understand if we understand the difference between genetics and genomics. Sanger sequencing is a classical example of a genetic test, whereas all forms of next generation sequencing is the representation of genomic testing. For the purpose of this talk, I'm not going to go into the biochemistry and the science of Sanger or next generation sequencing, but to talk more about why in some situation whole genome sequencing and whole exome sequencing may be beneficial. These are second generation sequencing or next generation sequencing techniques. The advantages include high diagnostic yield. It has a wider coverage, and it can lead to possible gene discovery. And of course, the data would be more difficult to interpret, there are more uncertainties, and the test itself is more costly. Exome constitutes 1% of the whole genome. So for exome sequencing, we focus on the protein coding regions of our genome. We can identify variants within the protein coding regions, and mainly we focus on single nucleotide variations. An exome has a limited capacity in detecting copy number variations and structural variations. Whereas for whole genome sequencing, it involves sequencing the entire genome, both the coding and the non-coding part. For the types of variants being detected, it includes SNVs, as well as copy number variations and structural variants. In considering our diagnostic strategy, we have to think about what is the characteristics of the conditions that we are investigating for our patient. If it is specific and is known to involve only single gene, then single gene testing may be more appropriate. For example, if clinically a patient has the diagnosis of cystic fibrosis, of course the right test to order is the single gene testing for CF. CFTR gene sequencing will be the appropriate choice. However, when phenotypically we are dealing with non-specific conditions or conditions that is known to have high genetic heterogeneity, more and more we should consider the gene panel as well as exome sequencing or whole genome sequencing. The most extreme form of non-specific features would be those patients that have undiagnosed disease. So conditions we may not be able, or symptoms and signs of the patients may not allow us to put the patients in a certain diagnostic bucket. Then the use of exome or genome sequencing would be very helpful. What about the diagnostic yield of exome and genome? It is now known that for exome sequencing, the diagnostic yield range from around 25 to 40%. Trio-based exome sequencing has proven to have a higher diagnostic yield than singleton exome sequencing. And theoretically, whole genome sequencing should have an advantage over exome sequencing in achieving a higher diagnostic yield, because it also looks into the non-coding region and it can detect copy number variations and structural variations better than exome sequencing. But it's context specific, and notice that this figure is obtained from a publication in 2018. Nowadays, we have more understanding of the use of whole genome sequencing and their availability of more tools, in particular bioinformatics tools that allow the investigations of the genome better compared to a few years ago. So I'm using my own projects as an example. So this is the whole exome sequencing project done in the Department of Pediatrics and Adolescent Medicine in the University of Hong Kong. Up to date, we have more than 1,200 participants. As you can see, the diagnostic yield of exome sequencing varies in different disease categories. For example, for undiagnosed disease highlighted here, our initial diagnostic yield is around 40%. When we reanalyze the data 3 years after the initial analysis, we increase the overall diagnostic yield to around 50%. Rapid exome sequencing is being offered to patients in the intensive care, for example, the NICU and the PICU, and the diagnostic yield is around 30%. And you can see among the different disease conditions, the diagnostic yield of exome sequencing varies a lot. When we receive a genome or an exome report, typically, what does it tell us? First of all, most importantly, is the primary findings. Primary findings are the molecular findings that may explain the reason of referral for doing the genomic testing. If you followed the American College of Medical Genetics and Genomics, their guidelines put variants into 5 categories: benign, likely benign, which overall we would call them a negative finding, so no changes were found that are known to cause or contribute to the patient's disease. It could be positive, which in the ACMG guidelines are those likely pathogenic or pathogenic mutation. We have found a cause that might explain the patient's disease. And of course, we have a big category called variant of unknown significance. Right? These kind of changes were found, but there is not enough information available to determine the meaning of the change. Besides primary findings, there are also secondary findings or incidental findings. This is quite different from the single gene testing that we are more familiar with, because we are looking into all the protein coding part of a genome in exome sequencing, and in fact the whole genome when we are doing genome sequencing. We may be able to discover some results by chance that is totally not related to the patient's symptoms, but still could have implication for his or her own health. A lot of caution has to be exercised in the evaluation of these incidental molecular findings. Let me give you a case example. So this is an 8-year-old boy referred from our child neurologist for genetic evaluation. The core features include microcephaly, global developmental delay, and importantly, generalized dystonia. We have done a lot of investigation in our hospital, including blood tests, urine tests, and CSF tests, covering neurometabolic and neurotransmitter investigation, and they're all normal. MRI imaging is normal as well. Physical examination confirmed the finding of microcephaly as well as generalized dystonia, with lower limb more involved than upper limb, and there are multiple dysmorphic features noticed. All in all, clinically, with the physical examination and all the investigation, this remained to be an undiagnosed case. Trio-based exome sequencing was arranged, and these are the findings. For the primary finding, one pathogenic variant was identified, and it is in the CT-NNB1 gene. It is de novo, that means it's not inherited from the parents, and there is an OMIM condition called CT-NNB1 syndrome that has been described in patients carrying mutations of this gene, and it is characterized by intellectual disability, hypotonia, microcephaly, visual problem, and seizure. Quite compatible with the initial reason for referral for genetic evaluation. There is also secondary findings that is unrelated to the clinical symptoms, and the mutation is found in the collagen 1A1 gene, which is associated with a skeletal dysplasia called osteogenesis imperfecta. Again, this is de novo, not inherited from parents. So looking first at the primary finding, as I have already reported to you, the patient's clinical presentation is quite compatible with patients reported to have CT-NNB1 syndrome. So we have already made the diagnosis for this case. And interestingly, the multiple case reports actually suggest some new directions of treatment, especially towards the generalized dystonia of the patient. Multiple case reports have explained and have shown that the use of L-DOPA as a treatment is effective for the management of dystonia in these patients with CT-NNB1 syndrome. So this information was promptly communicated to the neurologist who referred this patient, both for the diagnosis and for the management option. And when we go through the literature, one common features of CT-NNB1 syndrome is visual impairment. We clarified with the parents at this stage there is no visual impairment, but we have, for safety reasons, still referred the child to be evaluated by our ophthalmologist. What about the secondary findings? It's actually very interesting when we noted that a collagen 1A1 variant has been identified. On further examination and history taking, the parents actually volunteered there was an interesting history of femur fracture for one time due to a small impact car accident. When we evaluate the child clinically, his teeth were normal and there were no bone deformity, but we did see the presence of blue sclera, which is a characteristic sign of osteogenesis imperfecta. So clinically we conclude that this patient has mild OI, and we referred the child for multidisciplinary care in our skeletal dysplasia clinic run by our orthopedic surgeons and our endocrinologist. So this is the secondary findings. Previously, secondary findings are called incidental findings. These are genetic variants found incidentally or accidentally in the process of a genome analysis. It is now revised to you, and we use the terminology of secondary findings because these genes are now intentionally being analyzed according to international recommendations. Showing you here is the ACMG statements that includes 59 medically actionable genes. Earlier this year, actually this gene list has been modified. And when we look into the gene list, it actually does not include collagen 1A1. So should this still be considered as secondary findings? Or it should be considered as dual diagnosis? Although classical medical teaching said that one man, one disease, now in genetics we have proven beyond doubt that this is not the case. One man sometimes have two or more diseases. For some symptoms, it might be explained by disease 1 caused by mutation in gene 1 or gene A, while the other symptoms may be explainable by mutation in another gene, gene B here. So the condition or the situation that we are seeing in this case is really not an incidental finding because it's not in any incidental finding or medically actionable gene list according to guidelines. But this is more one man, two disease, or what we call dual diagnosis. So this child have symptoms and signs that could be explainable by the combinations of the effect of mutations in both CTNNB1 and collagen 1A1. So I hope that using this case example, you see how does genome sequencing affect genetic counseling in the genomic era. First of all, we are able to provide more help in ending the diagnostic odysseys. So you can see that in the case example, the neurologist has done batteries of investigations but yield no results able to help with the diagnosis. Also, it enhanced personalized treatment. For example, in this child, because we know the molecular diagnosis, L-DOPA has now been started to deal with the dystonia because medical literature has shown its effectiveness in the control of dystonia in children with CTNNB1 syndrome. Because of the diagnosis of CTNNB1 related syndrome as an osteogenesis imperfecta, now the child is under multidisciplinary management. Initially, he was seen just by child neurologists, but now he is also seen by ophthalmologists, as well as in the bone clinic, which is run by our endocrinologist and our orthopedic surgeon. Of course, we can provide more information for family and reproductive planning because both mutations are known to be de novo. Therefore, there is a low recurrent risk for the parents, and testing of siblings is not necessary. And of course, it helps to provide more information for the psychosocial care of the patients and their parents, because now we were able to end the diagnostic odysseys. And it provides a lot of information about how we should take care of the other family members, given the positive genetic finding. As you can see, genomic sequencing or exome sequencing is being now used a lot in rare genetic disease contexts. So showing you this graph predicts the use of genomics in healthcare. Notice we are talking about clinical care, not research. So the Global Alliance for Genomics and Health looks into the situation beyond 2020 up to the year 2030. So as you can see, they predict that there is an increase in use in genomic sequencing or exome sequencing in healthcare. It is increasing for rare genetic disease, but you can see here to this time of the year, we are now in 2021. What you can see here is an even steeper increase in the use and the applications of genomic sequencing in the care of cancer patients. So this is one of such genomic program being applied to patients with cancer. So this is the Australian Zero Childhood Cancer Project. So it recruits patients younger than 21 years of age who has high risk or relapsing cancers with a survival chance of less than 30%. So they take in patients at primary diagnosis, if the cancer relapse or when there is progression, and it includes all kinds of cancer from leukemia, lymphoma, blood cancer, hemic malignancies to solid tumors involving the CNS and sarcoma and neuroblastoma. In the year 2017, they have recruited 400 children, and they collect DNA samples both from the germline and the tumors. And besides whole genome sequencing, there is a batteries of omic testing that is being applied to these patients. So this is the workflow of the Zero Childhood Cancer projects. The key characteristics of this project is the real-time recruitment and the real-time feedback of the results. So the feedback of the results to the patients and the clinicians occurred in stage so as to inform the clinical care of these patients and to make sure that the genomic information will reach the point of care for an effective management of our patients. So this is one example, Thomas, that you can find from their webpage. With the diagnosis of brain tumors and joining this genomic program, they were able to find an EGFR mutations in the cancer samples, and that allows target therapy using tyrosine kinase inhibitors, and it helps to control the brain tumor, resulting in shrinkage in size of the tumors. Just like Thomas, many patients, up to 70% of the patients, have complete or partial response, or their cancers actually get stabilized. It is made possible because of the personalized treatment recommendation, returning to the clinicians and families in a reasonable turnaround time of 9 weeks. And this not just help to make the diagnosis, but informed management of these patients with cancers. So we should look out for more applications in the different field in clinical medicine. Besides rare disease, cancer will be the next that is expected to rise significantly. So this is a diagram depicting the situation in 2017. And as you can see, genomics enters healthcare already in the United States, in Australia, in Finland, and in UK. They have their own national genome projects. What about the situation right now in 2021? So this is a summary that I have made earlier this year, together with some colleagues trying to summarize the different national genome projects that are occurring around the world. And you can see that a lot of country has now already embarked in the journey of genomic projects and see how genome sequencing may help the development of genomic medicine in their country. I'm from Hong Kong, and I'm very pleased to let you know that Hong Kong also have a Hong Kong Genome Projects. So this was actually made into the policy by the chief executive in 2017. So at that time, a steering committee was formed to lead the development of genomic medicine in Hong Kong. And amongst the 8 recommendations proposed by the committee, Hong Kong Genome Project is actually the flagship projects. That is the projects that we use to catalyze the development of genomic medicine in Hong Kong. So the objectives is really to enhance clinical application as well as promote research on genomic medicine. And these would be achieved through the establishment of a genome database, infrastructure and protocol for genetic and genomic testing. And of course, we would nurture a pool of talents, expertise and professionals for establishing and improving the development of genomic medicine in Hong Kong. So we hope that we would have a single database which link phenotype and genotypic data together that encourage collaboration. In order to do that, we need to standardize the data format and standards, and we have to have vigorous data security and privacy protection regimen. We are going to standardize our analytic pipeline and our protocol from the stage of informed consent taking to the analysis and the result feedback to the patients and the family. And hopefully, we would be able to equip existing healthcare professionals with the new skills and competence for genomic medicine, and we will attract young people, new talents to develop into the different professionals that is needed for genomic medicine, including genetic counselors and bioinformaticians. I'm going into the summary part of my talk. As you can see, genetic counseling in the genomic era is now being very complex. We have broader testing approach from single gene to whole genome sequencing. And it involves very complex information with the different types of information provided in different clinical settings, from predictive to diagnostic to pharmacogenetic testing, and sometimes even in direct-to-consumer perspective. There would be increasing number of results that need to be disclosed. Sometimes they're positive, sometimes they're negative, sometimes it involves variant of unknown significance or even secondary findings. And it creates more issues with regards to the ethical, psychological, and social dimensions. So the Stanford group reported in 2010 some of the potential challenges in the clinical application of whole genome sequencing. First of all, the results become very complex. It's very difficult to explain to the families and patients. And the genetic counselors and geneticists will have to understand the limitations of genome sequencing. In other words, what could be diagnosed by whole genome sequencing, what could not. There needs to be accessible and well-curated database so that we can have an efficient search of information. And then there needs to be newer strategies to deal with uncertainties, in particular the variant of unknown significance. Obviously, it involves a lot of training of the healthcare professionals, and there must be way so that we can revisit issues pertinent to whole genome sequencing and genomic medicine so that we can incorporate new knowledge, new information into our clinical practice. Looking into 2030, we expect that the general public will have access to the digitalized whole genome sequencing anytime, any place, on any device. So as a profession working in genomic medicine, clinical geneticist and genetic counselor has to get prepared for this possible change in the future. Thank you very much for your attention. Lastly, I would like to thank the two excellent teams that I have the opportunity to work with. One is the genetic and genomic team in the Department of Pediatrics and Adolescent Medicine in the University of Hong Kong. The other is, of course, the Hong Kong Genome Institute, which is recently established to carry out the flagship project of Hong Kong Genome Project. Thank you very much for your attention. I hope you liked the talk. Goodbye.
Now, can I request Dr. Kumara Manikvel sir to introduce our next speaker, Dr. Dhanalakshmi.
Actually, there are two questions that Dr. Moses has asked. Maybe.
So we'll take the questions at the end of the sessions.
All right.
Thank you, sir.
Thank you. So I'm Dr. Kumar here, and I have a great pleasure in joining this session. And thanks to the organizers. And the next speaker is Dr. Dhanalakshmi. She earned her doctorate in applied biology from Mumbai University. She also got her postgraduate diploma in hospital management and medical legal system. She's a certified associate genetic counselor by the Board of Genetic Counseling of India, and a registered clinical laboratory geneticist, and also in the European Board of Medical Genetics. She's currently working as a scientific officer officer in charge at the Department of Cancer Cytogenetics at ACTREC, Tata Memorial Center, Mumbai. She has more than a decade of experience in the field of cancer genetics, pre- and postnatal cytogenetics, and human genetics. She has some executive positions as a cytogeneticist in INCA's IVF Center, section head at the Department of Genetics, Metropolis Healthcare Private Limited, senior cytogeneticist at SRL Diagnostic Private Limited, and executive director in cytogenetics of iGenetic Diagnostics. And Dr. Indumati is going to speak in this session. Dr. Indumati.
Thank you so much, sir, for this kind words and a kind introduction. I will just share my screen. I would like to thank the Board of Genetic Counseling India for giving me this opportunity to be a part of this eminent speakers and chairpersons present in this session. I also would like to thank the President, BGCI, Dr. Annie Hassan, and the organizing team, Dr. Pruchi Madan, Dr. Jaya Vyas, and the moderators for this session today, Dr. Indumati, Dr. Sailesh, and Dr. Brinda. Today I have been given this topic, conventional cytogenetics, can it survive in the modern genomic era? So let's see. So looking at the history, we all have seen the various landmarks, events way back 100 years before, several years before, Charles Darwin. We know the important events that have happened over the time in the history of human genetics. Charles Darwin, we know about Mendel, who has introduced the fundamental laws of inheritance way back in 1865. We also know about the word chromosome coined by Valdier. Also, in 1956, it was Levin and Tijoux who reported that the chromosome number was 46 and not 48. Later, we had the development of molecular techniques in way back. Even Lejeune actually described Down syndrome, and later on, we all know Janet Rowley way back in 1972 discovered that many of these leukemias are because of chromosomal translocation, and she was the first to discover the 922 translocation in CML patients. And from so many years till now, we have been progressed over so many techniques that have come, and some have vanished, some have sustained over the period of time, and we have also completed the Human Genome Project, and we have had several different techniques with higher specificity, sensitivity come in the latest times. So talking about karyotype, it's one of the very old technique and which can detect both numerical and structural numerical abnormalities. And so I would like to just let you go through and tell you, will a technique as ancient as this pull through? I feel that yes, it can. Let's see how. The utility of chromosome analysis in clinical genetics. We all know that the well-known or the common genetic syndromes, it can be, useful in those. Sex chromosomal abnormalities, in recurrent spontaneous abortions, the pregnancy losses, bad obstetric history, product of conceptions, and also in the prenatal setup. So let us see. The known clinical syndromes. We all know the genotype and phenotype are well established in such clinical syndromes. For example, an index case presents with clinical features of Down syndrome, and this is the most common syndrome, and we know that this, karyotype will be done for it, and the Down syndrome could be because of the free trisomy 21, or it could be a Robertsonian translocation, okay, also because of a mosaic trisomy 21. So these are the images which really, these are the trisomy, free trisomy 21 is the most common, followed obviously by the Robertsonian translocation, which is usually inherited by a parent who's a carrier of this Robertsonian translocation, and also the 21-21 translocation, which is could be very, very detrimental, and in such cases the parental karyotype becomes very, very important. So such simple chromosomal abnormalities which can be directly seen in a karyotype, and also when there are multiple congenital anomalies in neonates, where we straight away can straight away confirm whether by the clinical features, whether it is a suspected trisomy of a 13 Patau or an Edward trisomy 18. Do you still think you can opt for or prefer another test instead of a karyotype? This is something that we need to talk. Sex chromosomal abnormalities, again, about Klinefelter syndrome and the various variants of Klinefelter syndrome. A simple karyotype would tell you that it's an XXY, or if there are multiple other X chromosomes involved. Here we all know this could be due to the errors in the mitotic errors, which could be 1, or it could be in mitosis 2. And also because of which they could get abnormal trisomies or monosomies. Turner syndrome. We know that the classical Turner syndrome is a loss of the X chromosome. So this is a monosomy X chromosome. There could be mosaic Turner syndrome, which could be due to a mosaic cell line with any of the variant other abnormalities. That could be a ring chromosome, or it could be a 46XY, or it could be all the metaphases showing an isochromosome. It could be deletions of either a P arm or a Q arm of the X chromosome. It could be inversions in the X chromosome, isodicentric, etc. So here the phenotypes just gives you an indication that this child or this girl who's come could be a Turner syndrome, and a simple test like karyotype would confirm the diagnosis. The XYY, again, where these kids have hyperactivity and they are quite destructive. So not only the phenotype, but phenotype could be just mild, dull, normal a kid. However, there are behavioral patterns that is very important to be picked up by either the pediatrician, or also if the child is presented to a genetic counselor to understand what are the features, not only phenotype but also the behavioral patterns. And a simple karyotype can confirm whether it is has any chromosomal abnormality. Similarly, XXX syndrome again can be picked up. In cases of amenorrhea, primary, secondary, with females who have ovarian dysgenesis or POF, here we have seen there are several sex autosome translocations that have been identified in several publications that are reported in literature. And these become very important. Now, if the female does have these abnormalities, the breakpoints become very, very crucial here. There could be genes which are disrupted or lost due to this balanced translocation, which need to be further looked upon and see whether which kind of genes are present, or any mutations or any losses of such. So a karyotype becomes very, very important here. Here again, autosomal translocation is also important. This is a female who came to us with history of primary amenorrhea. Both ovaries were absent and the uterus was hypoplastic. The karyotype was showing a Robertsonian translocation, a double dosage of 1421. This could be probably because both her parents could be carriers of this Robertsonian translocation. Coming to recurrent spontaneous abortions, we know that couples with balanced translocations have a high risk of miscarriage, or a child born with an unbalanced derivative chromosome. That is because they have a balanced translocation. Therefore, there are higher chances that they have or give unbalanced chromosomal derivative to their child. So this is an example of an 4/8 translocation in a female or the wife who had come to us, where she had recurrent abortions, and we should be doing a karyotype because this is a balanced translocation, and we all know that such balanced translocation do give us various different patterns of derivative chromosomes. So unbalanced chromosomal derivatives in the children, which probably may not survive, or if survive, they will have multiple abnormalities. They would have mental defects or intellectual disability. They could have birth defects and several other issues. Coming to bad obstetric history, we know stillbirth. There are cases of neonatal death and congenital anomalies in a family with bad obstetric history, especially when the parents are carriers of balanced translocation. For example, here that I show that there is a 6/12 translocation seen in the father, wherein this child which had come to us has an unbalanced 6 chromosome, a chromosome 6, where there is a loss of chromosome 6, whereas there is a gain of an extra part of chromosome 12. So this is the derivative 6 or abnormal 6 from the father that he has inherited. So it is an inheritance of the derivative chromosome from one of the abnormal balanced father. Coming to product of conceptions, we are all aware, and we have read so much, and in the cytogenetic lab, everyone has seen there are many abortions in the first trimesters that are seen due to chromosomal abnormalities. Now, these could be because of triploides, tetraploides, which could be de novo, or they could be inherited derivative chromosomes, as I explained, which could cause an abortion. And this is because the fetus is not fit to survive, right? And the triploides are obviously caused because of, digenic or diandric fertilization. The images are representative images wherein you can see that there is fetal growth retardation in digenic or maternally derived triploidy. And this triploidy usually occurs approximately in 2% of the conceptus. Well, you know, we have been hearing karyotyping is a gold standard over years and still now, but in the prenatal setup, yes, it still survives. Okay, because when you know that there is we already have a sonography or a high risk pregnancy that is going on, and a sonography is suggestive of a fetal anomaly, we would go in for an amniotic fluid or a CVS and do a karyotyping. Yes, chromosomal, numerical and structural would be detected by karyotype. However, you know, the guidelines now say that a CMA is recommended, but depending on the abnormalities that you would suspect, we could go in for the higher technologies. And though these other newer technologies and molecular technologies are far more expensive, here genetic counseling plays very, very important role. When you get such abnormalities, we need to counsel the patient well, and we should know which technique would pick up which kind of abnormalities. For simple, you know, if ultrasonography is suspecting like a Down syndrome, then we could just go for a karyotyping. The utility of chromosomes in hematological malignancies. We know that a karyotype gives a wide, picture of the entire genome at one go, and is an adjunct diagnostic tool. Clonal chromosomal abnormalities can be detected. It also aids in diagnosis and classification of the malignancy. It predicts treatment, response, and clinical outcome, helping in risk stratification of the patient. It's an independent prognostic indicator. The variants undetected by interface FISH or RT-PCR also are covered when you look at the whole genome picture. Novel recurring chromosomal abnormalities also can be discovered, and therefore karyotype is valuable also for monitoring post bone marrow transplant patients, and also to check their disease status. Coming to how we all know that complex karyotype is one of the most important to pick up in a karyotype, especially in AML cases. This is a poor prognostic indicator, and detecting such complex karyotypes which have more than 3 aberrations become very, very crucial, especially in hemat malignancies. Here you can see there are multiple abnormalities. X11 translocation is there. Also the 3-5 translocation is detected.
You have 5 more minutes, Dr. Dhanlakshmi.
Monosomal karyotype is defined as the presence of at least 2 autosomal monosomies or 1 autosomal monosomy along with 1 structural rearrangement. And this again is worse than the complex karyotype. So detecting this again becomes very, very important. And the karyotype very simply, a cytogeneticist can be able to pick this abnormality. So this is an example of clonal abnormalities. So we all know that hemat abnormalities are clonal. So getting clones, different clones become very, very important. Detecting such clone is impossible by higher techniques, where in karyotype we can say that there is a clone which has 821 translocation along with a clone which has loss of the sex chromosome and the 821 translocation, and in the same patient we have a third clone which is loss of X chromosome, a gain of chromosome 4, which is trisomy 4, along with the 821 translocation. Now this is an indication of disease progression. So this is possible, and it's very simply detected by a karyotype. Cytogenetics or karyotyping also confirms diagnosis. If there are differential diagnosis versus when there is CML-CP versus CMPD, when you get a 922 translocation, it confirms it's CML, and therefore this becomes very, very important even after a flow cytometry or immunophenotyping is done. Here also very, very important phenomena when in the ploidy analysis in BLL patients, we do get the ploidy analysis becomes very, very important, because if it is a hypodiploid clone, it shows its poor prognosis, and when it is hyper diploid, it is a good prognostic marker. So when such cases have to be detected, therefore it is possible that the clones are there, the hypoclone is there, and these hypoclones are duplicated or endo-reduplicated, and it gives us a picture of hyperdiploidy. So we need to, and karyotype helps us to get different clones of hypodiploid as well as hyperdiploid, indicating it is a endo-reduplication case, and this could be a poor prognosis. Different structural abnormalities can be very, very easily detected. The homogeneously stained regions can be detected very easily in karyotyping. The isochromosomes, the duplications of the iso-PH or any isochromosome, for instance, 17q isochromosome or the 7q here shown. The ring chromosome can be detected. Double minutes, again, in hemat become very, very important, to which could be, indicative of disease progression. So this slide just tells you that how important cytogenetics, cytogenetic alterations are for prognosis, and this is obviously is very, very, it's incorporated in the WHO 2016 classification to detect abnormalities in AML. AML with additional abnormalities, especially in follow-up, is again important. Here we had a patient just with A21 translocation and a trisomy 4 at diagnosis, and at follow-up we also got an additional 212 translocation, and once the patient was diagnosed with this additional abnormalities, soon the patient disease. So the disease progression can be very well picked up by karyotyping.
You have a minute.
Yes. Also, this is a CAP guideline, and also the ASH, which tells you that the karyotype cannot be replaced by FISH or any other molecular technique. So this is just a slide telling you that yes, karyotype is there very much present. And this is an article which just tells you there is very clearly tells you in a molecular technique or the CMA and the WGS, we just find out that there is a terminal deletion of the 15q chromosome, but this could be due to various different reasons. This could be because of a terminal deletion, this could be because of an interstitial deletion, this could be because of a ring chromosome or an unbalanced translocation of 15 with another chromosome. So this is very, very essential, because this is important for recurrence risk and genetic counseling. So why a karyotype? We know the World Bank has classified India as a lower middle income country. Now in India, there is no centralized healthcare system, and we heavily rely on economical diagnostic tests. And therefore, I think karyotype is very economical and gives you a good picture of many of the abnormalities. The advantages is the full genome picture. It identifies multiple clones, additional abnormalities, is easily available in many of the laboratories in our country. It has a shorter TAT, and it's, of course, a low-cost test. Whereas we also have to look at limitations of this test. And as a geneticist or a genetic counselor, I should understand there would be some things that we would not be able to pick up, especially the cryptic abnormalities, especially present in adjacent genes, the translocations between adjacent genes, the mutations. We also need experienced and competent trained staff in cytogenetics. The low proliferation of abnormal clone is something that we need to, again, check. And also low mitotic index or mitotic failure, which are the limitations of the karyotype. And I would like to, give you a take-home message that karyotype is an invaluable tool in the management of patients. And we, as genetic counselors, as geneticists, and in the field of genetic counseling, we have various tests: karyotype, FISH, the CMA, the MLPA, the NGS, whole exome, whole genome sequencing for various other human diseases. And it is so vast. So we are supposed to be understanding the limitations and the advantages of the various tests, and which test for which disorder or which technique would be best suited to detect such aberrations. So can cytogenetics survive in the modern era? Yes, it will.
Thank you very much, Dr. Shetty, for your fascinating talk.
Thank you so much.
I will now, I'm delighted to be able to introduce a recorded talk, this by Dr. Thomas Löhr. Thomas is the head of the Molecular Cytogenetic Institute of Human Genetics in Jena in Germany. So a diploma, PhD in human genetics, and wait for it, 12 books, 100 book chapters, 750 referred papers, and 900 abstracts. I don't know what I've been doing in my life, everybody, really. That's incredible. So interest in molecular cytogenetics and leukemia cytogenetics and supernumerary marker chromosomes. And career highlights include a specialist in human genetics and a denomination award by the German Society of Human Genetics, and his multiple long-standing international collaborations with many scientists across the world. Delighted to introduce his work today. Thank you very much.
Hello, and thanks for inviting me to give this talk on the topic when molecular cytogenetics cannot be replaced by and or is less costly than modern molecular genetic high-throughput tests. So why is this topic of interest, especially for me? This is because I'm dealing with molecular cytogenetics since more than 20 years, and I'm editor of Molecular Cytogenetics Journal together with Ivan Yurov, as it is shown here. Also, I'm author of several books, all involving somehow fluorescence in situ hybridization, which is the basic technique of molecular cytogenetics. And for me also, the topic of human genetics is very much correlated with molecular cytogenetics. Nonetheless, I'm often asked if we still do need chromosomes in diagnostics and research, if we need FISH, and if we not can all do better or at least the same good by array CGH and by next generation sequencing. So here shown is the traditional way how human genetic diagnostics works. You have genetic counseling as the entering point for the patients, and then you have many tools what you can do to study the DNA of the patient. So you can do clinical cytogenetics, you can do molecular cytogenetics, you can do tumor cytogenetics, and also you can do molecular genetics, which is a very big field nowadays. And many people think, okay, we can skip all the 3 points which are shown here as deleted, and we can do everything with genetic counseling and molecular genetics. Because we have the genomic era nowadays, and even maybe the epigenomic or post-genomic era, and all can be done by these two approaches, as I already mentioned. So like array CGH or by next generation sequencing, abbreviated NGS. And here is shown again the traditional way how human genetic diagnostics is and was done up to now, and is up to now requested to do in Germany and many surrounding countries in Europe also by the health insurances. So the health insurances asked first to do a genetic counseling as the entrance condition to do genetic tests in a patient. So here it is found out what the patient exactly wants to know about his or her condition. An informed consent is signed, a pedigree is constructed, and it is discussed and decided together with the patient which tests and which consequences of the tests can be and which tests now are requested by the patient. The next point is then to do clinical cytogenetics in most cases. That means we do a chromosome analysis and check for gross imbalances, and the idea is, if we concentrate from now on as a question of the genetic counseling mental retardation, to pick up the most frequent chromosomal reasons for mental retardation, and this can be done by just using clinical cytogenetics. Only after genetic counseling and clinical cytogenetics have been done, then there may be the indication also to do molecular cytogenetics. So, if indicated, we can check by this technique for unclear marker chromosomes, for example, or check for specific submicroscopic changes, which may be suggested because the medical doctor sees specific signs and symptoms of the specific patient. Yes, and only after these 3 steps have been done, then we can think about doing an array CGH or an NGS, but only as a panel diagnostics. Normally, we do not do an exome in all cases. So the idea is then here to screen for submicroscopic changes, that means mainly in array CGH, or to screen for affected genes, that would mean orientated along the symptoms which have been recognized according to the genetic counseling. Well, what is propagated by many companies and also by many scientists of the mainstream is that we can only do the 2 things. As mentioned before, we can do just genetic counseling and then immediately jump directly to NGS and then to do an exome. Because this is easy, this is cheap, this can detect everything. So this is what is now propagated on many meetings and on many papers. As you can imagine, I do not belong to this mainstream opinion people. So for me, it is clear that modern array CGH and NGS or 3rd generation sequencing cannot do all. And you need both directions. You need the traditional way of analyzing and you need the new way of analyzing. And this is just based on differences or possibilities and advantages of molecular genetics on the one side and molecular cytogenetics and cytogenetics on the other side. And I just want to concentrate on 4 points where you see some differences, possibilities and advantages of the different techniques. And I want to start with point 1, which is shown here. You have on the one hand the molecular genetics, which is able to study millions of cells at a time, while with molecular cytogenetics and cytogenetics, you are on the single cell level. So that means with molecular cytogenetics and cytogenetics, you can much better access mosaics. Just to show this in more detail, when you have molecular genetics, you start with many cells, you extract DNA of many cells, and you get one result from many cells. And when you go to molecular cytogenetics, you can analyze really each single cell from this collection of cells, which is shown on the left side. You can look into the cell, can look into 2 different cells, and you may find, okay, in one cell, you have here a karyotype with 2 X chromosomes, and here you have from this cell a karyotype with only 1 X chromosome. So that means you have a Turner mosaic, which you can easily pick up when you do the analysis on the single cell level. So, as I said already, we can detect very nicely mosaics, and this would be already example 1, which I want to show you in this connection. But the example 1 was about cytogenetics. I want to talk about the advantages of molecular cytogenetics. So, what is molecular cytogenetics? We all know it is basically today only one method, the fluorescence in situ hybridization, abbreviated FISH approach. And with this FISH approach, you can look into single cells on the metaphase level or the interphase level. So you can get information using the appropriate probes and probe sets from metaphases and from interphase cells. And you can do by that also something like a statistic or semi-statistic evaluation. The nice thing about molecular cytogenetics is that you can use many different kinds of probes, and what is shown here is one extreme example of multicolor FISH. This is a technique which is called multicolor banding, also available as M-banding from the company Metasystems, and the technique was developed in the laboratory in Jena, in Germany, where I come from. So just here as a screenshot, and to show you, we can also do not only GTG banding, a black and white banding of chromosomes, but we can also do a very nice multicolor banding. And this is also applicable not only in metaphases, but only in interphases. But this is not topic of this talk. So as an example one, I showed you an example where you can detect mosaics by cytogenetics already, but you can also do for sure the molecular cytogenetic mosaic detection much better, because here you can use also the interfaces. And one prominent example would be that you would do and apply FISH technique to detect aberrations in interfaces or bone marrow smear of leukemia patients. So here people would take a bone marrow aspiration, and you could, for example, check what is shown here in this picture for a sex mismatched bone marrow transplantation. So in the one nucleus you would see two green signals, which would be a female nucleus, and in the other one a green and a red signal, which would stand for a male nucleus. And for sure you would have to do 100 or 1000 interface nuclei to check here for the status of the sex mismatched bone marrow transplantation. And for sure you can also check for minimal residual disease by that, but it has to be added that you can do that for sure as well by real-time PCR or NGS methods. However, it turned out sometimes these approaches are much too sensible. They have a high sensibility and they detect even non-clinically relevant remains of cell clones. And so FISH technique is often preferred by the clinicians to check for this kind of mosaics. Another example, so example number 3 for the detection of mosaic karyotypes by molecular cytogenetics would be that of mosaic small supernumerary marker chromosomes. One very well-known example would be these kind of patients. If you would see a patient like that, that would suggest maybe it's a Pallister-Killian patient. And in this case, if you would study peripheral blood lymphocytes, extract DNA from them and do array CGH or NDS, in most cases you will not find any aberration. Also in cytogenetics, doing from peripheral blood, most likely you will not find any aberration. But if you do FISH technique and look in the interface again, you may find this kind of pattern that you find in a small amount of the cells when you use a centromere 12, 3 signals for the centromere 12, or if you would use a probe for the short arms of the chromosome 12, you may find 4 signals in a few rare cells. This is because this Pallister-Killian syndrome is based on what is shown here as a karyotype, partial karyotype, based on a tetrasomy of the short arm of chromosome 12. And this is induced by an inverted duplicated marker chromosome 12p. So, in this case, molecular cytogenetics can help you to find a very small mosaic concerning this marker derived from chromosome 12. So, to summarize this point, molecular cytogenetics is needed when you suggest a kind of mosaic karyotype. So that means especially in tumor diagnostics, where you can check for minimal residual disease, where you can check for sex mismatched bone marrow transplantation, or another big field where you check solid tumors in FFPE sections. This is something where you can basically preferentially only work with FISH diagnostics. Besides, we have the big field of pre- and postnatal diagnostics, where you can check for the small supernumerary marker chromosome mosaics, where you can test for sex chromosome mosaics in thousands or more interface cells in a very short time, and you can check for any mosaic of a gross chromosomal aberration also very nicely in interfaces or metaphases wherever you want using the FISH test. The second point important to consider why molecular cytogenetics is still important to be used is that you have to think about the construction of the human genome, and that means around 10% of the human genome is heterochromatic DNA, which is here highlighted in blue. And these regions cannot be detected by array-CGH and very hard only by NGS, because those techniques primarily are blind for heterochromatin. You may say heterochromatin is gene poor or doesn't contain any genes, and it's not important. I show you some examples where it is important to also consider heterochromatin. And so here for the molecular genetics side, we can say we have a whole genomic overview excluding the heterochromatic region. For the molecular cytogenetics on the other side, we have the whole genomic overview including the heterochromatin. And when we look now as a first example on this case, this would be an array-CGH result speaking directly for a trisomy 21. You would have green excess material in the array-CGH experiment for chromosome 21, and the Y chromosomes you would have trisomy 21 in a male patient. But, as I said, this is example 1. This can mean different things. It can mean you have a free trisomy 21. But it can also mean you have a translocation trisomy involving chromosome 13, or it can mean a translocation trisomy involving 2 chromosomes 21. So, it's a problem of result interpretation, which you need here to consider, because only by cytogenetics or molecular cytogenetics you can additionally get the information if this Down syndrome patient has this trisomy due to a free trisomy or a translocation trisomy. And this is very important for the counseling of the patients to know the truth. Here is example 2 for this problem of heterochromatin. Here we would have an array-CGH result showing a loss near the centromere region of chromosome 13, which is shown here beside the whole karyogram as only for the chromosome 13 the result. So this can mean just simply we have an interstitial deletion, but it can also mean we have a ring chromosome because we have no information about the heterochromatic part, and there could be just a ring formation including the telomeric region. It could also be a translocation like shown here, that a whole chromosome 20 would have been translocated with centromere inactivation and without loss of any material to chromosome 13. And we can have also a small supernumerary marker chromosome, abbreviated SSMC in mosaic, which in most cases would be lost, but in a few cells would still be there. And all these 3 different kinds of molecular cytogenetic or cytogenetic results would mean you have to counsel the patient or the parents differently. And the third point is the same what I told you for the heterochromatic parts is also true for the euchromatic parts, because with molecular genetics you can just look at the DNA from many cells at a high resolution view with no clue on the chromosomal level and how the underlying chromosomal aberration looks like, which leads to the imbalance you may find by molecular genetics. And the molecular genetics you may find point mutations, but also copy number variations for sure. Now we only concentrate on the copy number variations, and here I show you an example which was produced by array-CGH and we got in our lab as a duplication of chromosome 13 material in these green labeled parts. What does that mean on the chromosomal level? So in this example 1, I want to show you for this kind of rearrangement that the resolution at chromosomal level and the results which we can align with the chromosomal level are important, because the structure of the rearrangement leading to this imbalance is of importance. And here is what we found. We did here in this case a kind of multicolor banding, like I showed you before, this nice whole genomic overview of multicolor banding, and we did a lot of locus-specific probes. So here's just shown the chromosome 13 with the imbalances, highlighted by ARray-CGH, and the result was the following. So very, very complicated rearrangement with 5 breakpoints at least, and here you see what happened here. A little bit more easy to understand by the arrows shown here and the orientation of the different chromosomal parts, and the very complicated ISCN nomenclature of this rearrangement is also shown here. So this is a very nice example that ARray-CGH is not enough, or also when you do NGS and find this kind of copy number variation, you need also to have the chromosomal view of the result to understand what happened. Yes, and the final point is about the differences, possibilities, advantages of the two techniques, is about the money. So we all know that NGS is always announced as being very, very cheap method. And that means you have only to use the consumables and you have to purchase the machine. This is what people talk about. And this is also what people of the companies mean when they say it is a cheap method, because it is always calculated as only per consumables. Even the purchase is not included in what they will calculate to you how about the costs of a single NGS experiment. Besides, you have a yearly maintenance. Besides, you have evaluation software to buy and to also to update. You have to do a yearly quality control, and you need specialists to do that stuff, like always. And all this comes together to a considerable amount of money what you need to calculate for the costs of an NGS experiment. For molecular cytogenetics, on the other hand, it is the same kind of costs, in principle like shown for NGS, but compared to the amount of money you need for NGS, molecular cytogenetics is relatively affordable. So overall, this is an available diagnostics, and you can easily include into a stepwise diagnostics, like shown in the beginning of the presentations being used in Germany. So to summarize my talk, molecular cytogenetics can, from my point of view, not be replaced by modern molecular genetic high throughput tests, and it is always less costly than those. Also, molecular cytogenetics is one of the more and more available cytogenomic tools we have, luckily, to answer questions in routine human genetic diagnostics, but also in research. So we need really to stop thinking about concurrence of these different approaches, because they complement each other. So we really should be happy to have all these different possibilities to do cytogenomics, and not like shown here with these 4 guys fighting against each other, but like these 2 guys, they should work together and they should really use to be in a good concert, and especially to be used in a way that it is in the favor of our patients we want to care for. Thank you for your attention, and I hope I covered the field as you hoped it. Okay, thank you for listening.
So the next speaker is Dr. Jayesh Sheth. And Dr. Sheth is the founder and chairman of the Foundation for Research in Genetics and Endocrinology and Institute of Human Genetics in Ahmedabad, Gujarat, in India. She's the director of the Shah Pathology Lab and Endocrine Unit at Ahmedabad again. About his academic background, he's a PhD in biochemistry, fellow of UICC and WHO, diploma certificate in reproductive medicine and biology from the University of Geneva, and he has about 132 publications both at national and international journals, book on genetics, and several chapters in endocrinology and genetics. His interests are in lysosomal storage disorders, rare disorders, thyroid diseases, diabetes, monogenic disorders, genomics of developmental disorders, and herbal drug for degenerative and chronic diseases. His career highlights are national patent on low-cost eye cell screening, Who Was So in Medicine and Healthcare edition of 2006 by the Marquis, Future of India Business Excellence and Achievements Award in 1000 Petals CNBC and TV18. So Dr. Sheth will be talking on the selection of appropriate investigations for metabolic storage disorders in the genomic age. Dr. Sheth.
Hello. Thank you very much, first of all. Good evening to everyone. And thank to Dr. Prochi, Dr. Annie, and all other organizers for inviting me in this interesting meeting. And I've just heard Dhanlakshmi and Dr. Thomas. I really agree with very, very fascinating and this modern era of genomics, when we all talk whenever we want to understand, okay, do exomes, and then ultimately we get confused. So I am asked to talk on the selection of appropriate investigation for metabolic storage disorders in the genomic age. So I'll focusing mainly on the metabolic storage, what it is. As a counselors, as a clinicians, as a pediatricians, you may see the faces like different faces like this. So as simple as like the Down syndrome, or maybe as simple as like sickle disease, or maybe the complex like the adult is with the paraplegic child, or maybe the child with the dysmorphic features or very aggressive behavior. So it is a challenge. So it's not that every investigation require the RACGH. Like for the cases like Down syndrome, we don't need RACGH. You just simply karyotype or chromosome investigation will be enough. Or sickle cell disease again, you require simple molecular tests. Or the cases like in a paraplegia, yes, you require the maybe the NGS-based technology. But the cases like the very dysmorphic face and aggressive behavior, I will show how we misdiagnose the cases when we just, without understanding properly of the advanced genomic tests like RACGH or full exome or clinical exome, we delay the diagnosis. Not only that, we miss the diagnosis also. So what metabolic storage disorders, there are challenges to the counselors. The main reason are the overlapping phenotypes, the presence of the variant of unknown significance, absence of mutations. Many of the time we see it in 2 to 3% cases in clinically and biochemically confirmed diagnosed case. There is a selection of appropriate screening test, and its interpretation is very important, therefore. And choosing the right test as a gold standard, that is very important. You don't require the gun when we can just do with the small needles. So what the storage disorders, I'll just brief about it. It is as we know that we have trillions of cells in the body, and the lysosomes, they work excellently to keep not a healthy, but cells healthy. So whatever the cellular debris, protein, carbohydrate, undigested cell debris, nucleic acid, they all get removed by the lysosomal enzymes. So the lysosome, they function in presence of these enzymes. There are around 70 different lysosomal storage disorders. And what happens in normal case, you see the healthy cell, but when this enzyme deficiency is there, the lysosomes are not able to make the phagocytosis or autophagy mechanism. So as a result, there is an accumulation of all the substrate like the fat, proteins, carbohydrate, all kind of debris. So these are cells, the swells. And depending on where the location is, it may be in the liver and spleen, you see the huge liver, huge spleen. In the bone, you see the early osteoporosis, or maybe in the kidney, the early kidney renal failure, and maybe with the neuroregression, with the failure of the lung keel, cardiomyopathy, or maybe myopathy, or in the skin also angiokeratoma or melanosis, or the dysmorphic face like this. So what exactly is a challenge? So is it that, yes, we just go over the exam study and we get the answer, but I will show you the examples, how we miss it. So until before 2 decades, I think in India, we were thinking that storage disorders or lysosomal diseases are very rare in the country. So in 2004, I think when we published first paper in Indian pediatrics, we saw that no, they are not rare. Almost about 30 to 40% children in a high index group, with the children with dysmorphic features, skeletal dysplasia, neuroregression, cherry spot. They have underlying cause of storage disorders. And then subsequently in 2013, again, we published the paper in JIMD, and we showed that around 38% of the children with the high index cases, they have a storage disorders. So that's quite high. And about most common is the lipid storage, followed by the MPS. That is the most common one. Now, so now I start here. What to do when you often see the children with dysmorphism in a clinical practice as a counselor, and the development delay. We know that when the dysmorphism is there, obviously we just go with the karyotype, and only development delay is there. We may confuse what to do in investigation, maybe array or exome study. Here is a child in a very clear-cut case. You can see that the child has the dysmorphic features. He has got a neuroregression, with the failure of the regression in the learn scale. Found hydrocephalus. He has a multiple joint swelling. He has impaired hearing, excess hair on the all over the body. But when you do whole exome study, obviously the doctor has asked for a whole exome study to identify the diagnosis. There was no pathogenic or ABVS even identified. And the child, when it come to us, we thought that maybe the maybe have the mucopolysaccharide. The child didn't have a corneal clouding. So first thing we did the urinary gag. It's a very simple study, very simple biochemical test, just like in a chromosome knee-jerk investigation. So gag was mild moderate elevation, it's 12.9 milligram. So obviously we need to confirm what kind of the gag. There are different kind of the glycosaminoglycans. Either say the chondroitin sulfate, lametin sulfate, and heparin sulfate. They are the main component of that. So particularly we found a very high amount of the lametin sulfate excess. So usually we find this kind, it gives a definite diagnosis that it is definitely we are dealing with mucopolysaccharide. No other conditions can give you the excess of the DS or the lametin sulfate. So that's one, we get the clue. And then there is no corneal clouding, so we apply a clinical clue. No corneal clouding. So that means a neuroregression is MPS 2 is there. We did the MPS 2 enzymes at alpha hydrosulfate in the plasma. It is less than 10%, 6.3 nanomoles. So that confirmed the diagnosis of the MPS 2 Hunter's disease. And again we wanted to search then why no mutation. So we did the MLPA, but could not have no deletion duplications in the gene. So this is a very classical example. When you use the modern technique straight away, you miss the diagnosis. And not only that, I think I have been asked several times for the phenotype for this patient, because this was a part of our national task force by the ICMR. So we contributed the case. And child is receiving the ERT and is doing improvement. Even 6-minute walk test is good. So this is one of the example. So what the message from this is? The negative report of exome study or MLPA need to be taken with caution when clinical suspicion index is high. Again, here the case. This child can be referred to us from southern region, from Chennai. See, he is born to the consanguineous parents, and this is a twin. The sister had the similar features like the male, and sister has died. There are one normal SIB is there. The child has got, he can see the very aggressive facial features with the bushy eyebrows. He has got a skeletal dysplasia also there. So he also had hearing loss. So what to do? So obviously, I think MRI was done. That has shown that J-sepsala and prominent clavus. No clue to that. Vera again confirmed that the severe hearing loss bilateral. Abdominal sonography was done that suggested that he has a hepatosplenomegaly. Echo is normal in this case, surprisingly. And obviously, when we see the dysmorphism, I think is a dictum. We do the karyotype study, and karyotype is normal. So obviously, we do the error, but we do the array CGH, and look here the array. When we do the array CGH, in the brother, we found he has got a 10q duplicate deletion and the duplication of 20q. Obviously, we know that array CGH results need to be confirmed in the parental confirmation. Because you may find the benign or they doesn't give any diagnostic clue. So when we did these studies again to confirm this deletion duplication inheritance, we found the father has a deletion of the 10q, he is not having a duplication. Mother is having the deletion and duplication both. Twin sister who died also had a deletion duplication. The younger brother who is normal has got a duplication of 22q. So what does it mean? That this deletion duplication array CGH, it doesn't give any clue. But obviously we found the copy neutral loss of homozygosity in several chromosomes. There was almost 7% of the genome. There is a copy neutral loss was there. And then it was a SNP array. So we thought there's something we are missing. So when we did the SNP array, we thought maybe some MPS is because of the very core special features. It could be MPS. And when we look at this MPS gene from array readers, that has showed that the NAGLU gene and GUSB gene, they were homozygous in the case. But parents were not homozygous, nor in normal sibling. So again, we did the GAG study, urinary glycoaminoglycans, which was very high. And we did the electrophoresis. See, quantitative GAG doesn't give any, just give a clue that because you do get false positive also in some cases, or false negative also. So we did the electrophoresis of the urinary GAG study, found the excess of HS. So again, when you do find the excess of heparin sulfate in electrophoresis, there are no other conditions except Sanfilippo. It comes from the diagnosis, it is Sanfilippo. Now, what type it is, we do not know. Maybe because there are 4 types: Sanfilippo type A, type B, type C, or type D. So, based on that, we have to do the enzyme studies. When we did the enzyme studies, we found that the master who is affected, he has got undetectable level of the beta D glucosaminidase in leukocytes. The mother, father, they have a low level, almost 50%. Obviously, enzyme study cannot detect the carrier status, but we found that the level were nearly 50%. Brother who is normal, he is normal level of the enzymes. So finally, the diagnosis is Sanfilippo type 3B. So what the message is, that the genetic test may not be able to give an answer in all cases. They are critical to understand and set limitations with patients to avoid the false hope. Do not jump for a genomic test, but rather spend time with clinical details and use an appropriate screening test before you do the investigations. And array readers can be false positive or benign deletion duplications. That's why you always need to be validated by parental study of qPCR, which is very important to all the genetic counselors and all the geneticians I would like to convey here. Here again, a child is born, both the parents are a cardiologist. They have 2 miscarriages were there. The third child got IGR, birth weight was 1.8 kg. When child was normal, his intellectual seems to be normal. He had a noisy breathing. After some time, skeletal abnormality was there. He had got the lump was there. And so could be, I think, looking at the facial features, it could be MPS, could be ICL, could be GM1 gangliosidosis. So based on the clinical diagnosis, the MRI was carried out, and he had a gibbous deformity at dorsum and the D2 and L1 and L2 position, which is very evident here. X-ray also, we can see in the hands also that the bilateral short distal ulna, narrow to the second metacarpals, and triangular shape of skull, that is also very visible here. So obviously looks like a MPS. So we did the spot test, and the spot test was positive. GAG was mild elevated, not very high, mild elevated. So it gives a false hope. But when we did the study, again, in electrophoresis, given some keratin sulfate and converters, there were no DS or KS. So that rules out there is no MPS, but maybe some molecule may be there. So, but child doesn't look like molecule. There is no skeletal dysplasia there, no skeletal dysplasia. There's a multiplex is there. So what it could be? So we did the enzyme studies, and we did the beta-gal sulfate, which was low, but it is nearly 35%. For enzyme studies, has to be 10% of the mean value. Then only is how to consider as a diagnostic. We did the beta-galactosidase, which is also nearly 50% of the mean value. So obviously there is no diagnosis. I think what exactly it is now. So we have done the ICEL screen. This is the test. Is 100% sensitive. Is a few hundred rupees only. You will be surprised to know it's a 500 rupees cost, and is 100% diagnostic. We have not found any false positive, false negative. Recently, I think we sent the publication of the human mutation, 22 cases of mucolipidosis with Dr. Aswin Dalal collaboration. None of the case we could not identify the mutation. Every case we identify the mutation. So this is very confirmatory, and we say that from based on this, which the child has an ICEL. And then we did the plasma enzyme. You look at the enzyme, beta-glucuronidase is almost 100 times high. The hexasaminidase, aride sulfate, all enzymes are several fold elevation. So the multiple enzymes are elevated. So that again confirm this child has got the ICL disease. So your simple screening test can give us a clue, and then you do the confirmatory by enzymes, and then further you can go for the molecular investigations. Here again a similar case like 11-month-old male. He has got a mild dysmorphic features, but you can see this. It's very extensive melanosis is there on the skin. So that, and he had got a sonography was suggestive of hepatomegaly. Again, in this case, the MPS screen was a very mild spot is there, but GAG was nearly normal, not very mild elevated. And when we did the electrophoresis, it is normal because this is condotten sulfate and a carotenoid sulfate, condotten sulfate and heparin is not access. So it's not MPS. So what it is then? Is ICL is negative. So we did the leukocyte enzyme, beta-galactosidase is very low. So that gives a confirmatory diagnosis. This child has got a GM1 gangliosidosis. So what the message is? Evaluate screening test carefully, as especially urinary GAG study. You may get false positive in conditions other than MPS, like in ICL disease or maybe in GM1 gangliosidosis, because in both the cases, in one case in ICL, there are several enzymes are deficient. In the particularly in the GM1, the same enzyme is responsible for the two different diseases. In MORQ also is because of the MORQ B, it also occurs because of the same enzyme deficiency. And ICL screening is 100% sensitive and specific for the mucolipidosis. Just like I think this is not a forum to discuss about the alkaptonuria or the PKU, but there are several cases, like I think one case we've seen with alkaptonuria. I think we did so much number of studies has been carried out, whole exome and everything. And I say we can do these studies in just in the 200 rupees by the alkaptonuria, simple do the alkaptonuria in the lab, and it is it's definitely a confirmatory diagnosis. Yes, we require the molecular studies or maybe the GCMS studies to make the confirmation, but primarily we can do by this simple screening test. Same way, like posterior with skeletal dysplasia, multiple dysostosis multiplex, I will show that. Here is a child, we can see that he has got a multiple skeletal deformities, is a skeletal dysplasia. So obviously this child was ordered for the whole exome studies, that because it is a skeletal dysplasia, that what exactly could not fit in any diagnosis. And surprisingly, the child exome study was found to be normal. I don't know why it is, but when they refer to as the child, he has a restricted movement of the shoulders, elbow, wrist, and the knees, delayed walking. In X-ray investigations, we can see that in X-ray, the anterior inferior breaking of the lower thoracic vertebra is there. Bullets of metacarpus, and when we did the again GAG study, urinary GAG was was elevated, and we did the electrophoresis here. The carotenoid sulfate was very marked, and that correlate with the clinical correlation, the skeletal dysplasia. So when the carotenoid sulfate is excess, you only find in cases with the MORQ. You do not find MPS 4A or 4B. No other conditions can elevate except for GM1. We found that one case, we found the KS elevated. So here again, when we did the enzyme study, beta-gal sulfate sulfatase, the child has got a MORQ syndrome type A is confirmative. And then when we did the molecular study also, what we find that MORQ disease in Gujarat, we found in a high number, maybe because there is a founder mutations in the Patel community. So as a counselor also, when we do the counsel, you should know that caste of the patient also. Why? Because what does the literature some suggest that the founder mutation is certain community. So in Patel community in Gujarat, P77R is the most common mutation seen in 55%. Same way, the L36R also is 80%. We can see that around nearly 80% cases, the two mutations, you can identify the molecular confirmation. So we should have this knowledge. So as I think Dr. Dhanlakshmi was showing that, we have to also think about the patient's pocket also. Because in India, there no insurance coverage is there. So when we ask for the investigation, be very judicious. Do not just jump on the whole exome. Yes, they are helpful, but do not jump. We can also help by the simple simple screening test, even for molecular also. Now, when you do the P7/7R, it just costs, I think, 3,000, 4,000 rupees. No need to do NGS for that. Again, when we see the patient with hepatosplenomegaly, see the child with the large spleen coarse fistures, the hepatosplenomegaly, very scaly spleen and non-neuronopathic form was there. Bone marrow was done. It was a severe erythroid hyperplasia. Thrombocytopenia was there. And we did the chitotriosidase as a screening marker. It was 1,000 folds high, 38,000, the normal range is 28 to 62 nanomole, and beta glucosidase was low, 4.3. So that gives the confirmation that the child has a Gaucher disease. And it's a type 1 because there is no neuronal involvement is there, so it's type 1. Did the molecular study, we identify in the GBA gene, is a R359Q, which is a homozygous mutation, with this is a known pathogenic mutation in the child. And you know that the Gaucher disease is the most common across the globe. In India also, it is the most common metabolic storage disorder, which is a treatable. This child, luckily, he has been receiving the therapy. He is on ERT, and we can see he looks absolutely normal. So we have 3 children at the moment who are receiving the free therapy in our center for Gaucher disease. Here again a case with a 20-year male, normal up to 15 years, and after that he suddenly difficulty in walking. He has hemoglobin is low, his platelets is very mild thrombocytopenia, and because of the frequent fall, the X-ray was done. They were suggestive of the avascular necrosis of left head of femur. Sonography was done. It's a moderate hepatomegaly and marked splenomegaly. Bone marrow, no doubt bone marrow is now outdated. No, it's not suggested to make the diagnosis for Gaucher or Niemann-Pick disease. But this was done in that, this is the old case that showed the Gaucher cells are there. So we did the investigation again. The chitotriosidase is a very simple test investigation, which was 54,000. So that confirmed that child definitely has this patient. This person has definitely a Gaucher disease, and the beta glucosidase from leukocytes is very low, less than 10%, at 2.5. So that again, and we did the mutation study again. He found the well as the L-tryptophy and well as the R329C. So that again confirmed the diagnosis of the adult onset Gaucher disease. This is very rare, but the idea when you, as a genetic counselor, when you make the counseling, you have to have the proper knowledge of the clinical insights of the patients and the progress of the disease along with the pedigree.
And we have 5 more minutes.
Okay, 5 minutes. Ne? Okay, I think I'm about to finish it then. So now we look at the chitotriosidase. So this now, as like the gag we do for MPS, see for chitotriosidase for lipid storage disorders, we use the chitotriosidase as first line screening test from plasma. If it is very high, like 8,000, 10,000, 20,000, you are sure it is a Gaucher disease, and do the enzymes and then do the molecular. Even in Niemann-Pick disease also you find the elevated, but not like the Gaucher disease. They have a very high level, but nearly 5 to 6,000. There are other storage disorders like Krabbe, GM1 also. You do find the chitotriosidase elevation, but they are not that significant elevated, and you cannot have the confirmatory diagnosis based on that. And again, a molecular marker here. So we have recently published the large data as a part of our multicentric study of ICMR task force, and 100 patients, and published in BMC Medical Genetics. We found that L-tryptophy is the most common mutation in India. Around 60% to 65% of the cases with Gaucher disease, whether type 1, type 2, type 3, you do the L-tryptophy. So whenever you see the patients with Gaucher disease, and if you want to do a molecular confirmation, go for L-tryptophy first. Don't just go on the jump for the diagnosis or the order for the clinical exam. Because this is very simple, it's just a few thousand rupees and you get the diagnosis in 30, 40. And second point is, there are a hotspot region also for most of the gene. For Gaucher disease, the hotspot region is exon 8, exon 9, exon 10 at the hotspot region. So I think around 80% of the molecular the mutation you identify in these two exons. So if you fail to diagnose by LT-property, you go with the exon 8 and exon 10. Mostly, I think 80% cases you are going to get the diagnosis. So that is how we can use the molecular screening test also. If we have no facility for the biochemical screening test in the center. This is again this case again referred to us from Dr. Sila from Amrita Institute and child with hyperactivities and neuroregression. So when you see the child with hyperactivities and neuroregression epilepsy, I think as a pediatric neurologist comes to your mind that is definitely a Tay-Sachs. So we did the enzyme study was normal. Then there is no other clues there. What to do? MRI suggested there would definitely the demyelination is done in MRI. So with it and possibly activate a protein deficiency there. So we did the mutation study GM2A gene. We identified there's a intronic mutations and one is exonic mutations also. So there are two such cases there we have. I think there are hardly 20 cases reported in the literature with activator protein. So here in such cases, if you do the exome study, it's going to be helpful. If you do the enzyme study, you are going to mislead. But in such case, if you do the exome study, you will be able to catch up such cases in the early stage. And we also again in the test set data found the mutations. This is only published in PLOS, and there are around 40% cases. This is again in Gujarat. But Parmar community in Gujarat, they have E462V and D222Y. These two are the most common mutations in Gujarat, in Parmar community. So if you screen these children, when you want to do molecular study, I think you will get the answers. And otherwise, there are no hotspot region in the for Hexate gene. So we cannot say, but if there are found the mutations is there. So screen them for them and you will be able to identify the mutation. So what the message is, children with phenotypic presentation as GM2 gangliosidosis, or the Tay-Sachs was sent off and normal enzyme activity of in leukocytes, you need to be investigated for the activator protein deficiency. So yes, even for Gaucher also. So at the last, I would like to acknowledge the research grant from ICMR, from DBT, our PhD students, our staff, several collaborators across the countries and abroad also. So I'm very much thankful to them. I'm very much thankful to our staff, and this is our institute where we carry out the investigations. I think many of you, Thomas also has been he has been with us, and I would like to give one message: passion for science, commit for a better world. We should not use this. No one should approach the temple of science with the soul of money change. I think whenever counsel the patient, do any investigation, please keep this in mind. Do not use the science as a money changer. And I remember the Dr. Kalam's words. And Thomas, you do remember you had a good interaction with Dr. Kalam at that time in 2014. And at the last, I would like to thank with a beautiful picture of the chromosome. So chromosomes are the knee-jerk investigation till date also in this era of the molecular genetics. Courtesy to Dr. Franishet, who may design these chromosomes. Thank you very much for giving me this opportunity. Thank you so much.
Thank you very much, Dr. Sheff, and thank you so much for those excellent cases and examples. So it's a great pleasure now to introduce Dr. John Belmont, who's a medical geneticist and pediatrician with 38 years of experience in human genetics. He's a professor at Baylor College in Texas, United States, and has a PhD and an MD from Baylor College, with residency at Children's Hospital National Medicine Center and a clinical fellowship there as well. He has interests in population genetics, the genetics human immune response, and structural congenital heart defects and functional studies of SIC3. Now, he's recently retired as Senior Principal Medical Scientist at Illumina and is involved in genetic counseling and on the board of directors of the National Society of Genetic Counselors. So very much looking forward to your talk. I'll hand over to John. Thank you.
Yes, thank you very much for the invitation to talk to this conference, and thank you to all of the attendees. Yeah, so I am speaking from Texas and from Houston, Texas, and you can see it's a city of trees. Okay, so the problem I want to talk about is the diagnosis of rare disorders and the use of whole genome sequencing in clinical application to that problem. And of course, I agree with the previous speakers that when you are certain about a genetic diagnosis or have a very strong suspicion, then targeted testing is still the most prudent course for diagnosis. However, there's large numbers of patients with rare and ultra rare diseases that continue to be really an enormous public health problem. And the ability to quickly arrive at a genetic diagnosis when it's present is expected to be very helpful. So if we consider the scope of the problem, it's estimated that 3 to 6% of the entire population is affected by a rare disease, and that up to 80% or so of those rare diseases have significant genetic forms. So not all of them are genetic, but there are genetic diagnoses that can be made for a very large number of them. The clinical challenge, of course, is that there's a huge number of already described genetic diseases, more than 6,000, where we have a gene association. So that makes it extremely difficult for even the most experienced physicians to recognize those. Some particular clinical populations include newborn intensive care units, where it's very difficult to carry out a comprehensive physical examination. And depending on the referral pattern, between 10 and 30% of the newborn infants in those intensive care units, where there's very costly care going on, have genetic diseases. And overall, in pediatric hospitals in the US, we estimate up to 14% of all hospital admissions involve a genetic disorder. So we've been talking about recently something called the diagnostic odyssey of what happens to these patients when they don't get diagnoses. And the pattern is quite concerning in that they may see up to 8, or on average 8 physicians, very lengthy delays in evaluation that go on for years and years, tens of thousands of dollars in costs of diagnostic testing, and on the way 2 to 3 misdiagnoses. So just to emphasize, even the most experienced clinical specialists can't reliably recognize all of the known rare and ultra rare diseases. So what can we do about this type of problem? Well, next generation sequencing is having a huge impact on this kind of problem. And so we don't necessarily advocate for a complete displacement of the classical genetic testing, but we see that there's now accumulating evidence for a huge impact of NGS and comprehensive genomic scale in NGS in the diagnosis of these conditions. So I want to contrast whole exome sequencing from whole genome sequencing, and then spend the rest of the talk focused on whole genome sequencing. So in whole exome sequencing and in NGS panels, where one targets a fewer number of genes, the DNA is fragmented, and then some kind of capture or amplification procedure is used to create a library that then goes on to the sequencer. In contrast, in whole genome sequencing, all of those parts of the test are skipped, and the fragmented DNA goes into a library that is made without any amplification and then sequenced. So this gives, in principle, an unbiased sampling of the genetic material in the germline genome. And what this does is enable a series of analyses of these unbiased sequences to allow a much more comprehensive analysis of the types of abnormalities that might be encountered and explain disease. So of course, the whole genome sequence data can be used to analyze small single nucleotide variants and small indels, but it can also be used to analyze copy number variants And I'll show an example of that. It can be used to identify structural variants, abnormalities in the sequence of the mitochondria. It can resolve paralogous sequences, some that are very common and involved in causing important diseases, and also repeat expansions, which are very important in progressive neurological disorders. So first, an example of detection of a copy number variant, and what you can see in this pseudokaryotype here is each chromosome displayed, and then this position on chromosome 6, where there's an easily seen displacement of the number of reads over the copy number variant that really anyone can see. Now, of course, this is a very large aberration meant to illustrate it, but the laboratory can use specialized software to detect aberrations that are down to 10 kilobases, and it's routine actually to detect much smaller ones, which are then subjected to confirmation. I did want to mention that there is an ability to detect mosaicism as well. And here's an example of an entire mosaic trisomy 12 where the sensitivity is down to 6% detected in this copy number depth analysis, so that larger abnormalities that are mosaic can be detected. It had been thought for the last decade or so that it was impossible to use whole genome sequencing or NGS to analyze for repeat expansion disorders, which are exemplified by FMR1 in Fragile X syndrome, but also a number of other neurological and neurodegenerative disorders like Friedreich's ataxia. But again, having knowledge of the existence of these disorders allows targeted software to be developed that is very accurate in determining that there is abnormalities in the repeats, and these disorders can now be screened in whole genome sequencing. And then also, when one is doing the sequencing, the mitochondrial genome co-purifies with the germline DNA, and on average, there can be 2,000 to 7,000 copies of mitochondrial DNA per copy of the germline DNA, so that the mitochondrial genome can be analyzed in detail. And I just wanted to mention this one clinical paper that analyzed 40 patients with mitochondrial disorders that were identified by using the modified Walker criteria. So these are experts have identified these patients as having a mitochondrial condition. And of course, whole genome sequencing was very effective in identifying the known autosomal and the mitochondrial genome abnormalities in these patients. But there were 7 cases that involved clear pathogenic abnormalities in disease genes where there was no previous evidence that they could cause a primary mitochondrial disorder. So even the most expert physician would not be able to make these diagnoses because the disease association simply hadn't yet been described. So smaller structural variations, so less than 1,000 base pairs, deletions and duplications, some insertions and inversions can be detected using NGS. This is getting better and better, but still remains a technical challenge. But there is a nascent capability to detect structural variants as well. I wanted to highlight one case example. A child who was seen in Tijuana, Mexico by a clinical team that involved physicians from Mexico and also from San Diego, California. And this is a child with epilepsy. She was 13 years old. She had very complex behavioral issues, autism and self-injurious behaviors. She also had delayed puberty and lack of development of secondary sex characteristics, and also had dysmorphic facial features and other dysmorphisms. Whole genome sequencing was carried out and found 5 different molecular abnormalities. And these very skilled dysmorphologists who evaluated her expressed to us when we gave them this result that had they detected even one of these, they would have stopped the evaluation. So this gives an example of a case in which the a very complicated set of abnormalities is taking place in the patient that could only be found by using a comprehensive test. Let me just say what some of those abnormalities were in this child. So one was a de novo stop gain in SCN2A, which is probably the cause of the epilepsy and developmental delay. But in addition, she had a de novo 358 kb deletion that involved 18 genes, including one that is a cancer predisposition gene, STK11. And when the physicians went back and examined her, she had the characteristic lip pigmentation abnormality of Poitz-Jaeger syndrome that goes with this disorder. She also had, this deletion involved KISS1R, and then on the other allele of the of KISSR, there was another point mutation explaining the developmental delay. She also had uniparental disomy on the short arm of chromosome 11, which is the clinical significance is not so clear. So genome sequencing is quite an excellent test for covering this huge range of possible abnormalities and sort of relieves the physician of making a guess about some very complicated or ultra rare disorder that they may not have previously encountered, or in patients like I just mentioned, where there's multiple different diagnoses going on. But we're asking ourselves the question, can we demonstrate real clinical utility from this kind of testing? And clinical utility involves a complicated set of considerations, not just the clinical utility of finding effective treatments, but also the personal utilities for parents and the possibility of testing other family members, economic utilities of possibly having cost savings in care situations like intensive care units where the cost of care is very, very large. And then utilities for health systems where there can be appropriate planning around the actual burden of disease in the population for which they're responsible. So I want to just outline a few recent publications that address these questions of clinical utility. The first is a randomized controlled trial that was published a couple of years ago that involved 65 patients. 32 received whole genome sequencing and 33 with standard genetic testing. And then the primary endpoint was the diagnostic yield at about 1 month after evaluation. So the diagnostic yield of whole genome sequencing was 31% compared to only 3% for the standard genetic testing pathway. And in fact, the clinical trial was stopped early because there was a very large difference, and the endpoint had been achieved. The median time to diagnosis was also very much shortened from 107 days to 13 days. This led in California to a publicly funded project that they colorfully named Project Baby Bear, and it involved 5 pediatric hospitals. One was the Specialist Center, Rady Children's Hospital in San Diego, and then less specialized hospitals where they may not have had ready access to a clinical geneticist. And they recruited 154 newborns into the study and then asked the question, could whole genome sequencing be shown to alter the care of the babies in the NICU? And they achieved a 43% diagnostic yield, and 68% of the children with a diagnosis had a change in management or a change in care pathway. So this demonstrated importantly that even the non-specialized hospitals were able to efficiently identify the patients who could benefit from this kind of testing. If we look at a number of other publications in this space of critically ill infants, there's a pattern across all studies of enhanced diagnostic yields from using whole genome sequencing compared to the typical care pathway when it's been compared, and also a change in management in 32 to 72% of the diagnosed patients. How about in pediatric outpatients? So again, there's a number of early publications about this. This is a publication from Toronto, Canada at Hospital for Sick Children, where 103 patients were chosen for whole genome sequencing. Many of these patients had previous extensive workups. And so that allowed them to have a subset of 70 patients who had had both whole genome sequencing and whole exome sequencing, where it was found that the diagnostic yield in whole genome sequencing was 50% compared to only 37% for the whole exome sequencing. And those additional diagnoses came from exactly the kinds of things that I showed you earlier. They are mitochondrial disorders and certain kinds of small copy number variants that weren't detected by the exome sequencing. This is a publication that we were very proud of at Illumina. It describes 60 patients in that Hospital Infantil de las Californias in Tijuana, Mexico. So these are patients who otherwise had no access to any genetic testing and often including karyotype. There were 60 patients and the diagnostic yield was 68%. So nearly 70% of these patients got a diagnosis, and they involved all kinds of genetic abnormalities, including chromosomal abnormalities, large CNVs, and many rare and ultra rare disorders. So even in a resource poor environment, using whole genome sequencing was very effective and led to a change in management of nearly 50% of these children. So if we look at some publications, additional publications in this space, again, how many minutes? Okay, so high diagnostic yields for whole genome sequencing in the range of 50 to 75%. Whole genome sequencing is being implemented in European countries. This is a map of some of the activities of implementation in these different companies, most recently the France Genomique, where there are 48 indications that are being allowed. So to summarize, we believe that whole genome sequencing is going to be a foundational technology, a platform for not only rare disorders, but also for all of these other kinds of clinical uses in both adults and children. And thank you very much for your attention.
I thank all the speakers for their insightful and interesting talks on genetic testing, ranging from gold standard techniques like karyotyping, biochemical testing, to current genomic testing, as well as also for ensuring the necessity of complementing each other for better patient care and treatment with respect to the clinical scenario, ranging from classical syndromes to unknown rare diseases. Thank you once again to all the speakers. Now I am very pleased to invite our faculty, Dr. John Belmont, Dr. Thomas, Dr. Jayesh, and Dr. Dhanlakshmi, and chairs Professor Julian and Dr. Kumar Manikwel for panel discussion and to address the questions proposed in the chat box. Thank you.
Thank you so much. And I'd like to, apart from the invitation, I'd like to congratulate the organisers for bringing together such a distinguished group of speakers who have brought together the topic beautifully, and absolutely tour de force in the field. So thank you so much for that. For me, this brings up two issues that we start with in medicine when we're learning. The first one being, don't go looking for two diagnoses if only one will do. And the second point being, it's all about the history, the examination, the family history, and then the basic chemical tests, and genetics comes in at the end. And both of these things that I was taught when my hair was black rather than grey are now being questioned by these new technologies. And so there are questions about when does this new technology take over? When does it take over from the classic teaching of history and examination and some of the classical cytogenetics? In fact, one of the questions goes on to ask about when does it take over from a CT scan and an MRI scan? So I'll start with John, because he covered some of this in his talk. When is the argument for history and examination and investigations going to be lost? And when is this going to be taken over by these new molecular techniques?
It will not be lost. We are still doctors. We still have to take care of patients, and we have to start with the patient and the family. And so I'm certainly not advocating for that. What I'm seeing, though, in my thinking has changed quite a bit as I've looked at the technological advance, and it's only going to get better, that some of the burden of guessing and our inaccurate ability to recognize these ultra rare disorders will be greatly alleviated by technical help.
Another take-home message is particularly for young genetic counselors is that when you suggest for an NGS test, you should also sort of warn them that there could be more than one diagnosis. Because if they are going to be, the parents are going to face a second diagnosis, that's going to increase their worry, their cost, and also taking care of the child. So therefore, the genetic counselors have to be very careful when you actually try to ask to do a genetic test, particularly the family. And also that you have to see the clinical utility. Okay, so that these are very important take-home points as well. Yeah. So Dr. Seth, you would like to add any other points on this issue?
I think no. I see what I felt very interesting to hear the talk of John Billman when he talk about the sick children and whole genome studies. That's really very interesting because it cuts out the days of treatment and the diagnosis. But in country like India, it is very difficult. The reason is because most of the patients, they no insurance coverage, no government coverage, no government facility. Everybody has to go to the private. So that is why I think in India, what I emphasize on the clinical acumen. You have to have a clinical accuracy, more important. I remember one of the research patients, I think, came, just called up the resident calling me from the SSG hospital, Baroda. So patient is not affording, but we are suspecting alkaptonuria, and the doctor says that you go have to, somebody has, some geneticist must have suggested to go for the exome study straight away. So we come from the diet. I say, if you are sure for the alkaptonuria, just send me the urine sample. I will do just in 200 rupees. It just, I think maybe you are not even $1, and it is confirmed alkaptonuria. So why then, if you are in country like India, I think we have to think for that, because we have to think for all. Genomic tests are very, I must say that, I must admit, very difficult cases we are able to now solve with the genomic test or NGS or whole genome or whole exome. Most of all the rare disease only we are able to diagnose by the advanced genomic test. So they have definite role. At the same time, we should not forget our old, the basic test, simple karyotyping, or simple test like biochemical test, or simple PCR with the founder mutation studies. I think then definitely we can go ahead with the advanced genomics. It is, nobody can deny the role of the advanced genomic test. It is very important. But my message is, please think before you order. Give it time, spend time with clinical details. Small clinical details will definitely help you to reach the diagnosis, and at the same time will helping the patient also as well.
Thank you. So we've talked about some of the challenges about the clinical context, but I'd like to ask Thomas a question about some of the traps that we can get caught in by embracing these new technologies and forgetting about mosaicism or structural variants. So how can a clinician who's thinking about these new technologies make sure they don't miss some of these other aspects which classic technologies would have detected? What is the secret to try and work out, well, have we considered mosaicism or a rearrangement, for instance?
I don't think we can make a general rule here. It's something which we really need to see as something special for our field. I think that people tend to think if we have something new, we should throw away the old. I'm not sure if other fields do this as we tend to do. So I think really, for me, this scheme, what I presented, like we still have in Germany, and I hope we will keep it still, is really to have something like a stepwise diagnosis by which you will just always be forced to follow this rule, first cytogenetics, then array or NGS, and by that you will not forget or miss anything. Still, you can miss something because if it's a low mosaicism, for example, you may also miss if you have only 15 metaphases. But as you said before, it's always a matter of the clinical diagnosis, of the clinical science, to think on the right thing. Yeah.
Dr. Barwell, so we have about 8 questions for the speakers. Shall we go one by one? Would you like to go ahead with the first?
Yes, we can do that. So we've got a question here about what test is offered for increased nuchal translucency in a fetus. What would the team recommend? Should we ask Dr. Shetty to start off with?
With respect to ductal translucency, the NT, if it is increased and if the sonography also suspects of any other, fetal abnormalities or fetal anomalies, maybe a simple karyotype also could give us the answer, or else CMA would be a good test with respect to structural fetal anomalies.
Okay, thank you. Would anybody else like to comment?
In the QA section of the Barwell, there are 8 questions that has been specifically addressed to the speakers. Maybe we can see them.
Yes, we've got specific questions which have been asked. There's one question that was about sequence depth. I don't know if John would like to answer that.
Can you clarify a little bit about that question? So for
yes, so on the Q&A, the question was, what was the average sequence depth that would be recommended in terms of cost versus misdiagnoses? And it just came up on the Q&A.
Right. So for whole genome sequencing, we standardize at 30x, but typically it's more like 40 to 42x is achieved. And of course, that is much lower than what one expects for exome or targeted panels. But it shows that the PCR-free library method gives such even coverage that you achieve essentially very, very low error rates by having that amount of coverage. I did want to just mention about the cost of genome sequencing, because that's obviously very expensive. And but if one has the perspective of a health system, and you're talking about the patients who don't get a diagnosis that you want to get a diagnosis, it is actually the most expensive thing to do sequential testing because so many patients are not resolved by the upstream tests. But if you're at the patient perspective or family perspective, the sequential testing, if they have one's having to bear the cost, then it certainly makes more sense to do that.
Did Thomas want to say anything further about that? Because I know he mentioned this in his talk.
Yes, but I think that was covered. So it's really a matter of costs. And yeah, I think there's nothing to add to that.
Okay. There was another question when it came to QFPCR versus FISH. So Dr. Shetty might want to comment on when did those two different approaches may be used and the pros and cons?
QF PCR again is a good technique for prenatal setup to look at the trisomies. Yes, even fish can do pickup, but here I could say, and Sir Thomas Sir could put in more insights into it. According to me, maybe QF PCR would have some advantages, but especially in prenatal, with compared to fish, I think QF PCR would give us better results.
Okay, Thomas, did you want to say anything further?
I agree. So I think for sure, if you have the possibility to combine both techniques, it's still maybe the best thing. But and another thing is also what is started now with us here for not for leukemia, but for solid tumors, that also NGS is done then there. But this is really a matter of costs and what can be done practically.
Dr. Belmont, can I ask a question which is in the Q&A? What kind of depth will you recommend for whole genome sequencing or exome sequencing?
40x for whole genome sequencing, 100x for exome.
Okay, with regards to, there's a question about trio analysis in inherited cancer, and also I suspect the question is also about somatic versus germline testing in cancer as well. I don't know if Dr. Sheff would like to comment. We've talked about trio analysis for rare disease, but in terms of inherited cancer, did you want to say anything further or about tumors themselves and the value of paired samples? Jayesh, can you hear me?
Okay, I thought it was John. I think the trio analysis, yes, particularly in the somatic or germline cancer is very important. So you do identify, you confirm the diagnosis, because many of the time you know that in the genomic era, you do find the VUS or some uncertain significance. So in those cases, if you do the trio, it cut down the cost also at the same time, and you are able to make the confirmatory diagnosis. But again, we have to think for the pocket, because when you offer the trio analysis, it also costs very high. So what we follow is the practice is first index case and then do the confirmatory diagnosis. At least that cut down the cost. So that way trio is the best one. But I think in the practice in India, we prefer, for research study, yes, it is fine. But for the diagnostic purpose, in the patient point of view, we'll always go with index case and then do the confirmatory study in the parents.
There is a concern about...
Recently, I think one example I'll give for trio analysis. The index case diagnosed, the child had the very clear-cut, the MRI was suggestive of the leukodystrophy. And the doctor also has asked for the whole exome study. They picked up the mutations related to the microcephaly. And it was not clinical correlating. Then obviously the MRI picture was suggestive of leukodystrophy. We need the leukodystrophic panel for the enzymes. It turned out to be a Krabbe disease. Now the patient mutation study was done. Mutation could not pick up for the Krabbe. There is no mutation identified. The patient is again pregnant now. The wife is pregnant. What to do? Obviously, we did the study, and then we went back, because what happened now? We simply report the VUS without referring the literature, referring the database. So then, when looked at the VUS which is reported for the microcephaly, that was not a VUS. In fact, in the varium data anomaly and the database, we saw that it is likely benign. So because what happened in the pregnancy when we did the study for the enzyme study for Krabbe, we did the mutation study, what was identified in the index case and the parent. Then again, the amniotic fluid showed the homozygous status. Though it was negative, unaffected child for the Krabbe, what to do? So then when look back everything, we say, no, we are sure that no, this is a benign condition. And unfortunately, both parents had the heterozygous and we found the homozygous. But this is a very critical situation. So in such cases, yes, pure analysis does help. But again, I think sometimes it makes the complication. I would like to Dr. John to make any comment on the John. You have any comment on this? It's very interesting. Recently, I think just this week only we make the diagnosis, and he belonged to the doctor family from Rajasthan.
No, it's a fascinating situation, and of course, our testing cannot resolve everything yet. We still have many unknown cases, but it does give me an opportunity to mention that Illumina now, I'm not speaking for myself anymore, that has an international program called iHope, and there are sites now in more than 30 locations around the world for referral of rare and undiagnosed patients who that have stumped doctors, and this is done at no cost. So if you would like to get more information about the iHope program, it's a philanthropic program from Illumina that I'm sure I can make the connection for you.
Thank you.
Dr. Belmont, question for you. So you get a couple with bad obstetric history, repeated abortions, and then you do a whole exome, then you do a microarray, do mitochondrial mitome screening, and everything is negative, then how do you handle that family? Not that question, I'm addressing it to you. Can you hear me?
Sorry, who are you asking, Dr. Kumar?
Dr. Belmont, you're on mute. Let me repeat the question in case it didn't go through well. So you get a family with bad obstetric history, repeated abortions. Then you do exome sequencing, negative. Then you try to do a microarray, and again, that's negative. And then you do a mitochondrial genome screening, and again, that's negative. How do you handle such kind of families?
And have you already done a karyotype as well?
Yes.
This is
everything is negative.
This is the classic thing that one should think to do. Yeah. I don't want Thomas to be mad at me for not suggesting that. So so I think this raises a big question of, even when we were doing whole genome sequencing and including long read sequencing, which I didn't even mention, which possibly can even do better, or closing the diagnostic gap, we're still left with very large numbers of patients where we are certain that they have a monogenic disorder, but we can't find the abnormality. And we don't exactly know why that is. And there are many explanations. We don't have time right now to go through all of the different possible explanations, but this is the research challenge for the next decade.
Thank you very much. I'd like to leave the last word to Dr. Shetty. There was a question about high resolution karyotyping and when that would be indicated. And I'll take the opportunity to thank all the speakers for bringing together a fantastic afternoon session. So Dr. Shetty, over to you.
Right. High resolution banding actually is done in most of the laboratories, who do karyotyping. It is just a technical addition of ethidium bromide. Now this, when you do this high resolution banding, your chromosomal resolution is about 550 bands. Okay. Usually we have 400 to 550 bands without, doing any modifications. However, if you need a higher resolution, that means more number of bands, so that we can detect some smaller rearrangements or smaller deletions or duplications, we may be able to probably detect such aberrations in a high resolution karyotyping. And that's the reason we do HRB. And of course, because of newer technologies like CMA, nowadays people do not ask for such HRBs. Yes.
Okay, so thank you, everybody. It was a great evening, and we had such a wonderful panel of speakers as well as the questions. And I'd like to thank my co-chair, Dr. Bhagat, as well as the organizers for giving the opportunity. And I ask Dr. Darwin to close the session. A few words. Thank you.
Well, it's a huge honor to be involved today. There are challenges on how many diagnoses an individual may have and how best to make that diagnosis, and more importantly, what that means for the patient and for the downstream costs for healthcare and for the family. So this is the beginning of the conversation. I think we've covered huge amounts of depth. Many of the questions which came up were in the talks as well. Thank you for all the questions. They were extremely helpful in framing the debate. And to the organizers, I wish you a safe time, these difficult moments in our history. And we will come through it, I'm sure, stronger, but with more questions, I'm sure. So thank you very much for this evening.
Thank you all. Thank you.
Thank you, everybody. That was indeed a very enlightening discussion brought forth by our esteemed panelists and chairpersons. Thank you very much. With this, we come to the conclusion of the session of talk on choosing the right tests. We request everyone to please attend the series of talks by our eminent faculty lined up for the next 2 days of the e-conference. We definitely look forward to your participation and valuable feedback. Please feel free to post your queries to our BGCI Conference mail ID. Thank you again, all panelists, chairpersons, and participants for taking out time from your busy schedules to make this happen. Goodbye and wishing everyone well and stay safe. Thank you.